এই যে নিয়েছে চেক হ্যালো হ্যালো চেক চেক টেস্ট হ্যালো হ্যালো চেক আছে চেক টেস্ট হ্যালো হ্যালো চেক চেক টেস্ট হ্যালো হ্যালো বাড়াবো নি এখান থেকে চেক এত পরে check. Hello, hello.
या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या कुन्देन्दु तुषारहारधवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या
হ্যালো সমীর বাবু, এই যে ফারাক্কাটা এসেছিল।
Hello, sound check. Hello.
চলবে এই কি জ্বলছে দেখছেন এই যে হালকা
চেক হ্যালো
Good morning, everybody. So I will request our learned gathering, those who are standing on the rear side, please take your seat. We are going to start our program. This is the second day's update midterm of 2022. So please sit here. Dr. Ananda Bagchi and all others, please have your seat. Because of our late, you have got plenty of time to chat within yourselves. Now, good morning, everybody. We are officially starting our second day program of our midterm update 2022. So we are having a very exciting first session, that is farewell programs to tuberculosis, hepatitis, and Kala-Azar. So the second speaker, Dr. Vivek Kumar, for some emergency personal problem, he couldn't turn up. So ultimately, we have two sessions. One is farewell programs to tuberculosis and farewell programs to Kala-Azar. And this important session will be chaired by our most revered senior physician, Dr. Ajay Chakraborty, who is now officer on special duty, Uttar Kanna. Dr. Pallab Bhattacharya, he is working as additional director in our Sastha Bhavan and taking care of all these farewell programs, that is hepatitis, tuberculosis, and Kala-Azar. Under his guidance, all the doctors are working to make an end to all these three infectious diseases. And Dr. Vibhuti Saha, who is HOD of Infectious Department of Infections of STM, Professor Vibhuti Shah. So I hand over to our respected chairpersons, Dr. Ajay Chakraborty, Dr. Pallab Bhattacharya, and Dr. Vibhuti Shah, to start the proceeding. Over to our chairperson, sir.
Good morning. Welcome to you all. So today, there is something special that we are going to give goodbye to 3 diseases today. So that is the tuberculosis, the hepatitis, and the Kala-Azar. We all know, since the history, these 3 diseases are killing thousands and thousands of people. And sometimes you see this, mainly the tuberculosis and Kala-Azar, they are mainly affected the poor and marginal people, those who cannot afford the treatment, those who cannot afford for the diagnosis, and also they cannot continue the treatment. This is, previously it was called the poor man's disease. Till today, definitely, the good nutrition can prevent this too. But the thing is that, you see, a lot of deaths are happening in these 2 diseases. But after a long battle, we have won over these 2 diseases partially. And Kala-Azar, we are becoming the first state to declare as the elimination of Kala-Azar very soon. Already the study is going on, already the surveillance is going on, so that they can just, it will be proved beyond doubt that Kala-Azar is no longer a public health problem in the state of West Bengal. You know, Kala-Azar is very easy to remove because Kala-Azar is a very localized disease. It doesn't spread from one area to another. It doesn't spread from human to human. The vector is required. And that is a poor dwelling and other poor health conditions that actually invited the disease. So environmental factor plays a very big role in this Kala-Azar. So whenever the people education level and economic level is growing up gradually, then definitely it is easier to handle, to change the environment and to handle the disease and to control the disease. So now Kala-Jar is going to eliminate very soon. So that is our first thing to achieve. Second thing, the tuberculosis. Tuberculosis also, you see, since long we are working on tuberculosis, and previously it was the National Tuberculosis Program. And that National Tuberculosis Program has a many loopholes. Many loopholes means irregular supply of drugs, not rational diagnosis, that is mostly based on empirical diagnosis, based on X-ray findings, and that was so on and so on. The thing is that there was no process of ensuring the drug compliance and completion of the treatment. And now, after the introduction of the RNTCP, we have introduced the rifampicin, and then we started the short course chemotherapy. And with the short course chemotherapy, the whole paradigm has been shifted. That long duration of the tuberculosis treatment was reduced to 6 months, and in some relapse cases or the retreatment cases, it was to 9 months. But the problem was only there because of the introduction of rifampicin in the hands of the people in the community, then and unsupervised, in many cases unsupervised. So the program was a very good that only the supervised DOT therapy should be given. But in many cases, we have compromised this DOT and supervision. And that's why we have evolved the resistance, drug resistance tuberculosis. And now the challenge is that drug resistance tuberculosis and then XDR, extra drug resistance tuberculosis. So multi-drug resistance tuberculosis is now the threat for the future generations. Now, if we can do, this is also the right moment. If we can stop TB, if we can stop the TB as a public health problem and bring the prevalence in the very low level, then definitely we can succeed. And there is a dangerous outbreak of the drug resistance TB will be prevented. So that is the strategy. And now, therefore, we are just challenging, we are taking this oath to eliminate the tuberculosis by 2025. And for that, you will be very highly pleased to know that already our 2 districts has achieved a very good target. So they have reduced their case load of 60 to 80%. That is Purbo Mendipur and our Nandigram district. So they have reduced their case load of by 60%. And that's why just recently, 2 months back, we have won the gold medal by the government of India. So that is a very, very good thing that we can do, that has been proved. That is the first step. And also, beside that, Nadia, they have also reduced by 30%, and that is why they have been awarded the bronze award. So based on these 2 districts, by the success of these 2 districts, 3 districts, rather I say, now we can hope that we can do, we have the ability, and we will definitely do and extend throughout our state so that we'll also say goodbye to TB by 2025. And the third thing is that hepatitis. We all know that hepatitis is a long-standing problem and there was no treatment previously. And hepatitis was the, really, it is not a very fast killing, but it's a slow killing disease. And it can cause the carcinoma, it can cause the cirrhosis, and so many other things. And there is a problem for the, actually, the transmission potential is very, very high, though it is transmitted to the blood and blood routes, but the transmission potentiality of the hepatitis B and C is very, very high. Virus hepatitis A is definitely there, and that is a waterborne disease. And we know almost all of us have suffered from the virus hepatitis A. And that doesn't kill the person, only in case of exceptional cases. But normally we can recover from that and we can just stay happily. But this hepatitis B and hepatitis C, they cause a lot of damage and sometimes they kills the person. So also after the discovery and after getting the very good drug for the hepatitis B and hepatitis C, now we can just hope that we'll also can say goodbye to the hepatitis B and C, because if I can break the transmission route, if we can early detect all the cases by screening of the high risk group, and then we can just give them the best possible medicine to control the virus, and hepatitis C is very curable disease. If we can cure this, then the route of the chain of transmission can be broken down, and definitely one day we can say goodbye to viral, also the hepatitis. So now I am just handing over the mic to Dr. Professor Vibhuti Saha to just start the program. Thank you.
Thank you, Dr. Chakraborty.
So we know that the 3.3 Sustainable Development Goal of United Nations has called for ending the epidemics of AIDS, tuberculosis, and malaria, as well as neglected tropical diseases by 2030. And as we all of us know that we in India is the largest contributor of tuberculosis. We are the topmost. We contribute to 26% of the cases of tuberculosis in the world. And as we are hoping that we bring down the incidence by 80% and reduce the death by 50% by the end of 2030. So as Dr. Chakravarti was saying that we have problems of rifampicin-resistant tuberculosis, pre-XDR tuberculosis, XDR tuberculosis, as well as HIV and tuberculosis. And apart from treatment, apart from increasing the diagnostic facilities, treatment has been expanded, and also preventive treatment for tuberculosis. It has been predicted that it has been oath that every man who has a sputum positive tuberculosis in the family will get a preventive treatment of tuberculosis. And one word of hope that instead of 6 months preventive treatment of tuberculosis with INH, there have been treatment of 3 months with weekly rifampicin and INH. So these have been the developments of tuberculosis. So now it's my present duty to call Dr. Somnath Mukherjee to talk to us about tuberculosis. Dr. Subhashish Mukherjee to talk on tuberculosis. Dr. Subhashish Mukherjee, please.
Thank you. At the outset, I would like to thank API West Bengal chapter for inviting me as a speaker in front of this learned audience. I would like to pay my sincere thanks to the August chairpersons, Ajay Chakraborty sir, Pallab Bhattacharya sir, and Vibhuti Saha sir, and the August gatherings learned. Many of them are my teachers since my postgraduate days. So I would like to start my talk about a disease whose farewell we are talking about, tuberculosis, which is with mankind since the time of Egyptian mummies. So it is our vision, and with our accelerated and conjoint efforts, we hope to eliminate, not eradicate. Eliminate means to come down, bring down the incidence and prevalence to a low level so that it ceases to be a major public health problem. That is our goal we hope to achieve by 2025. And this was this year's World TB Day's theme, invest to end TB, save lives. A few glimpses to the journey of tuberculosis with mankind. It has been mentioned since the time of Egyptian mummies, as ancient as this. It was considered in history as a curse and known in different names like Jokha, Rajrog, Khoirog, until the discovery of Mycobacterium tuberculosis as positive agent by Robert Koch in 1882. The disease was considered incurable and deadly until the discovery of first antitubercular drug in 1944. And TB HIV co-infection and DRTB epidemic have amplified the problem very much. So before trying to eliminate, let us see what daunting task lies in front of us. This is the current scenario of TB. The incidence is 188 per lakh population. Prevalence of all forms of TB is 312 per lakh population. Prevalence of TB infection as measured by IGRA test is 31.4%. Prevalence of DRTB is 9.1 per lakh population. And the prevalence of DRTB among all TB patients is around 6.1%. Prevalence of INH resistance is as high as 11% in new cases, and it is around or more than 25% in retreatment cases. What is more worrisome is that 64% of chest symptomatic suggestive of TB did not seek healthcare services willingly. So those major chunk are spreading the disease and are not getting diagnosed because they are not coming voluntarily to the healthcare facilities. And still, the mortality in all forms of TB in India is 37 per lakh population. Obviously, the mortality is highest among MDR and XDR TB cases. The comorbidities have complicated the scenario very much. Alcohol, diabetes, HIV co-infection, smoking, malnutrition, and the recent COVID pandemic are the common TB comorbidities. So what the fight was started with? It started with prayer and rituals. Then the came of sanatorium era. There was no drugs, only fresh air, rest, and nutrition was thought to be the salvage therapy before death. Next, surgery came earlier. Later, antitubercular chemotherapy came into the scenario. A short journey through our National Tuberculosis Control Program, different phases. It started with NTCP in 1962. Then in 1983 only, short course chemotherapy was introduced. NTCP was reviewed and RNTCP dot strategy was started as a pilot project in 93 and full-fledged program started in 1998. With the advancement of our knowledge, the Stop TB strategy came then in 2006. DOTS Plus project was introduced in 2007 and entire country was covered in 2013. Previously, there was a category called category 3, we all know that, but it was abolished in 2010. TB was made notifiable and serodiagnostic tests like IgM and IgG were banned by making legislation in 2012. TB notification also made and mandatory through NICSOI. Then leaping forward from the Stop TB strategy, after achieving the initial goals, we moved forward to End TB strategy and sustainable development goals in 2015, as Professor Shah was saying. Daily regimen was introduced instead of intermittent regimen in 2016. Next step was abolition of category 2 treatment in 2018. The last lap, National Strategic Plan 2017 and 2025, it announced a goal of eliminating TB by 2025. The world has set a target of 2030. In National Strategic Plan, we have set our target 5 years earlier. So National Tuberculosis Elimination Program has been launched and emphasized in 2020. Stop TB strategy had a vision of world-free tuberculosis, and it has a goal of to dramatically reduce the global burden of TB by 2015 in line with the Millennium Development Goals and the Stop TB Partnership targets. It had short-term, intermediate-term, and long-term goals. The short-term goals was no different from that time RNTCP goal to achieve 85% cure rate and 70% diagnosis. Middle-term goals were to reduce the global burden to 50% of that level that prevailed in 1990. And it had a long-term goal of by 2050 to bring down TB incidence to less than 1 case per million population per year. After initial achieving goal, RNTCP also scaled up its targets from 85-70. It first changed to 90-90 target. 90% diagnosis, 90% success rate, and address DRTB, HIV, and other private public collaboration important areas. Next, the End TB strategy. Zero TB death, zero TB disease, zero TB suffering was its vision. And its main targets are 95% reduction in deaths due to TB, 90% reduction in its incidence rate, and no affected families should face catastrophic costs due to TB. This End TB strategy and sustainable development goals pave the way forward towards our accelerated impetus towards elimination towards tuberculosis. And these are the several NTB strategy components. I will not go into detail. This is the 4 pillars of National Strategic Plan: prevent infection, detect infection with molecular testing and drug resistance, treat efficiently, and build a partnership. So prevent, detect, treat, and build. NTEP has launched on these pillars. Its vision is to achieve a TB-free India with 0 death, disease, and poverty associated with TB, and to achieve a rapid reduction of TB burden by 2025. And the objective is to reduce the estimated TB incidence to 44, reduce the estimated TB prevalence to 65 per lakh, mortality to bring down to 3 per lakh, and to achieve 0 catastrophic cost for affected families due to TB. And to achieve those objectives, we should at least achieve a treatment success rate in 92% among DSTB and 75% among DRTB patients. Active case finding is an important tool because, as I have mentioned, 64% do not reach the healthcare on their own. TB cases must be notified, and TB preventive therapy should be emphasized, and at least 95% of the eligible population should be covered by TB preventive therapy to achieve the elimination goals. So there are some major changes in the diagnostic and treatment, some paradigm shifts. I will just touch the nutshells. The TB suspect term has been abolished with presumptive TB. Presumptive pulmonary TB is a person with any of the symptoms or signs: cough more than 2 weeks, fever more than 2 weeks, significant weight loss and hemoptysis, and any suggestive abnormality in chest X-ray, and special impetus to be given for diagnosis in special risk immunosuppressed and other populations. Presumptive EPTP is presence of organ-specific symptoms and signs along with constitutional symptoms, but we should try to achieve a microbiological diagnosis as far as practicable in these patients too. And the presumptive pediatric TB, the additional points are here that loss of weight or no weight gain, and the history of contact with infectious TB diseases. These are also additional points to suspect presumptive TB in pediatric population. The case definitions, it has been simplified. Only microbiology confirmed, which refers to a TB patient whose biological sample are positive either by smear or by culture or by WHO and India government endorsed rapid molecular testing methods, means CBNAT and line probe assay. And the another P is clinically diagnosed TB case, which refers to presumptive TB patient where bacteriological or microbiological confirmation has not been achieved, but the treating physician stamps it as a clinically diagnosed TB based on symptoms, radiology, and other ancillary investigations. So only 2 types of case definitions: microbiology confirmed, clinically diagnosed. The drug resistant TB definitions has also changed. I will only highlight the important one. Rifampicin resistance or RRTB has been highlighted. It is a TB patient whose biological specimen has been found to be resistant to rifampicin, detected either by phenotypic or genotypic methods, with or without resistance to other anti-TB drugs. Why this has been highlighted? Because in program per se, RRTB has been given the equivalent status of MDR-TB. So RRTB should be treated in the same line as DRTB. And the pre-XDR and XDR definition has been modified with the abolition of injectable drugs. Now we have entered the era of all oral TB regimens mostly. So pre-XDR is a disease caused by Mycobacterium tuberculosis that must be MDR or RR at the baseline with additional resistance to any of the respiratory fluoroquinolones, means levofloxacin, moxifloxacin. And XDR, a TB caused by Mycobacterium tuberculosis, again, which must satisfy the MDR or RR TB with additional resistance to any of the fluoroquinolones and at least 1 additional group A drugs. That means either bedaquiline or linezolid or both. So these are the new pre-XDR and XDR TB definitions. Diagnosis, I will highlight on the rapid molecular diagnostic test. the nucleic acid amplification test or CBNAT, and the first and second line LPS. These are WHO and Government of India endorsed cases. The advantage is that the rapidity of diagnosis with high sensitivity and specificity. CBNAT, the diagnosis can be achieved in only 2 hours. And in LPA, the drug resistance we can get only within 72 hours. Where in liquid culture, the time is around 6 weeks. So this has put forward our fight. This has helped us. But one thing we should keep in mind, the genotypic test, that is drug resistant test, they cannot be used for determining treatment response. So CBNAT, LPA for diagnosis of drug resistance, they are fine. But they cannot be used as a follow-up test to see whether patient is improving or not. For that, we need drug susceptibility testing. So the TB treatment regimens which are available now, it has also been simplified. DSTB regimen for INH monopoly, shorter all oral MDR or RRTB, all oral longer regimen. So these 4 regimens are available now in as per program, and one experimental in the pipeline BPAL regimen for XDR TB where no other treatment option is available with bedaquiline, pretomanid and linezolid 6 to 9 months. So let us see what is the diagnostic and treatment algorithm has been very much simplified. So all TB patients are undergone CBNAT. If CBNAT shows rifampicin sensitive, then we put the sample for first line LPA to see additional INH resistance. If first line LPA shows no INH resistance, then rifampicin sensitive, INH also sensitive, so continue treatment for DST. If rifampicin is sensitive, but first line LPA shows INH is resistant, so we categorize it as INH monoresistant and we treat the patient as INH monoresistance regimen. Next, the other arm, CBNAT. The CBNAT side shows rifampicin resistance is detected. Then we send first line LPA along with baseline second line LPA with liquid culture DST to pyrazinamide, bedaquiline, moxifloxacin, linezolid and delamine, part and parcel of universal DST program now. If no additional drug resistance is detected, then it should be it can be treated as RRTB by shorter all oral longer shorter regimen, all oral regimen. If any additional drug resistance is detected, then we should go for all oral longer regimen. So this is the protocol. This is DSTB regimen now. Again a change that 2 HRZD plus 4 HRE. Ethambutol has been added in the continuation phase. And another thing that has changed, the daily dose of drug and weight banding. There are 5 weight bands for adults, 25 to 34, 35 to 49, 50 to 64, 65 to 75 and above 75, and accordingly 2, 3, 4, 5 and 6 tablets per day. The tablets are fixed dose combination consisting of 4 drugs, rifampicin 150, INH 75, pyrazinamide 400 and ethambutol 275. And the continuation phase FDC contains 3 drugs, H, R and E. The CP may be extended for 3 to 6 months in certain TB like CNS skeletal disseminated based on clinical decision. This is the new grouping of anti-TB drugs. We should spend a few seconds on it. For DRTB classification, there are mainly 3 groups. Group A, the most important, it consists levofloxacin, moxifloxacin, bedaquiline and linezolid. For DRTB regimen, all of the group A drugs, one of the quinolones and other 2, all 3 group A drugs should be used wherever feasible. Group B, 2 drugs, clofazimine, then cycloserine or terizidone. And group C, ethambutol, delamine, pyrazinamide, and the other lower down drugs, amikacin, imipenem cilastatin, lithionamide, prothionamide, PAS. Bedaquiline and delamine are the 2 newer drugs that has been added in the armamentarium of our fight against tuberculosis. This is the regimen for H monopoly resistance. There is no IPCP differentiation. 6 or 9 months regimen with 4 drugs, just HRZD DSTB regimen. As INH is resistance, you take out H and incorporate levofloxacin. The regime levofloxacin, rifampicin, ethambutyl pyrazinamide for 6 to 9 months. No separate IPCP. Treatment algorithm MDR or RRTB, I have already discussed. RR detected. If no additional drug resistance, we can go for shorter all oral. If additional drug resistance, we should go for all oral longer. This is the shorter oral DRTB regimen containing bedaquiline, 4 to 6 months of IP with bedaquiline, levofloxacin, clofazimine, pyrazinamide, ethambutyl, high dose INH and ethionamide, and 5 months CP with levofloxacin, clofazimine, pyrazinamide, ethambutyl. Whom should be put on shorter oral? There should be no additional drug resistance, only RR. If there is resistance to INH, it should be either in CAT-G or in INHA, not both, and no additional drug resistance. Another exclusion criteria is there. If there is bilateral cavitary disease or extensive disease, we should not go for shorter treatment, we should go for all oral longer. So these are the DST based and the severity based exclusion criteria of which I have already mentioned. And this is all oral longer MDR or XDR-TB regimen containing bedaquiline for MDR RR-TB with additional drug resistance or who are not suitable for shorter. This is a 18 to 20 months regime consisting of levofloxacin, bedaquiline, but bedaquiline will be stopped at 6 months, linezolid, clofazimine, and cyclosin. Follow-up has been added, especially long-term follow-up, which has been important. After completion of treatment, patient should be followed up for at least 24 months to detect early relapse. TPT or tuberculosis preventive therapy has been given due importance. After ruling out active TB, we should start TPT, and who are the target population? Previously, TPT was offered to only contacts of pulmonary tuberculosis patients who are microbiologically confirmed and who are less than 5 years of age, children. But here the scope has been extended to people living with HIV, adult and children above 12 months, household contacts below 5 years, household contacts of 5 years and above who are in contact with a drug sensitive TB, individuals who are on immunosuppressive therapy and having silicosis or anti-TNF treatment like this. And there are several regimes also. One is, we already know 6 months INH. But another regimen has been proposed, as Dr. Shah has already mentioned, 3 months therapy with weekly INH and rifampicin. For DRTB also, there has been a proposition. It has not been implemented yet. There are 2 regimes has been proposed for contacts of DRTB. For only RRTB but INH sensitive, these should be treated with levofloxacin for 6 months, and for RSTB, INH monoresistant, they can be given 4 months rifampicin TPT. This is a proposal, but still now not started and incorporated in our guideline. There are several contraindications. We should rule out active TB, active or chronic hepatitis, concurrent use of other hepatotoxic drugs, regular alcoholics, pregnancy or previous. But pregnancy and previous history of TB are not contraindications. So TPT has been highlighted. What are the additional initiatives? Active case finding. This has been periodically inside the program. There is scope for active case finding to find out the cases which are looming at large and not coming to healthcare facilities. DDR, NDR, TB site and Center of Excellences have been set up to deal with the complicated cases. Difficult to treat TB clinics in each state have been set up to discuss the difficult drug resistant cases and solve those. With this, I would stop here with a word of caution that we hope to achieve our goal, but we have miles to go before we sleep. And we need cooperation from everybody of us, public sector, private sector, the government commitment to achieve this daunting task in this short time. So thank you all.
Thank you, Dr. Mukherjee, for covering the topic extensively and vividly. I think if there are any questions, that can be taken after, because we are running short of time. So now I hand over the mic to Dr. Pallab Bhattacharya to continue the session.
So firstly, kudos to API West Bengal for initiating this marvelous symphony or orchestration on the swan song or elimination efforts of three major epidemics that we have had. So essentially, the elimination of the next entity that we'll be considering now is Kala-Azar. And here we may comment or feel confident because the universe is relatively smaller. Countrywide, we have 5 states which are in the limelight regarding Kala-Azar. And in our state, it amounts to 120 blocks across 11 districts. So this is our universe where we need to concentrate. And in the meantime, since the 90s, when this was thought of and the program began, early 90s, we in this state particularly have been able to reach somewhere in the sense that for the last 3 years, we have been consistent with the elimination goals. And now the final documentation and all is ongoing. So that's where we are. So now we have our young speaker, Dr. Deeptak Bhaumik, who would be taking us through the journey of the elimination process of Kala-Azar in this state. Thank you. Over to Dr. Deeptak.
First of all, I would like to thank API West Bengal chapter for giving me the privilege to speak on this platform. Hello. 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 Yeah. Good morning, respected chairpersons, respected teachers, and all the esteemed delegates. I would like to thank API West Bengal chapter for giving me the privilege to speak on this platform today. Today, I'm going to talk on the Kala-Azar elimination in India and West Bengal. Now, today in the year 2022, this is very important because India is aiming to achieve the Kala-Azar elimination within the next year, that is year 2023, and West Bengal is one of the endemic states in India. History of Kala-Azar is older than the dated records. The agent of the disease was first isolated in India by Dr. William Leishman, who observed the parasite in spleen smears of a soldier who died of the disease in Dum Dum, and hence it was once called Dum Dum fever. And Charles Donovan also worked on this parasite, and they independently discovered the protozoa. In South Asia, Kala-Azar occurs in Bengal, Bangladesh, Nepal, and ectopically in Bhutan also. Nearly 200 million people are considered at risk of contracting Kala-Azar. In India, 54 districts across 4 states, Bihar, West Bengal, Uttar Pradesh, and Jharkhand are endemic. In West Bengal, 11 districts are endemic of Kala-Azar. Out of the 214 blocks in those districts, 120 blocks are endemic. All Kala-Azar endemic blocks in West Bengal have achieved the elimination target since 2017. Kala-Azar became a notifiable disease in the year 2014. Now this is the whole world scenario where India is reporting more than 1,000 cases per year. And this is the countries in Southeast Asian region which reports Kala-Azar cases, India, Nepal, Bhutan, Bangladesh, and few cases from Thailand also. Kala-Azar is a complex vector-borne disease caused by the protozoa Leishmania donovani. Leishmaniasis is endemic in 97 countries, and 3 lakh cases and almost 20,000 deaths per year occurs due to Kala-Azar. Visceral leishmaniasis, which is also known as Kala-Azar, represents the most severe form of the disease, though it is also available. It occurs in other 3 forms like cutaneous, mucocutaneous, and the visceral leishmaniasis. India is one of the 6 countries that account for 90% of the global burden. Approximately 130 million people spanning 54 districts that I have already mentioned. In West Bengal, the scenario is total 11 districts are known to be endemic of Kala-Azar, but now due to division, the districts and the number has increased to 14. In recent years, 10 endemic districts have reported Kala-Azar cases, and in 2020, in West Bengal, total 58 VL, that is visceral leishmaniasis cases, and 39 PKDL cases was reported. It is a slow progressive disease. In India, Leishmania donovani is the only parasite and human is the only reservoir. The parasite primarily infects the reticuloendothelial system, and post-Kala-Azar dermal leishmaniasis is a condition when Leishmania donovani invades skin cells, resides and develops there and manifests as dermal lesions, which occurs in 5 to 10% post-treatment of visceral leishmaniasis, and the median duration is 6 months to 1 year later it develops. This is transmitted to human by bite of infected female sandfly of Phlebotomus argentipes group. The Kala-Azar is fatal if not treated, and man is the only reservoir. Incubation period ranges from 10 days to 2 years. However, in India, it may range from 4 months to 1 year. Sandfly is a poor flyer moving in short hopping flights, and the movement is restricted within 25 meters. Key symptoms includes irregular fever for more than 2 weeks, splenomegaly, and weight loss. Post-Kala-Azar dermal leishmaniasis is a sequelae of Kala-Azar. Now, a few words on the vector. Actually, this Phlebotomus argentipes is entirely endophilic, residing within the indoors, and it prefers humid area, and it resides in the cracks and crevices of the muddy walls of the houses in endemic regions. Human behavior like sleeping outside the ground may increase the risk of transmission. Malnutrition and diets lacking in protein, energy, iron deficiency, vitamin A and zinc deficiency may increase the risk. A higher proportion of males, that is males than females, in a ratio of 60 to 40, and close to 40% cases are among children less than 15 years. So this is the life cycle of the protozoa. Which I want to emphasize on is that in human individuals, we see the promasticoid form, and this amasticoid form, and amasticoid form is can be seen in splenic and bone marrow aspirates, which is known as the LD body. Now, this is the epidemiological triangle, including the host, the environment, and the vector. Now, Kala-Azar elimination target. The annual incidence or the incidence rate of Kala-Azar should be below 1 case of visceral leishmaniasis per 10,000 population at block level in India. So what are the feasibilities of elimination? Since we know that man is the only reservoir and Phlebotomus argentipes, the sandfly, is the only known vector. The disease is confined to limited geographical area, rapid diagnostic tests are available, and there are high political commitments also. The main strategies for achieving the targets are early diagnosis and complete treatment, integrated vector management, effective disease and vector surveillance, social mobilization and partnerships, clinical and operational research. Now, the strategy is interruption of transmission for reducing the vector population by undertaking indoor residual insecticidal spray at least twice in a year with DDT early diagnosis and treatment of Kala-Azar, and health education for the community awareness. Diagnosis and treatment of VL and PKDL. This is a case definitions. A suspected case is a person who is having fever for more than 2 weeks and residing or traveling to the endemic area. And a probable case is when we rule out malaria. Now, confirmed case is when we perform on a case of fever residing in the endemic area, when we rule out malaria, and then we perform tests which in the form of RDT or biopsy to look for LD bodies. Now, what are the clinical presentation? That is irregular fever with chills and rigor, intermittent, fatigue, blackish discoloration of skin, enlargement of spleen and liver, that is splenohepatomegaly, progressive anemia, and low blood counts, pancytopenia can also be seen with increased globulin level in the blood. Relapse is a Kala-Azar case who experiences recurrence of Kala-Azar symptoms with parasitological confirmation at any point of time after previous initial cure, that is 15 days of the treatment when the treatment regimen is less than 5 days. The diagnosis can be done by rapid diagnostic tests, and if suspicion of relapse or RDT negative with strong clinical suspicion is present, then refer to a medical college for biopsy from the spleen or bone marrow to look for LD bodies. Currently, the diagnosis is done by RDT or biopsy. Among the biopsy specimens, the splenic aspirated is the most sensitive with sensitivity more than 95%, followed by bone marrow and lymph nodes. Though lymph nodes are only present in very late in the disease, and the sensitivity of lymph node biopsy is 58%. RDT, that is the RK39 antigen-based kit test, it has some advantages, that is easy to perform, laboratory setting is not required, easy to transport, can be performed on a single prick blood. The results are available in 10 minutes. Disadvantages is cannot distinguish between current and past infection or in diagnosis of relapse or as prognostic test. This is a procedure that we have to take one single drop of blood and we have to add a chase buffer, and it is a kit test. So if there are 2 lines, it is positive. One important thing that RK39 tests may remain positive up to 24 months after treatment. Now, what is the treatment of Kala-Azar patient? It is liposomal amphotericin B at a dose of 10 milligram per kg body weight. The total dose should not exceed beyond 500 milligram, and it has to be reconstituted with sterile water, and it has to be charged into 5% dextrose for transfusion. This is AmBisome, which is supplied by WHO with agreement with the government of India. And this is the steps of preparing AmBisome, and we must remember that we have to charge it in dextrose solution for transfusion. For each patient, start the infusion with 1 to 2 drops per minute, very slow test dose for a period of 10 minutes. And if the person develops no further reaction, then we have to give the rest of the solution within 2 to 3 hours. Infusion related reactions usually not very serious. Fever, chills can occur, lower back pain, nausea. If there is any infusion related reaction, we must slow down the infusion, observe the patient closely, and then we again start infusing. If there is any severe reaction, we must follow the standard operating procedure, and all adverse reaction must be reported. Anaphylactic reaction is very less, observed in less than 1 in 2,000 patients. Interaction, we all know that with nephrotoxic drugs and with corticosteroids and diuretics, there is chance of hypokalemia. Now, this is a very safe drug, and it has given in 1 month patient aged 1 month only up to 16 years, and in all adult patients, and even pregnant patient, this drug is very safe. Now, VL with HIV co-infection and its treatment. This treatment differs because the total dose is 40 milligram per kg body weight in 10 equal doses. That is day 1 to 5. Then the same dose has to be repeated on day 10, day 17, day 24, day 31, and day 38. The why VLHIV is important, the magnitude of VLHIV is 4 to 5%, and it is more prevalent in Bihar. VLHIV co-infection has major clinical, diagnostic, and epidemiological implication. The two diseases are mutually reinforcing, poor treatment outcomes and higher mortality is present. Co-infected patients are more than 90% in more than 90% patients there is relapse, and poses a new challenge to elimination effort of Kala-Azar. Now, after giving liposomal amphotericin B, we may discharge the patient immediately. The fever will subside within the first week. This is followed by a return of appetite, weight gain, and the regression of spleen occurs at a rate of 1 millimeter per week. Now, PKDL is the case definition is a person of Kala-Azar endemic area with hypopigmented macules, papules, plaques, or nodules with previous history of Kala-Azar. And probable case is when we perform RDT and RDT becomes positive, that is probable PKDL, and it has to be confirmed by doing a skin slit smear or biopsy or PCR based test. PKDL usually appears first on the face and spreads to the other part of the body. It has a potential role in transmission of VL in the inter-epidemic period and may act as a reservoir. Potential threat to success of KA elimination program. These are the differentials, most commonly leprosy. These are the few images of PKDL showing the different type of skin lesions actually. Now, what is the treatment? This treatment is with miltefosine. If the person is weighing more than 25, then 100 milligram total dose in 2 divided doses for 12 weeks. If the weight is less than 25, then it's 50 milligram once daily for 12 weeks. And we must remember one thing is that it is contraindicated in pregnancy and lactation. So the choice is liposomal and amphotericin B, but the doses varies because it has to be given for 3 weeks actually. Now, these are the few pictures where the skin lesions has regressed. Before and after treatment. So this is in one slide showing all the treatment options in VL, VLHIV, and PKDL. Now, follow-up can be done 15 days after the therapy, and at 1 month, 6 months, then every 6 months. For treatment outcome, initial treatment assessment has to be done after 15 days if the treatment duration is less than 5 days, and then after 6 months. Treatment outcome for PKDL cases, here it differs because the initial cure can be done as early as 15 days, but the clinical cure or the final cure has to be examined at 12 months. Now, some key epidemiological terms here important is that outbreak. Outbreak is defined as 10 or more laboratory confirmed cases reported in a given area or among a specific group of people within 6 months of occurrence of index case. 5 or more in UP and West Bengal, and 1 or more in non-endemic areas. Now, this is the standard operating procedure of elimination program and management, outbreak management. Now, if there is a major outbreak, then we have to first confirm whether indeed there is an outbreak, and then we have to prevent morbidities and mortalities, and to determine the most effective and practical means of controlling the outbreak. First, if there is any suspicion of outbreak, we have to intimate the deputy CMOH regarding the matter that a probable outbreak has occurred of Kala-Azar. Once Kala-Azar outbreak is suspected, we have to confirm the occurrence, planning and implementation and immediate rapid response, strengthening system for prevention, early detection, and effective management of future outbreaks. As soon as information of suspected outbreak is received, the first step is to confirm the diagnosis. In non-endemic area, parasitological confirmation of first few cases should be done. Once diagnosis is confirmed, then estimate the extent, a spot mapping can be done. As soon as the diagnosis is confirmed, then we have to treat the cases, and detection of additional KA and PKDL cases through house-to-house active case search in at-risk areas or entire village, hamlet or cluster, or 500 meters or 250 houses surrounding the Kala-Azar case. And all suspected cases shall be examined by a trained MO and tested if required within 2 days. This is very important. Achieving Kala-Azar elimination is not only achieving physical target of less than 1 incidence of Kala-Azar per 10,000 at block level, but to ensure a system where even a single suspect of Kala-Azar is timely diagnosed, put on treatment, and properly followed up, so as to ensure no death or prolonged morbidity. Now, this program has been integrated with other programs, HIV and Kala-Azar for co-management of HIV-VL, Kala-Azar and leprosy in active case search, pharmacovigilance program, RBSK, integrated fever surveillance program, Kala-Azar with COVID, integrated entomological survey in districts using VHND for Kala-Azar's social mobilization activities. Integration of surveillance activities helped in better programmatic output with holistic approach. This is cost effective and time saving. Now, this is the incidence of VL cases per 10,000 population from 2014 to 2020 in West Bengal, where in 2014, the incidence rate of more than 1 was seen in 12 blocks. It gradually decreased to nil in 2017 and ever since. Like from 2017, West Bengal is able to achieve the elimination target. Now, these are the some few silent villages reporting cases in 2020-21 with few new blocks and new focus being discovered. Now, new hotspot villages with blocks, more than 2 Kala-Azar cases in a village. These are Kalimpong, Dinajpur, Rampurhat, Darjeeling, South 24 Parganas and Dakhin Dinajpur districts. West Bengal particularly shares border with Bangladesh, Nepal and Bhutan, and as well as some interstate borders with Bihar, Jharkhand. So the cross reporting is very important. Cross notifying all referred cases to their respective place of residence. This should be encouraged and implemented throughout the state by a standard mechanism. Now, WHO NTD roadmap, that is neglected tropical disease, 2021 to 2130. The new WHO NTD roadmap has proposed a new target for elimination of Kala-Azar. It is defined as achieving less than 1% case fatality rate due to primary Kala-Azar. It has 2 more sub-targets in ACAR region, namely number of countries in ACAR validated for elimination less than 1 case per 10,000 population at block level in India at 100% by 2030 and PKDL cases detected and treated 100% by 2030. Now, there are 3 key preconditions, that is adequate health services that can incorporate Kala-Azar diagnosis and treatment as a routine activity and which are no longer a vertical program without risk of jeopardizing results. Revisiting entirely the vector control program under the principle of integrated vector management, examining all the steps from procurement to implementation, from planning to monitoring, implement all necessary efforts to coordinate with the districts and blocks. Thank you. Let us eliminate Kala-Azar together. Thank you very much. Thank you.
We have come to a close of this session. So actually, if you have any questions, because we are running late, I think my co-chairs would agree. The questions may be taken up with the speakers during tea or lunch. That would be ideal because we are running late. So the common refrain has been multi-stakeholder participation, community involvement for elimination of all these 3 programs. And of course, the physician being a pillar in the domain of public health so that we move from silos to synergies to achieve elimination goals and targets. Thank you all. We close the session.
Thank you, sir. Thank you very much.
Thank you, Chairperson sirs, and both the speakers for offering us a very exciting session. Now we pass on to yet another very important session. Before passing to the second session, we like to felicitate our speakers as well as chairpersons. May I request all the chairpersons and the speakers to come on the stage, please. Dr. Subhashish Mukherjee and Dr. Deeptak Bhaumik. May I request our chairperson, sir, to offer a small memento as a token of respect, love from our end, API West Bengal chapter. So may I request Dr. Pallav Bhattacharya as well as Dr. Vibhuti Shah as well as Dr. Ajay Chakraborty to offer memento to Dr. Shubhashish Mukherjee, sir. Please stand here, sir. Please, please. Next, I request all the chairpersons to offer a memento to our Deeptak Bhaumik. He is also from Sagadatta, both the speakers from Sagadatta. Previous one is associate professor. Deeptak Bhaumik is assistant professor. Both are very dynamic and working very hard over there to maintain their departments. So now we pass on to the second session. That is also a very interesting session and very practical session. So, sorry, sir. I am so sorry, sir, I am running late and there in next session, I request Professor R.N. Sarkar to hand over the memento to our respected chairperson, sir. I am so sorry. Dr. Pallab Bhattacharya, now Dr. Ajay Chakraborty. Now I request Dr. R.N. Sarkar to offer our memento to Dr. Vibhuti Saha. Thank you, sir. Thank you, all the chairpersons and speakers for offering a very good session. Now we pass on to the second session as we are running late. So that's why I forgot that decorum. I am sorry for that. Now in the second session, we are having our chairpersons, Professor Dr. D.K. Majumdar. May I request Professor Dr. D.K. Majumdar to come on the dais. Dr. Shivendu Ghosh, please escort him. Now may I request Professor Anita Datto, please come over the dais. Professor Anita Datto, madam. Now Professor Navanita Chakraborty. So Professor D.K. Majumdar is a retired professor and HOD, Department of Medicine, VIMS, that is Vivekananda Institute of Medical Sciences. Professor Anita Datto is also a retired professor of Venaris Medical College, and Professor Navanita Chakraborty is head and professor, Department of Medicine, Medical College, Kolkata. I request all the chairpersons to go the speakers in a reverse way, because the last two speakers are in hurry to catch their flight. So please go the schedule of speakers in a reverse way. Now over to Professor D.K. Majumdar, Professor Anita Datto, and Professor Navanita Chakraborty to start the proceeding. Over to you, sir and madams.
Good morning, everybody. We are going for a very important session, and all the subjects are actually global health problem. So as Dr. Goswami and Dr. N.P. Singh, they'll be ready for catching their flights. So we'll invite Dr. B.D. Goswami or Dr. N.P. Singh, sorry, you can come first. Yes. The subject is how to delay the progression of CKD, a practical treatise. So this is a universal problem, and chronic kidney disease is really a global health problem. And almost every person, particularly in India, is suffering from hypertension or CKD or many chronic urinary infection and many other things. So we have to delay the progression of CKD. Dr. N.P. Singh, I'll request you to start your proceedings. Thank you.
Thank you, respected chairpersons. I'm honored and privileged to be speaking in front of a very, very elite and senior chairpersons. And I'm also honored to be here in the cultural capital of India, a city of both processions and city of joy. I'm really happy to know that you do a lot of processions and you remain happy. And I'm also privileged to be speaking in front of my seniors, Dr. Amal Banerjee, Dr. Sarkar, Dr. Chakravarti, Dr. Ghosh, with whom I've been interacting in a national level. And I'm especially thankful to Dr. Chakravarti and Dr. Jyotimari Paul, whom I do not see. He must be busy in the national politics as usual. And I think what is important for us to talk to for next 25 minutes to this very, very learned but depleted audience, and some of them are having the tea, is to see whether we can now have some strategies to prevent the progression of one of the dreadful disease. And I am very clear, I do not have any personal disclosure except for an excellent hospitality given by my friends in a 5-star hotel. And also I was treated to a good breakfast today. Except that, I do not have any conflict of issues. My outline of presentation would be to talk to you about how, apart from the infections which are on the rise, as was stated by my previous speakers, but non-communicable diseases are also on the rise, and we've seen a rapid spread of hypertension, diabetes, and all those. So we're going to talk about the disease burden. Also, I'll talk to you about trajectory of chronic kidney disease, how a specific individual behaves once he's diagnosed as a case of chronic kidney disease, and what are the risk factors associated with progression of CKD. We all know about the risk factors for CKD, but what are the risk factors for progression? And then we'll try to see if we can try to reverse this trend, or at least halt this trend of rapidly progressive renal disease. And then there'll be some key messages. Well, we all know around a decade back, we used to call chronic renal failure a term in which the creatinine was more than 1.2 arbitrarily, without giving credence to what is the duration of the therapy. But now, for last decade, we are very sure that chronic kidney disease is defined as alteration or dysfunction of the structure or the function which is persistent for 3 months. Even if you have an electrolyte abnormalities, which is secondary to a tubular dysfunction, persisting for 3 months defines it to be CKD. So are the structural imaging abnormalities or a history of kidney transplantation. So what is important is we need to have evidence of albuminuria, evidence of a decreased GFR, persisting for at least 3 months is what will define as chronic kidney disease. And lately, around 5 years back, there was a group formed as Global Burden of Disease, and I was very lucky to be a part of that in the CKD group. That published a series of articles in Lancet about what is the prevalence of various non-communicable disease. And this is a study which was published in Lancet in 2000 study, which talked about global, regional, and national prevalence of chronic kidney disease. And we will see here that the overall prevalence of chronic kidney disease all over the world is to the tune of 9 to 12%. And India also participated in that. And the numbers have shown a significant rise, not only in terms of morbidity, but also in morbidity. And these are some of the elegant studies done by some researchers in India about prevalence of chronic kidney disease. Dr. Sanjay Agarwal from AIIMS started the trend, and he found that his 10% of CKD patients were diabetic, hypertension was prevalent 22%, but his criteria was based on a single level of creatinine mode 1.8. Obviously, this was before when eGFR came into picture. Then, of course, there have been some studies, and this was our study which we published in 2009, which said a prevalence of a low GFR to be the tune of around 4%. Subsequently, A.K. Singh from US published his data, and where he found a prevalence to be very high as 17.2%, but this was a voluntary approach. And then, of course, there was a study by Dr. Janal Verma, who described the prevalence to be the tune of around 4 to 6%. Now, why is it important for us to make a diagnosis of chronic kidney disease? Once a diagnosis of chronic kidney disease is made, there is a relentless progression to what is known as end-stage renal disease. Unfortunately, majority of these patients would succumb not only to ESRD, but to significant mortality due to cardiovascular disorders. So as I said, general prevalence varies from 9 to 20%, but please understand that there is a catch here. Why the incidence is so high is because of the fact we take into account the age, sex, and the serum creatinine. Now with time, each one of us are aging, though we may not be able to see our age like Dr. Chakravarti sitting here or others, but with aging, there is some decline in renal function, but that is a healthy aging that may not necessarily convert into a chronic kidney disease. So with the aging, the difference would be that the GFR is reduced gradually, but when you have a CKD, you have an associated structural or abnormal function in terms of proteinuria. And as I said, the mortality is being very high, progressive rise in CKD, and there's a need to improve current management. And what is utmost important is to detect them early in the primary care staging and halt the progression. Now, if you have a diagnosis of CKD, each person will behave in a different way. That will depend on what is his trajectory. And that trajectory is dependent on various factors, including the etiology, including even in that etiology of nephropathy, what is the underlying diagnosis of FSGS versus the other disorders. If a patient has an ADPKDA, then his trajectory is different. Then his genes also decide how is his trajectory going to be. So we need to understand the patient very well of a chronic kidney disease and have a strategy based on the diagnosis of CKD in this patient. As I said, there are various types of patterns of his rapid progression to renal failure and stage renal disease. And these are highly variable. One person may have a very slow progression to chronic kidney disease. And this is a practical experience. You must have seen a patient of CKD comes to you. After 3 months, the rise is just 0.5 or 1 milligram. On the other hand, we have a patient who shows a very, very rapid decline in chronic disease. So these are some of the strategy. We can divide them into very fast. If there's a rapid downfall to within few months, he goes into a dialysis program, or the strategy has to push this graph up and up. If a person is very fast, it has to go into fast, and slowly we should try to retard the progression. And this is the difference is because of the heterogeneity of the etiology of. Now, the next slide is going to be the most important slide. I'll spend some time on that. What are the risk factors for CKD progression? Now, so first, of course, the most important thing is the lifestyle factors. Now, each one of us have a different lifestyle. Someone walks 15,000 per steps and takes a vegetarian diet. On the other hand, some of you will go out and smoke, and I understand that smoking is pretty high in West Bengal. You will also indulge in alcohol in the evening. You will take a lot of salt. So physical activity will determine how your progress is going to be. Then there are certain biomarkers. Of course, these are still experimental state, but still, if you do a urinary biomarker, you might find there are certain biomarkers which might show a positive trend in such patients. And these are the patients who are more likely to progress. Then I always say, you can't choose our father. We can't choose our father, but we can choose our father-in-law. So we can't predict our genetics. Our genetics will determine how we are going to progress in CKD progression. But definitely our lifestyle is the one which can save us. So there are certain these genetic predisposition to CKD progression, to RAS inhibition, to fibrosis, to inflammation. Now we have identified that there is a mesenchymal cells in the kidney which will convert into fibrosis, and that is the one which will determine the chronic kidney disease. And then there are certain genetic factors for our metabolism production also. Then, of course, the renal factors, a presence of a low GFR, a presence of a uropathy, obstructive uropathy in an elderly, presence of a glomerulonephritis, all this can predict how the progression is going to be. And presence of complications, anemia, metabolic bone disease, hyperkalemia, these will push the kidney dysfunction much further. And presence of a controlled high blood pressure, diabetes, autoimmune disease, gout, intermittent sepsis, all these can determine. And finally, do no harm. We are the ones who contribute further by giving them drugs, by giving them toxin, by subjecting them to unnecessarily CT scan that can also progress. So in nutshell, there are certain modified factors, there are certain various other factors which will contribute to the individual's progression of chronic kidney disease. And that is why there is a difference in trajectory of patients who go into CKD disease. Now, one very important factor, when I was a child, when I was studying medicine, I was told that patient develops a renal failure, acute renal failure, he recovers fully. But that is not so in this era. AKIs, subacute or acute, will cause certain amount of damage. And this is what is depicted by here. Say we have a patient with chronic kidney disease. He's progressive slowly. Suddenly he's developed one episode of AKI. His progression will become faster. His deterioration will become faster. And AKI severity will also determine how we'll go down it. And when he has multiple episodes of AKI, he's going to have further progression. So AKI and CKD are very interlinked with each other. AKI is never self-limited. It will always lead to some amount of renal damage. And if I ask you one question, how many nephrons do we have in one kidney? Can anyone answer this? Young and how many nephrons or glomeruli do we have in one kidney? We have around 10 lakhs in each side, right? So if we have 10 lakhs in each side, as we grow older, at the age of 60, 70, our nephron number is reduced to 7 lakhs. Then each episode of AKI will reduce that number further. It may not translate to a decrease or increase in the serum creatinine, but it will definitely damage the kidney. And these are the factors: the old age, the delayed recovery, the severity, the etiology, and the comorbidities all will push an AKI to a case of chronic. And if a patient develops an AKI when you already have a low GFR, then the chances of this going into ESRD is much more higher. And how do we screen the progression? We need to, whenever we see a patient of CKD, we need to find out 3 important things. One is, what is his etiology? Try to find out the etiology. Is he diabetic? Is he hypertensive? Does he have what is known as a CKD-U? Does he have a polycystic kidney disease? Does he have an obstructive air? Second is, try to find out the GFR category and also write the albumin category. Based on these 3, we can predict how is he going to progress. And we use estimated risk of occurrence of complications, and also we try to find out. And this is how we need to write. We now need to define CKD based on the cause, based on the GFR category, and also based on albuminuria category. You may have a person whose albuminuria, we no longer called it as microalbuminuria. We say normal to mildly increased when your albumin is less than 30 milligram per gram from 3 milligram. We call it as moderately increased if the albuminuria between 30 to 300, and we call it as severely increased if the albuminuria is more than 300 milligram per gram of creatinine. And also based on his GFR category, we can divide them into G1, G2, G3A, G3B, G4, and G5. Obviously, a person with G3, 4B, and A3 will have much more worse prognosis as compared to a person whose category is much lower. And as I said, we should also define him by etiology. And each one of you should have, you have so many apps on your mobile. You must also have an app of calculating EGFR. By downloading this EGFR calculator, you can just put the age of the person, the sex of the person, and serum creatinine, and you can find out the exact EGFR by these calculations. So, having talked to you about the etiology and the trajectory, are there any actual people come and ask you, Dr. Saab, what is your medicine? What is the nephrologist medicine which you are writing? Ye to sugar ki bimari hai, ye to blood pressure ka ilaj hai, this is something else. Is there any actual medication which can prevent the progression of chronic kidney disease? And today, in my API JAPI journal, there is an editorial written by me on retarding chronic kidney disease progression, which is getting published today. Do we have a choice? And it is based on one of the original articles written by one of the authors from Kolkata regarding evidence of some particular drug. We'll talk about it on the prevention progression. So what is the main goal of therapy, or at least our strategy to delay the progression of disease, is to prevent cardiovascular deaths by focusing on cardiovascular morbidity, treatment of disease process, the blood pressure and the blood sugar control, and avoiding nephrotoxic drugs. As I said, giving one NSAID to a patient with creatinine of 2.5 is going to be much more harmful than you are trying to control his blood pressure. So what is important is to have a comprehensive control. You can't have a one-task approach. We will have to combine a lot of things together. We'll have to spend time to talk to him about lifestyle changes. We'll have to spend time to tell him about how quitting smoking and helping preventing the progression of CKD. We'll have to tell him how not chewing tobacco can also help him. So this has to require, this will require a multidisciplinary effort involving primary care physician, kidney specialist, endocrinologist, cardiologist, and dietitian. And we'll have to have a combination of physical therapies like exercise, nutrition, smoking cessation, lipid management, glycemic control, blood pressure control, then the drugs, and finally the antiplatelet agents. All these need to be addressed, ranging from these factors, and this will depend on the severity of kidney disease, which will need to be modified. Now, first and foremost important thing is do no harm. Let's not try to push a patient into further progression by avoiding giving drug-induced, causing drug-induced nephrotoxicity. Dr. Anirban Dawgali, again, one of a Bengali student whom I had, and I'm very privileged that he's now a senior nephrologist in USA. We've written an article together on drugs and kidney, and we are going to rewrite that article again after a span of 15 years to come out with certain new drugs which can be. We keep on talking about Ramdev causing this, other allopathy, other pathies causing this, but we have plenty of drugs which can actually cause damage to our kidneys. And we need to understand that any patient whose age is more than 60, who has diabetes, who has a drug interaction synergistic with nephrotoxic effect, who has exposure to multiple or high doses of nephrotoxin. We talked about Ambisome and how the WHO has described the way you should give an infusion to avoid nephrotoxicity. And of course, a person with multiple myeloma, a person with sepsis, or the person with volume depletion, these are the patients who are likely to deteriorate or have an adverse impact due to NSAIDs. Otherwise, taking an NSAID in a young, healthy adult may not be detrimental, may not harm you at all, but the same can happen, have an adverse thing. Second is the radio contrast. Again, it is similar. A person who is 60, who has diabetes, who has a creatinine of 1.5 is more likely to have damage with the contrast-induced nephrotoxicity as compared to a young adult who is undergoing a CT scanner, who is non-diabetic and hypertensive. So these are some of the risk factors: pre-existing renal insufficiency, diabetic, cognitive, congestive heart failure, hypertension, anemia, metabolic syndromes, hyperuricemia, and this is a pathogenesis. There is an oxidative stress, there's inflammation, there's apoptosis. So we need to understand that personal hydration. Ideally, a patient who is undergoing a DAS should be given hydration therapy. But if the patient is already in heart failure, then we have to reduce the dose of hydration as well. Instead of 120 ml per hour, we need to give it 60 ml per hour. So it has to be a personalized hydration. Pharmacological prophylactic agent, not much of a evidence, but remote ischemic preconditioning. These are the strategies which we need to employ to prevent contrast. What are the guidelines for slowing kidney function decline in patients with CKD? Well, there have been various guidelines. They have talked about blood pressure control. KDIGO has come out with 2012 and now 2021 guidelines. They've talked about blood pressure control. They've talked about how RAS inhibition not only can control blood pressure, but can also cause reduced proteinuria. They also talk about glycemic control, what should be the HbA1c target, and they've also talked about diet management. Then these various other guidelines have also talked about similar control. Now let's first come to blood pressure control. Now, there have been various trials, right from MDRD trial to Renin trial to SPRINT trial. We know about SPRINT trial very well. Then there's been ASSK trial and ACCORD trial. All of them have talked about renal protection and cardiac protection. So the important thing is to keep the blood pressure as near normal as possible. The earlier guidelines were less than 140/90. Then came the guideline that if you have a proteinuria, then reduce it to 130/90. But now recent guidelines have said keep the blood pressure, especially after SPRINT. They have said that the blood pressure control should be as near normal as possible to possibly around 120/80. And among all the other medications, probably renin-angiotensin system inhibitor should be a part and parcel of any patient who's got diabetes, who's got CKD, who's got hypertension. Avoid a combination of the drugs, and they are of course contraindicated in pregnancy. Next to ACE inhibitors in ARBs, if your potassium is not an issue, then probably mineralocorticoid receptor antagonists have emerged as one of the key drugs which can help you prevent the progression of CKD. And there are certain newer evidence of which has emerged to describe the same. Now, one important thing which is invariably asked is, So when I ask start ACE inhibitors ARBs, there is a problem of high creatinine and there's a problem of hyperkalemia. So please understand, this is one of the very good slide of showing you the monitoring of serum creatinine potassium levels. Now, every patient who's on ACE inhibitor ARB should be monitored for serum creatinine and potassium within 2 weeks of starting. Now, you can have 3 effects. You can have normokalemia with less than 30% increase in serum creatinine. We can gradually increase the dose in such patients. Patient can have hyperkalemia. What is important is review the current drugs. Is the patient on any drug which is further causing hyperkalemia? Consider the use of diuretics, soda bicarb, or exchange. Don't stop ACE inhibitors just because the patient has hyperkalemia. Give him a low dose of diuretics. It will decrease the diet in such a way that his potassium levels are. But if the patient has more than 30% increase in creatinine, then of course we have to review for causes of AKI. We have to correct volume depletion. We have to reassess concomitant medication. And we have to consider whether this patient has a bilateral renal artery stenosis or not. Then we should reduce or stop the ACE inhibitors ARBs. In such a situation, we should not stop. We should in fact continue to increase. Now, as I said, this was the recent study which was published in 2015 to talk about effect of finerenone on albuminuria in patients with diabetic nephropathy. And this was done in almost more than 1,000 patients. The hyperkalemia was less with this drug. And this drug showed that giving finerenone, that is mineralocorticoid receptor blockers, can help you prevent the progression of CKD. Second is a lot of things have been talked about glycemic control. The problem of HbA1c in CKD is manifold. There can be falsely elevated HbA1c because of the hemoglobin, because of carbamylation, because of uremia, because of metabolic acidosis. On the other hand, falsely normalized HbA1c can be because of shortened lifespan of RBCs, accelerated erythropoiesis, and frequent transfusions. So we need to take it with a pinch of salt. In CKD, we need to be careful and have a personalized approach. What is important to us to have a strategy? Can we target less than 6.1%? Yes, in a patient whose microvascular complications are not there, whose severity of CKD is mild, who does not have comorbidities, who has a long-term life expectancy, and who has hypoglycemia awareness present. So these are the patients where we should target for strict control. On the other hand, a patient with CKD5, a patient has severe hypoglycemia, a patient does not have an awareness, a patient's propensity to treatment to cause hypoglycemia is high, there the target has to be lower. So every patient has to be individualized. And these are some of the newer molecules or newer factors which has come. How to multi-dimensionalize the predictors. Now we know about age, HbA1c and this. Now we have certain newer inflammatory markers which have come up. We have also markers for kidney fibrosis. We have marker for kidney injury, and we have marker for advanced glycogen pathways. Of course, these are the markers which are still experimental, but very fast you're going to have a computerized based precision model which will tell you about what drug need to be given to such patients. As I said, glycemic management should consist of lifestyle. We all agree the first drug of choice has to be metformin. But after that, the recommendations have clearly given a second line drug as a sodium glucose transporter inhibitor, SGLT2 inhibitors. And if the blood sugar are not controlled, then GLP-1. Of course, in India and such sort of patients, we need to understand that these drugs are a bit costlier. We need to individualize the treatment. EGFR more than 30 ml, we can continue with all these drugs. Of course, the dose of metformin needs to be reduced, and we should ensure that patients are not vitamin D. A word about SGLT2 inhibitors. Apart from its anti-hyperglycemic effect, there are significant amount of changes which it brings about by decreasing the blood pressure, by inhibition of tubuloglomerular feedback, by proximal tubule decreased sodium reabsorption, by decreasing tubular inflammation. It causes a global kidney protection. Number of studies have shown a kidney outcome which are much better with SGLT2 inhibitors. It not only decreases the afferent arterial constriction, it normalizes GFR, so it causes some hemodynamic changes, decreases the global GFR, resulting in significant amount of cardiovascular and kidney benefits. And there are certain days which we need to withhold SGLT2, especially when your patient is very critically ill, is undergoing surgery, is fasting. But definitely we can continue SGLT2 inhibitors still around GFR of 30. And we need to be understanding that this is backed by a strong evidence of Credence trial, which has very clearly shown that superiority of it to placebo and in CKD patients, and also this drug may be considered routinely among similar patients of CKD. And another important molecule, but very costly, I do not personally prefer it, but those who can afford is the GLP-1 receptor agonist. They are, of course, short acting and long acting. We have once a week also drugs available. They have also been found to be, one of the key drugs which can not only control blood sugar, but also prevent the progression of chronic disease, which is what my topic was today. And DPP-4 inhibitors are also kidney neutral. They can be given even in the presence of low GFR, but the dose needs to be reduced. And this was the editorial written in 2020, and they have clearly shown that GLP-1 receptor agonist has commenced and will answer a question whether drugs will be effective to reduce diabetic kidney disease or not. So in summary, as far as diabetes is concerned, of course, physical activity, nutrition, weight loss, and metformin, the first drug, and addition of SGLT2 inhibitor. This is the second line drug, evidence-based. I do not say that we should do it in all patients, but evidence-based, and followed by either GLP-1, DPP-4, insulin, sulfonyl type, thyroxolidine. This should be guided by patient preference. And this is what is the model which is brought by RSSDI. They talk about patient factors, and we should always look at patient's pocket and patient's money. And these are the factors which will influence selection of glucose-lowering drugs other than SGLT2 inhibitor. And if the patient has heart failure, then probably we need to avoid these drugs. If the patient has a high risk as atherosclerotic disease, then maybe GLP-1. If we want to avoid hypoglycemia, then give these drugs which can cause reduction. After having talked about blood pressure and sugar control, the third and most important factor, that was so-called kidney drug, is trying to control metabolic acidosis. I remember my teacher, Dr. Rizvi, used to give pulse soda bicarb, and we never used to understand why is he giving that. But now, a very strong evidence to suggest that by giving just a tablet of 1.5 to 2 grams of soda bicarb in a patient whose serum bicarb level is less than 22 microgram, can help him preventing the progression of chronic. And these are some of the factors. CKD progression causes increased acid load, it increases endothelin levels, it increases angiotensin level, and that can cause host lot of factors which can further progress the progression of chronic kidney disease, and also may progress. So by giving a tablet of soda bicarb, we can always try to ensure, and there have been a meta-analysis of more than 14 trials which have shown that not only metabolic acidosis is a risk factor, but when given to a patient whose serum bicarbonate is less than 22 microgram, it has shown that it has been found to be a very, very effective tool, and all the evidences suggest that this drug is supposed to be the most effective drug for intervention by a nephrologist, oral alkali supplementation, or a reduction in dietary acid intake may slow the rate of kidney disease. This is one drug which a nephrologist can claim that this is a drug which one can use. Of course, coming to the lifestyle intervention, I think it's extremely important. I'm very sure must have had a heavy and hefty dinner yesterday, and you're going to have a lunch. But more important is to your tummy, your plate should be half full of fruits and vegetables, and 1/4 of a protein, and 1/4 of a whole grain and starchy vegetables. And in terms of chronic kidney disease patient, we can have certain strategies where we can give them a low protein diet or a very low protein diet with addition of keto acids and amino acids. This has been shown in certain evidences, certain strategies to prevent the progression of chronic kidney disease. It should be lower in processed meats, in refined carbohydrate and sweetened beverages. One of the, I think I agree with one thing about Ramdev is he calls cola as a toilet water. And I also call cold drink as a toilet water. It does much more harm than actually what it does. And this was one of the study published recently in 2020, again talking about low protein diet from chronic kidney disease, 8 years of clinical experience. And they concluded that a low protein diet recommended by nephrologists in conjunction with skilled dietitian delays dialysis and preserves. So it is extremely important to first assess the dietary intake. Most of our Indian patients, I don't know about West Bengal people, because you eat a lot of fish, but most of the Indian patients are already on low protein diet, so we do not need to restrict them further. Our progression should be much less. Talking about salt, now people ask me how to reduce salt, how to reduce salt. So these are some of the ways and means by which you can reduce the salt intake, and buy fresh vegetables, cook at home, avoid salty processed meats, keep healthy unsalted snacks, cut salty sauces like soya sauce, which has full of salt, use sweet, sour, bitter and spicy or hot flavor to season food instead of salt, read tablets, choose lower salt brands when possible. So these are some of the strategies which can help you reduce the. Now there are certain more strategies. I don't know how much time do I have. I'll have just 5 or 10 minutes. What is the effect of ketonologues? Now again, a very, very costly drug which is being given. I don't want to name the brands, but these are given in the dose of 2 TDS. The evidence is there, but evidence is not very strong. Now, if you look at the patient's pocket, and if the patient's pocket cannot afford ketonologues, then we can at least put the patient on low protein diet. And this is again the study done from India, from SGPGI. They did demonstrate that it may help you prevent decline in renal function, but the evidence is not very strong. Similarly, a role of probiotics. People give a very costly probiotics to another, adding pill burden to CKD patients. Role of probiotic in CKD is not clearly defined. So as of now, the evidence is only for soda bicarb, only for treating sugars, only for treating high blood pressure, nothing else. And this was another study which was shown. There was no evidence suggested that probiotics possess meaningful impacts on the reduction in the uric acid level. Now, this is the study which I was going to talk about. This study was published from Kolkata. Is N-acetylcysteine taurine a protecting agent? NephroSafe, the drugs look so, even yesterday night, one patient texted me that my doctor has put me on NephroSafe. Is it really going to save my nephros? So this was the study done by your colleagues from Kolkata, and this will be published in this this May issue of API. They did show, but the numbers were very small. I have criticized this study in my editorial. The statistical tool used were very, and as I mentioned, I have clearly mentioned about my conflict. They have not mentioned whether this study was supported by the company or not. They showed that N-acetylcysteine along with pyridoxine, that is NephroSafe.
Excuse me, sir.
May be useful.
You are very late. You are very late. You have already.
Ma'am, I was told half an hour. I don't.
No.
The last slide.
Already completed.
Okay. I still have 8 minutes. Started 12. Anyway, so these are some of the studies which have shown. The last study is on uric acid. Now the study is again whether to give febuxostat or Zyloric in such patients or not. There are it is still a controversial thing. And finally, what is more important in preventing the progression of chronic disease is to prevent infections. So we must vaccinate these patients. This is the strategy which is developed by Indian Society of Nephrology. All patients of CKD should receive hepatitis B vaccine, a pneumococcal vaccine, a varicella vaccine, of course, a diphtheria and tetanus toxoid vaccine. And we should always involve the nephrologists. They should work synergistically. Any patient who develops a GFR of CKD stage 3 or above should at least once be referred to a nephrologist. As the patient safety is first, don't keep the patient with you for a long time. Combine the management with the nephrologist. And this has been shown that patient safety and following CKD detection, if we involve the nephrologist, then probably the progression can be much delayed. And these are some of the standards of care for therapeutic management. As I said, there are certain newer molecules in the pipeline which can help you prevent fibrosis. We know these drugs are being used for COVID patients as well. There are certain drugs for antioxidative stress. There are anti-inflammatory drugs which are being used. There are single transduction pathway vasoactive agent and new molecule. So I think it is very important for us to guide our patients well, so that finally we are able to prevent the progression of chronic. Thank you very much. And I'm really sorry if I exceeded the time, but I've just finished 23 minutes, started at 12 o'clock. It's 20.
Thank you, Dr. Singh, for your excellent lecture. You have already answered all the questions which are coming to our mind.
If there are any 1 or 2 quick questions, I can answer. Otherwise, we can. Yes, sir. Any queries or any questions?
One question. Allowed. One question.
For CKD diagnosis, which is important, creatinine, serum creatinine or spot urine ACR? Or
Spot?
ACR,
Yes.
albumin creatinine, which is both.
All the three are same. If you want to do a 24-hour collection, then 24-hour proteins. If you want to do an ACR, it is albumin to creatinine ratio. We know that there's a fixed amount of creatinine gets filtered through the kidney every day. That is around 1 gram. So when we talk about the ratio, the less than 30 milligram is normal, 30 to 300 milligram is moderately, and more than 3. So we take into account a value of serum creatinine because we have to calculate eGFR, and we also talk about albumin. Based on albumin and value and the etiology, we give a final diagnosis of diabetic kidney disease, GFR stage 3B, albuminuria A2 category. That is how we write.
In CKD, vegetable protein or animal protein friendly?
So vegetable protein friendly, but some amount of almond protein diet can be. Thank you. Thank you, sir. I'm sorry for extending the time.
Next. Dr. B.D. Goswami, please. Please come to the dais.
Respected chairpersons and my friends, at the beginning, I must thank the organizing committee for inviting me to speak before you. I was asked to talk on this particular subject, incidentally detected asymptomatic hepatitis B surface antigen positive subjects. So what to do? It is a real problem, and I have to start with a real patient. On 3rd of June, 2015, 29-year-old male, non-diabetic, non-hypertensive, he went for a blood donation camp. And as usual, he was checked for hepatitis B, and it is positive. So then starts everything. Whole problem, we have to take the history of jaundice in the past. It was negative. Family history of hepatitis B, hepatitis C, it was negative. History of any surgery, as usual, you have to ask, it is negative. No dental procedure was done on him. Commercial barber used frequently, no. Blood transfusion history, no. And even there was no sexual contact of this person. So definitely it is an incidentally detected hepatitis B surface antigen positive subject. So what is, by definition, what we say about it? This is the definition. An asymptomatic individual, when he is detected with hepatitis B surface antigen, and that's on a routine blood test or screening. So that is by definition. But once the person is picked up, the question starts, how it is picked up usually. So usually blood donors, as in this patient, and most of the time is a health checkup. The health checkup may be usually annual health checkup, sometimes pre-employment health checkup, pre-operative health checkup, visa checkup, or sometimes for antenatal checkup, or even nowadays anywhere in hospital before admission, they used to check for Hep B, Hep C, or retrovirus. You have to check it. So point is, once somebody is diagnosed hepatitis B, it is a big issue. Big issue means there is distress of the patient or the family members because they think about the social stigma, they think about the cost of the whole therapy of hepatitis B, Then there is a question of the almost regular visit to the doctor. So all these issues come to the mind of the person. So it is a big psychological problem as well. So usually, whom to check for hepatitis B virus? Usually, this is the group, high risk group of patients, acute viral hepatitis, any chronic hepatitis patients, any family members, if somebody has got in a positive hepatitis B surface antigen or hepatocellular carcinoma, if we get, we have to check for Hep B. So basically, this is a spectrum of the disease. At one end, there is a incidentally detected hepatitis B surface antigen positive person. At the other end, what we have got, it is the hepatocellular carcinoma or chronic liver disease. That's how actually whole spectrum liver around. But very fact we have to remember is almost 20 to 30% of this group of patients incidentally detected ultimately end up with the chronic liver disease or hepatocellular carcinoma and causing almost 650,000 of people dying annually all over the world from hepatitis B. And very interestingly, majority of these patients are unaware that they have got this virus in their body. So what happens in acute viral hepatitis? It comes to any person, hepatitis B. So mostly they recover. Sometimes it will go for acute viral hepatitis, fulminant hepatic failure, 1% of the patient, and few percent of the patient will go for chronic liver disease. So this chronic liver disease may be again, if it continue to be for more than 6 months. So then they may sometimes have inactive, or it may be an active one. If it is active one also, again it may be E negative or E positive group of patients. This is important. Why? I'll talk about it later on. So it is a fact today, if a person has got the virus coming to him at neonates or the childhood, it will continue go for the chronicity very high, almost 90%. But if somebody has got at adulthood the virus, only less than 10% will go for the chronic liver disease. That fact is very important for all of us. But once it is established that it is a just incidentally detected, we should not forget that it is asymptomatic, of course. That does not mean that it is absence of the disease. And that's why all these patients should be critically evaluated time to time so that we should know about the condition of the problem. This particular slide is very clearly showing that even in those patients, clinically normal, absolutely normal, and biochemically ALT/AST is also normal. But the histology will show that almost 50% of them may have some sort of microinflammatory changes in the liver. So that's why the evaluation is very important for all of these group of patients. So what is the aim of the evaluation? To assess the stage of the liver disease, to assess the activity of the liver disease, and also to assess the viral status of that particular person. So that's why all the patients who have got incidentally detected, we should work up, follow up. What we should do? We should see the clinical course of the problem, jaundice, ascites, or any bleeding, whether they have got or not. You do the liver function test properly. You do an ultrasound to see the diameter of the portal vein ascites, nodular area of the liver. And you do fibroscan if possible, and nowadays everywhere it is possible to check the fibroscan. And sometimes you have to do the scan, CT scan, to see the liver. And also for further, biochemically we should check this group of patients with E antigen, with DNA, quantitative of course. You do an endoscopy to see whether varics are there or not, so that we should know chronicity of the problem. And in certain patients, probably we should go for the liver biopsy. The evidence of chronicity, how we'll know if there is ascites, splenomegaly, there is ultrasound, clear, picture they will show, is low albumin, or if there is hypersplenism, it means the chronic disease. But of course, from the liver biopsy, you can confirm, or for endoscopy also, you can confirm that there is varices, means chronic case. So coming back to our patient, what happened to that particular person? So on 5th of June, he consulted the family physician. Of course, the family was, as a whole, very much concerned about. So they went to a family physician, and he was prescribed immediately Arsocol, B complex, and the entecavir. Entecavir is the antiviral treatment for Hep B. So my question immediately, and all of you should ask yourself, is it justified to prescribe an antiviral to anybody if it is positive hepatitis B? It's a big question. All of us, we should ask ourselves before prescribing it. And he was very much confused because he went to the pharmacy and it is a very costly medicine. So he thought that, okay, let's have a second opinion. He came to me with gastro consultation. For the gastroenterologist, it is again coming as a dilemma. Why? Because to stop the entecavir, the antiviral drug, or to continue the entecavir. If I stop it, he will go back to the village or where from he came and ask that doctor, and some confrontation may be, it can happen. But the person himself, he did not started the medicine, so that's why it was easy for me. And I am describing here what we should do when somebody is coming to you with hepatitis B positive patient. If it is, you ask yourself what to do, and this is what we should do. You do a detailed examination, detailed history, advice for the family member. This is important because you ask the patient to check all the family members for Hep B. If it is positive, treatment has to be done. If it is negative, all the members should be immediately vaccinated so that it is not transmitted. You ask the patient not to donate blood in future because he already has got the positive test. Then, of course, you do the proper counseling of the patient, what he should do, what he should not do in his whole life. And also the family members should know about it as a detailed counseling. This is the picture of a family. The parents as well as the two kids came to me from Arunachal Pradesh, and all of them are positive for hepatitis B. But very interestingly, the person, the father, he got the diagnosis almost 15 years back, Hep B positive. But unfortunately, the doctor who started the treatment for the person, he did not explain everything to the family. The family was not vaccinated at all, and subsequently, that's why whole family is suffering today with Hep B. You see this picture, this picture showing 10-member family. One of them came to me and subsequently I checked, whole family today, two of them already died from Hep B cirrhosis, 3 of them on observation, and rest 5, they are on treatment for Hep B. Again, the similar picture. The concerned doctor, the first, did not told about the counseling, vaccination, and all these issues were not discussed. Even 2 cousin brother of the person who came to me also died from this particular Hep B. So what we should do in this case, and that's what I did. I did the LFT, antigen, DNA, and also the IgG and IgM antibody. I am showing the genotype, but sometimes you can miss it also for Hep B. It is not so much important. It is a costly thing to do. You can skip it, there is no issue. But the rest of the things are very important and we should do. So if a person has got Hep B, if it is positive, then what we should think of immediately, whether it is an acute case or whether it is a chronic case. Why? Because we have to treat or we don't have to treat. So this is a big issue and we should resolve it. In acute hepatitis B, what happens? Actually, basically, it is recent exposure, jaundice, and if ALFT, mainly ALT-AST is more than 500, means it's a acute viral hepatitis. And what is chronic? Is a chronicity more than 6 months if it is continuing. Is a chronic liver disease, and chronic liver disease may be again with liver disease or without liver disease. Positive may be there, but the signs symptoms of liver disease may not be there, or with may be there. So this is very important because your line of treatment will be decided on this one. Here, who to treat? Already I asked, is it justified to put the antiviral drug to anybody having the virus positive? So here we'll find the question and when to treat. Here, acute viral hepatitis, very clear, we should not have any doubt about. If it is acute viral hepatitis, no treatment required. You just follow them up. If it is chronic hepatitis B with liver disease, then treatment is a must. We have to treat the patient. But if the patient has got chronic hepatitis B, but without liver disease, what I showed earlier, then again, we should follow up. Don't treat him. So how can you know that it is acute or it is a chronic? Again, if the IgM antibody is positive against core antigen, so that is your acute viral hepatitis. If the IgG is positive, then it is a chronic viral hepatitis B. So from here also you can identify whether it is acute or it is a chronic case. So on 14th June, this man came to me, so we did the checkup. LFT normal, E antigen negative, IgM is negative, IgG is positive, and DNA is 20 ml. It's very low DNA level. But here it is very clear, IgG positive means it's a chronic case, but he does not require treatment because why? Probably I'll talk after 2-3 minutes. What is next? Any more investigation we need it in this case, in this person, or we'll treat the patient, or we'll follow them up. So always you justify what you are doing. Let us see what we should do. You follow up. The question is how to follow up, for how long to follow up, at what interval we should follow up. This is the answer here. Every 6 months we should follow this up. Usually it should be done every 3 months. But point is, in India, it is not an easy job. It is a costly test have to be done. So later, probably we can do it every 6 months. And what we should do, you repeat these tests. Surface antigen, E antigen, quantitative Hep B, alpha fetoprotein, portal hypertension. You do a fibrosis scan to see whether they have got fibrosis or not. At least we can do this thing easily nowadays. After 6 months, again, I asked the patient to come for follow-up. He came. This time, what is the result now? Surface antigen is positive, ALT-AST normal, but his DNA is below 20 level. So again, it is very low. We don't have to treat. So I'm just giving the question, should we treat them? I think no. Why? We'll talk later on. So after that, I lost the person for checkup. So after 3 years, he came back to me again. This time, ALT-AST is normal, but his DNA level is 984. So it is not normal, but higher. But whether it required treatment or not, that is another story. So will you treat? Yes, again, probably no. Why? You can know after 2-3 slides. So after 6 months, Again, he came back to me for follow-up, but this time you see his ALT, AST is quite high, and of course his DNA level is now more than 1 lakh, so very, very high. So next, what to do now? So will you treat now? This is my question. Any investigation we will go for? Probably ultrasound will be required, endoscopy will be required now because it is already a chronic case, high DNA level, ALT/AST is definitely a higher one. So liver biopsy, yes, in some cases, not all the cases, liver biopsy is required. So alpha fetoprotein, yes, all these patients should be done alpha fetoprotein because the hepatocellular carcinoma is always very, very high. We did the ultrasound, it is normal. Then we did the endoscopy. No, it is not working anyway, you leave it. We did the endoscopy, it was also, it is a normal endoscopy, it is not a problem, there is no berries, so this is not cirrhosis. But we did the fibroscan, and this is the fibroscan 26.8 score. That means it is an advanced cirrhosis of the patient. Now this patient is a cirrhotic patient, Hep B related one. So there is no question. We started entecavir 0.5 milligram daily. It is the normal dose for him. So next question I am giving, so when to treat? All of us, we should be very clear. When to treat, always look for the ALT level, look for E antigen, also look for the DNA level, the quantitative DNA. So because if the patient has got Hep B positive and E antigen is positive, this is one group of chronic liver disease. So ALT is 2 times of the upper limit of the normal. I'll be finishing within time. So DNA level is more than 20,000. You have to treat the patient. There is no doubt about it. If the ALT is not 2 times, but normal level, but your DNA is also less than 20,000, you have to follow them up. If ALT is in between the normal level and less than the 2 times of the upper limit, and DNA is less than 20,000, again, you should wait, or you can go for liver biopsy also. If E antigen is -1 here, the ALT 2 times of the upper limit of the normal, but the DNA level is not 20,000 as in hepatitis B antigen positive. Here 2,000 is the limit. If it is more than 2,000, you have to treat the patient. If DNA is negative, E antigen negative, but the ALT is normal and DNA also less than 2,000, you don't have to go for treatment, you just wait and follow up. If it is in between, you can go for either liver biopsy or you can go for follow-up. This is another story. The patient with the abdominal distension, presented with upper GI bleed, Hep B positive, and on endoscopy, sorry, it is not working probably. So it is a decompensated or compensated cirrhosis. So cirrhosis, if person has got cirrhosis, Hep B, 2 things, either decompensated. If it is decompensated, there is no Hep B, DNA level or anything else, directly you go for the treatment, there is no question about it, or you put the patient for liver transplant. But if the patient is compensated one, so instead of 20,000, you have to think of the 2,000 only. DNA level 2,000, you have to go for the treatment if it is more than that. So this is another scenario, that's why I am putting this slide. So why to treat? Because of this one, from acute viral hepatitis, chronic viral hepatitis, it will go for cirrhosis, it will go for liver failure or your HCC or the patient will die. This is the scenario. That's why all these things what I have mentioned, we have to treat the patient. So there is also the risk of progression of the disease. This is the detailed slide. I'm not
Dr.
going to detail.
Goswami,
Yes, I'm
please
finishing one or two
conclude.
slides. So if also we should remember, there is no cure of hepatitis B. We have got some medicines, of course, but these medicines options are there. This is the medicines. I'm not going to details about it. All these options we have got, and we have got the latest medicine, tenofovir alpha-phenamide. One tablet we can continue for almost lifelong. We can treat this patient. So in conclusion, hepatitis B infection is a global health problem. It is associated with fibrosis, cirrhosis, and liver cancer. There is no cure for Hep B, but there is a treatment option we have got. The goal of the treatment is to suppress the Hep B infection and prevent further liver damage. Successful disease management will involve the partnership between the doctor and the healthcare professional as well as with the patient or patient family. And timely referral and family counseling is key for the management. So another on this group, the conclusion, most of these groups who have got accidentally detected hepatitis B is a benign course. Mostly careful evaluation is important with ALT, E antigen, DNA level. Counseling is most important one. Already I have shown the issue. And when there is a doubt, always take a second opinion or a consultant. Thank you. Thank you.
Thank you, Dr. Goswami. As both of these speakers will catch their flight, so felicitation of them will be now, and after that, Dr. Ghoshal will be continued.
May I request Dr. N.P. Singh, please come over the dais.
Dr. B.D. Sharma. Dr. B.D. Goswami, sorry. Let's now move on to the next session and to the last part of the, yes. So let's now move on to the next speaker of this session, and I invite Dr. A.G. Ghoshal, who is a well-known face, to present his presentations on allergic and non-allergic rhinitis in adults. Dr. Ghoshal, please.
At the outset, I express my sincere thanks to the scientific committee for asking me to act as one of the chairperson. The topic is very important for this session, and particularly in relation to climate change and environmental pollution. The topic is allergic and non-allergic rhinitis in adults. And the speaker is Dr. A.G. Ghoshal, who does not need any introduction to this August gathering, as he has given several lectures in the API Forum of West Bengal branch and also in the various test meetings at Calcutta and also outside Calcutta, and also by Indian College of East Asian deliberation analytic rhinitis in adult.
Before Professor A.G. Ghoshal starts, one announcement, please. The PGTs, those who are interested or joining to quiz competition, please contact Dr. Adanu Chandra or Dr. Uddalak Chakraborty. Please contact Dr. Adanu Chandra. Please, sir.
So, good morning, everybody. So after CKD and chronic Hep C, allergic rhinitis, I had a debate with Partho that very few among these could be interested in rhinitis. He assured me all of them are really patients of allergic rhinitis. So they will listen very carefully. But me, I am not an allergologist. So a clinical pulmonologist like me, my window to the world is clinical research. And I welcome you to this. So this was the Abbott study, Asia Pacific burden of respiratory diseases. And as you can see, these 6 countries took part: Singapore, Taiwan, Malaysia, Thailand, and our institute, NOBI, National Allergy Asthma Bronchitis Institute, Kolkata, represented India. We were the chief investigative center from India in this Abbott study. This study gave us 8 international papers in, just name it, any journal, including Lancet, and 1 national paper. I'll come to that later. Asia Pacific burden of respiratory disease study, Abbott, and practically we got 4 diseases there topping the list: asthma, allergic rhinitis, chronic obstructive pulmonary disease, and rhinosinusitis. There are some secondary objectives, the proportion of the patients and others, but the chief purpose was this: to describe the healthcare resource use and work loss associated with these diseases, and also to describe the disease-specific health-related quality of life for the primary diagnosis, that is asthma or rhinitis, COPD or rhinosinusitis. This was the national paper published in Lung India from our institute, and it was awarded the best paper for that year. The burden of segregated respiratory diseases in India and the quality of care in these patients. And there have been multiple citations of this study in various, even in GBD, Global Burden of Disease Study, there is citation of this paper. So consecutive patients were taken without any choice. That was the protocol. And about 1/3 presented with the primary complication of condition of allergic rhinitis. And you can see the compositeness there. Practically there were combination of allergic rhinitis with COPD, with asthma, with rhinosinusitis, with multiple comorbidities. And 80% patients presented with the combination of asthma and allergic rhinitis with or without other conditions. And rhinosinusitis was the least frequently diagnosed, but even in there, 55% were also diagnosed with allergic rhinitis. Epidemiology of air in India. So limited data before this study on the burden of respiratory diseases, but approximately 55% of all allergies seen in India are attributed to allergic rhinitis. It's surprisingly common. 30% of adult patients receiving care for respiratory diseases had air, and it is the second most common reason for adults seeking care for respiratory disease, the first being asthma. But come to this. This is interesting. Healthcare resource utilization. We recall the last 4 weeks before the visit, how much healthcare resource use was there. And you can see very few went to the specialist. So all of us sitting here, see very few minuscule percentage of these patients. Most of them go to GP, as you can see. I don't see the cursor here. Yes, GPs. But again, for allergic rhinitis, they don't even go to the GPs. They go to the pharmacist, that is the shop owners, the medical shops, and they just consult them and buy the drugs from there. Less than 10% of patients ever go to a specialist. And also, this is such a chronic comorbidity. There is very few hospital or emergency data on this. Hospital or emergency data is available for COPD and asthma, none for allergic rhinitis. So patient presenting with the symptoms, as you can see, sneezing, the big chunk, then watery runny nose, then the very serious one, reflecting the cognitive dysfunction and quality of life is blocked nose or congestion. And of course, there are others, including headache, sore throat, and go down below. Cough is an impressive symptom for allergic rhinitis. The medications prescribed, maximum was oral antihistaminics. And you know there are newer generation of antihistaminics, including fexofenadine, then others have already come. Liquidity receptor antagonist, will come to them later. Lot going to alternative or traditional medicine, oral decongestant, and only minuscule, less than 30%, taking steroid nasal spray. So, guidelines have classified allergic rhinitis as intermittent, that is 4 days and 4 weeks, or persistent 4 days and 4 weeks. But there is another classification known as seasonal and perennial. Outdoor allergens such as grass and tree pollens are normally the main cause for seasonal allergic rhinitis. So outdoor allergens, seasonal allergic rhinitis. Indoor allergens, predominantly house dust mite, perennial allergic rhinitis. Difference of prevalence in rural and urban areas, but early life is very important. So exposure to farm animals during pregnancy had a protective effect against allergic outcome in infants. And cesarean section was associated with food allergy. So early life events are important in developing the allergic reaction for the rest of the life. And air pollution, as you know, is important. But what is important? Air pollution has two effects. One is the transient, raised air pollution, more symptoms. But the another problem is in the early life, when the immune system is plastic, any assault can make a lasting imprint. Once the clay dries up, this imprint persists for the rest of the life. This is epigenetic, and this is due to DNA methylation. So here is the summary. There is a genotype, there is the environmental assault, but what in between is the epigenetics. That means the permanent DNA damage, which is not part of the inheritance. But this microRNA damage, DNA methylation, produce lasting damage to the immune system and hyperreactivity for the rest of the life. And what we get histologically there, increased epithelial permeability and defective epithelial barriers. Climate change contributes. Climate change contributes in two ways. Number one, the air pollution themselves. Number two, the pollutant particles, the microns, they themselves act as carriers on which the allergens, pollens, etc. can stay suspended in the air for quite a long time and cause detrimental effect. The multifactorial part we know of the inflammation in allergic rhinitis, early phase, late phase, there is increasing vascular permeability, cellular infiltration, but lately the awareness has been mostly due to the neurogenic inflammation. Neurogenic inflammation causes persistent nasal hyperreactivity even in absence of allergen triggers. And the reported prevalence of neurogenic hyperreactivity in allergic rhinitis is more than 60%. So what happens is, due to this neurogenic hyperinflammation, modulation of sensory perception, chronic upregulation of neural function, neural hyperresponsiveness, ultimately leading to neurogenic inflammation. And the most vexing problem, I'll come to this, the physical obstruction of the nasal passage. So sneezing or rhinorrhea are transient processes, but once this physical obstruction develops, it's a persistent phenomenon. Engorgement of the nasal venous sinusoids, swelling of the anterior and inferior turbinates, it's a lasting problem and the real problem in poorly treated allergic rhinitis. Impact of nasal congestion on sleep and productivity, surprisingly dangerous. At least 50% report that congestion makes them wake up during night. There is a relation with asthma, there is a relation with OSA, which is my predominant site of interest in allergic rhinitis. There is a classification. This was an old classification, still going strong, intermittent, mild, moderate, severe, practically a bit theoretical and a little clinically confusing because there are a lot of overlaps between these different groups. So the modern awareness is phenotyping. As we do phenotyping in COPD, phenotyping in asthma, similarly there is phenotyping in allergic rhinitis, predominantly two phenotypes. One is the sneezing and rhinorrhea type, other is the nasal blockage type. So in sneezing and rhinorrhea, it is usually paroxysmal, but the blockers are usually persistent and progressive. And more patients in the sneezers and runners group had seasonal allergic rhinitis. And seasonal allergic rhinitis is usually related to outdoor allergens. And the blockers group has usually persistent perennial allergic rhinitis and usually related to indoor allergens, predominantly house dust mite. Allergic rhinitis and asthma, surprisingly common, underdiagnosed and undertreated. This was one of our papers, allergic rhinitis versus bronchodilator reversibility in the diagnosis of asthma. In our cohort, we saw that we thought bronchodilator reversibility is a sine qua non of asthma diagnosis. You get it only in 40% of asthma, bronchodilator reversibility. Look for allergic rhinitis in Eastern India. There will be more than 80%. We got 90%. So allergic rhinitis is unequivocally present in cases of asthma. And undertreated and undertreatment of allergic rhinitis leads to poor control in asthma. And although genetic sites of allergic rhinitis share the same genetic basis with asthma and allergic dermatitis, allergic rhinitis has its own genetic site. So practically the genes are overlapping but not the same, reflecting the specificity of different tissues to the allergens. A little clinical pulse about this combination of allergic rhinitis and asthma. Allergic rhinitis is an important risk factor for developing asthma and is also an important cause of non-optimal control of asthma. Everybody knows about the allergy march. So practically, we have heard long before, our older clinicians used to say, don't treat the skin problem, you will develop asthma. What happened is actually, this is part of the allergy march. This is a natural phenomenon. It is not that treating atopic dermatitis produces asthma, but atopic dermatitis comes first, allergic rhinitis, and then much later develops asthma. And patients who have more severe allergic rhinitis are more likely to develop asthma. There is a link which has been told that one airway and one disease, but there are some physiological factors why allergic rhinitis predisposes to asthma. One is postnasal drip. Another is the mouth breathing because they have their nasal blocked. And even in non-atopic subjects, a strong association between perennial rhinitis and asthma in non-atopic subjects were demonstrated in the European Community Respiratory Health Survey. Dietary changes do cause exacerbations. Changes in environmental do cause exacerbations. And again, as I said, there is a synergistic effect of air pollution with allergens in the atmosphere. Allergic rhinitis and OSA, surprisingly neglected till now. And it is particularly in the children group. Child is the father of the man because in children group, 80% of our children in India suffer from allergic rhinitis. and their nasal blockage makes them mouth breathers and changes permanently the facial structure so that they develop OSA in the adulthood. So preventing allergy and treating allergic rhinitis in child group is of utmost importance that must be conveyed to the primary care physicians. How does it produce? Allergic rhinitis increases the risk of developing obstructive sleep apnea by two major mechanisms. One is increase in airway resistance. Another is reduction in pharyngeal diameter because of the mouth breathing that moves the mandible inferiorly. And so there is more obstruction there. But there is something more. Why allergic rhinitis predisposes to obstructive sleep apnea? This is Bernoulli theorem. That means as the flow increases, so the negative pressure. So the maximum flow produces negative pressure that is more collapsible of the collapsible pharyngeal airways, which means allergic rhinitis itself is not the major site of obstruction in obstructive sleep apnea. It is the collapsible pharyngeal airways. But what happens is, just see the simile and don't mind the drawing. It is my drawing. So practically when the diaphragm are going down, producing the negative pressure, the air must go in through the nostrils down below. That maintains the balance. But when the nose is blocked here, and then the negative pressure down below, so maximum negative pressure develops here, and with these are collapsible part of the pharynx, further collapsing the pharynx together. So if you diagnose OSA, your patient cannot afford CPAP, at least treat the allergic rhinitis part with nasal corticosteroids. 40% alleviation of symptoms we have noted in our study of OSA only by treating allergic rhinitis.
Dr. Ghosal, just
many?
2
Okay,
minutes,
very good.
please also.
Okay, I will
No,
finish
no,
with you this time.
yes.
Pharmacotherapy, I'm not going to detail, you know all, but the main thing will be there, the steroid nasal spray, with or without antihistaminic nasal spray that is presently agilostine with fluticasone propionate. And selection of pharmacotherapy depends on symptoms, efficacy and safety, speed of onset of action, and most importantly, the side effects, effects on sleep and work productivity. This is the area guidelines. Everybody knows this, allergic rhinitis and impact of asthma. Basically, it is the treat with lifestyle changes first, and then intranasal corticosteroids with or without intranasal antihistaminics. And then you can go for systemic oral antihistaminic and if necessarily oral systemic corticosteroid for a brief duration. Area guidelines, same thing. So combination of nasal antihistaminic and nasal corticosteroid found to be more effective than intranasal corticosteroids alone. But there is a renewed interest in the congestion, the blockage. Practically that is the main source of problem. The rhinorrhea and sneezing is there weeping to the world. Everybody can see. The nasal blockage, they are perfectly symptomless outside, but they suffer the most due to cognitive dysfunction and loss of sleep. Decongestants had immediate effects, we know, but they have been blamed since long that they produce rebound congestion. So, what is the role of ENT people there? Of course, a lot of these allergic rhinitis, we like it or not, they go to the ENT people. And ENT people call themselves more surgeons than physicians. Lot of surgical, mostly the surgical is to relieve any blockage. But video neurectomy was one time very popular to treat that neurogenic inflammation part in allergic rhinitis. At present, allergic rhinitis, the awareness, the lifestyle, intranasal corticosteroid spray, and intranasal antihistaminics. Anything else? Newer drugs coming, but one is allergen immunotherapy, another is biologics. Allergen immunotherapy, I am not an allergologist, but the problem is it's a very long-lasting, expensive affair. And most time allergic immunotherapy is failing because the persistent insult, the patient stay in such a situation, the home, the environment, the air pollution, the dampness, everything together. When you have a persistent insult, it is very difficult for allergy in immunotherapy to give the desired result. And also it's a long-term process, so very low patient adherence. Biologics have come, particularly mepolizumab has got FDA approval for treatment in chronic rhinosinusitis with nasal polyp. So these two new drugs are there. Dupilumab, omalizumab is there for at least few years. Mepolizumab have come for the recent situation. And there is a new awareness here. There is nasal corticosteroids with oxymetazoline so that it takes care of both. This has already arrived in the market. Before concluding, I'll have this clinical pulse in allergic rhinitis. Food allergy testing is not recommended in the routine evaluation of rhinitis. Neither acupuncture nor herbal products have adequate studies to support their use for allergic rhinitis. Oral decongestants should be avoided during the first trimester of pregnancy. Intranasal corticosteroids remain the preferred monotherapy even in non-allergic rhinitis. Cough is a common symptom and impressive in both allergic and non-allergic rhinitis. Montelukast, unfortunately, is not that effective without antihistaminic. Depoparenteral corticosteroids are not recommended. And intranasal decongestant with or without intranasal corticosteroids may have a role for a short duration. I don't know whether any of this information will come to your help in your future practice. Thank you all for your kind hearing.
Thank you, Dr. Ghoshal. As we are running short, we are ending this session here. But Dr. Ghoshal, you please wait.
Thank you, sir. And I would request our chairpersons to please felicitate our speaker, Dr. Ghoshal. Thank you, sirs. And I request Dr. M.K. Rai to please felicitate our speakers. Yes, we are chairpersons. I'm sorry. To Dr. D.K. Majumdar, sir, please. To Dr. Anita Dotto and Dr. Navanita Chakraborty. Thank you, sirs and madams. So now let's move on to our next session. And to chair this session, I'd invite on stage Dr. Debashish Bhattacharya, who is our Honorable Director of Medical Education. And along with him, I'd invite Dr. Shamar Banerjee and Dr. Pradeep Mitra to please come on the dais.
Hey,
Dr. Debashish Bhattacharya, the Honorable DME, sir. Dr. Shamar Banerjee and Dr. Pradeep Mitra.
So we are running late, so directly without giving any preamble, I'm directly calling the speaker. Where is Jogiraj? Jogiraj, yes. You start your deliberation. We are not going to give you any preamble.
Thank you, sir. It's my privilege being here with most of my teachers being here present. Most of the time when I was resident, I used to sit there. Now it's time for me to sit here, to talk here. So it's my pleasure to be here. So this is a topic that Professor Kormakar once called me up and told me to speak on this. And at that time, I just told him, it's okay, I can do that. Then when I started to read on that and gone for various papers, I found basically different thoughts and different thought processes. And our thought processes are actually presented as papers. So it's very difficult topic and abstract topic, what I found later. But I try to tell you what I gathered, and I may be overwhelmed by my personal experience. Please pardon me. So possibility, what can happen to COVID ARDS from now? There may be no ARDS by COVID-19, no more COVID-19 cases as with ARDS potential. Maybe new coronavirus emerge from 19 to make it 22 or 23 or so on, something new. And the ARDS continues. And as a clinician for us, the nightmare continues. Pandemic of COVID-19 may end and it may continue also. So it could be a endemic with small number of severe cases that we see in case of influenza for long times. That can happen to COVID-19 also. And it may be we are lucky enough to have a cold kind of respiratory virus that replaces this COVID-19 and propagate and save the humankind. These are the possibilities. Now to end COVID-19, there are usual 3 epidemiological triad factors that we should focus on: agent factor, the infectivity, virulence, and how effective therapy we can use to restrict the agent. These 3 of them, infectivity with time will increase and virulence will decrease. This is usual rule for all respiratory viruses. And effective therapy to restrict agent will come up, and we are hoping for that for last 2 years for better and better antiviral, and probably this may come up with time, and the research and development should continue for that also. For regarding host factor, the natural immunity will definitely play a role, that multiple asymptomatic or mild symptomatic infection will be there, and that can give a natural immunity for 3 to 6 months on an average. It may be prolonged, but average it will be 3 to 6 months. And vaccination, the vaccination drive in the our country and in our state is excellent, and if we can continue this vaccination, whether that will be effective or not, that will be discussed later. And age of the population is one of the most important factor, that if you look at the recent upsurge of cases and upsurge of cases of severe ARDS, the aging population of Far East is actually the major cause of being deaths nowadays in COVID-19. The environment, some of the factors you may think that they may not come in the environment, but these factors are not actually under control of one single human being. It is a collective factor, like mask, how we use mask, or at all used or not, contact tracing, whether it is required or not currently, hospital management, how we can manage these patients in hospital, whether separate or cohort or in same ward, strategies of different governments. Our strategies are here also. So strategies of different governments will actually determine how we can respond to COVID and how we can think about COVID in future. And one of the most important factor is equitable access to vaccine and drugs. If we think that in India we are giving vaccines, we are giving precautionary dose, there are countries where 30% of vaccination of the population has not been done. So they will remain as focus for new variants, and that can have the potential to propagate and generate a epidemic from there. And after all, the responsibility of a citizen, and better to not tell something on Indian population. So there are three policies, as three divergent policies that all countries in the world actually define. One is removing all restrictions. That has been done in European countries like UK and Spain, that they have removed all restrictions. One is living with COVID approach. That is fortunately in India, US, Japan, and South Korea after February of this year. South Korea will be an interesting country to observe. So continuing to implement various mitigation measures to protect the vulnerable population. So we will live with COVID with some restrictions, with some relaxation. This is the notion of these countries. And the third one is zero COVID-19 approach, that pursuing a strong legislation and a strong suppression of COVID-19 cases, rapid contact tracing, and also restricting them. This approach is actually taken in Chile, China, Hong Kong, New Zealand, and South Korea before February 22. So South Korea changed their approach from being a zero COVID-19 approach to living with COVID-19. Now, what Omicron has done? The Omicron variant BA.1 that actually hit us in the end of December, and there was a upsurge of cases in January, and suddenly the number of cases was less, and now almost zero. My ICU is having 0 patients for last 3 days. So what Omicron BA.1 has affected the whole COVID scenario. The mortality and intubation rate has declined by as much as 80 to 90%. And this data is from African country, similarly from Canada, and in North Indian papers, that mortality and intubation has declined. When you compare that with Delta or the first wave, it's around 80 to 90%. Cause of most of the admissions were actually due to management of the comorbidities. So comorbidity care, and as a primary physician, that is our responsibility to take care of the comorbidities. The past influenza experience of Spanish flu, similar agent-like factors occurred. Actually, it became more infective and less virulent. So people developed multiple infections with mild symptoms, and the epidemic faded away. So Omicron BA.1 was actually ideal for that thing. And this actually shoots for beginning of the end. So probably Omicron has started the beginning of the end. So this is an interesting model given by a Seattle institute, where the Institute of Health Metrics and Evaluation their model is actually reflecting current scenario very well. So I choose this model that was given in way back in January 17. They told that transmission intensity of Omicron is so high that policy actions like increasing mass use, expanding vaccination coverage in population who actually had third doses of COVID-19 vaccine taken in the next weeks will have limited impact on the course of Omicron wave. So if we go for too much restrictions, it may not help. So what about the mask usage and urgent vaccination just before an upcoming epidemic? Increasing use of masks to 80% of the population will only reduce the cumulative infections over next 4 months by only 10%. So whether we should go for it or not, vaccine boosters is unlikely to have any substantial impact if virus is very fast spreading like Omicron. The transmission, but what is the tagline? The tagline is, but it still helps individually. If we consider community, it may not help, but if we consider as a single human being, it still helps. Test all to restrict wave, whether it helps. It actually increase disruption by having more individuals excluded from work, school, but unlikely to impact the course of the Omicron wave. Omicron or post-Omicron and following crisis, what we have seen in the Sri Lanka, we need to reconsider the testing strategy. So their prediction of April 22, given the high transmissibility of Omicron, it seems unlikely that China, Chile, South Korea will be able to permanently exclude the Omicron wave. And that what happened? Aging population and pockets of poor vaccination, the mortality will be very high and higher than low and medium income countries. So China is not a low medium income country, but what happened that people are dying over there. The era of extraordinary measures by the government and societies to control COVID-19 probably is over. Relaxation policy. In the relaxation policy, then whom to test? Elderly, the immunocompromised. If we think that this patient is immunocompromised, we should test for him. Patients with chronic kidney disease, chronic lung disease, or cardiovascular diseases, these are to be tested. And relaxation policy minded that it does not mean that not to test at all. New variants of COVID-19, BA1, 2, and so on are coming up. Reinfection of BA2 after infection with a BA1. So if you have a COVID in January, probably BA2 will not affect you so seriously. So probably we have some mileage of having an epidemic in the January. And BA4 and 5, these are new strains in South Africa, and they found that they are escaping immunity against BA1. So if there is a BA4 or 5 here, we are not safe. But severe disease is still prevented by vaccination. So here comes the role of vaccination. So we should continue vaccination amongst the vulnerables. So we have to adjust our policy as per the situation. And high income countries can respond very well with updated booster vaccine, where we are not having much updated booster vaccines. And there is a drug coming up with ritonavir boosted nirmatrelvir that is not available here. So it's effective around 87% when it has been given to a population who is not vaccinated. But what will be in the vaccinated population is still, we don't know. Yesterday, I got a paper that they showed that the BA4 and BA5 from South Africa is actually escaping the past infection of BA1. And you know that BA1 was actually hit South Africa first, Botswana, South Africa, and they are now having 4 and 5. These kind of new things will come up regularly, and possible scenario to end the pandemic, it could be soon and simultaneously in both high income and low medium income countries, but it is very unlikely. But emergence of a new variant that will be very transmissible and considerable ability, has the considerable immunity to evade our immune system and can prolong the pandemic. This chance is also low. The most likely chance is there will be less disruptive in the high income countries than low income countries. So high income countries will end the epidemic faster than low medium income countries because of this vaccine inequality. And building immunity across countries is most important. Vaccine donations are good things, but is not actually sustainable thing. So the low vaccine uptake in low medium income countries is slowing the pandemic actually. And we have to focus on that. And projected vaccine coverage was 60%, 61% in first dose in globally. But when you look at the Africa, it is in the February, it is around 15%. And recently there is no data for last 1 month. Vaccine non-response is common in hematological malignancy, dialysis, solid organ transplant recipients, and immune-mediated disease patients, and in different liver transplant patients. So in this group, we may have to give more and more vaccine, and the gap of 9 months may be reconsidered. The precautionary doses can combat waning effect of immunity for primary vaccination. Here it is 9 months after last dose. Effectiveness as a short-term measure, it is RCT proven above 60, but below 60 there is no data. Data on younger and healthcare worker is still lacking. So it is our duty to have data on that also. But it is better to continue additional doses and generate data. So fighting is not over. We have to keep fighting. Some may lose like Von Ryan and some may be triumph. Thank you.
Thank you, Yogiraj. I can just say when we are totally confused with the disease with which we are not accustomed, in my mind, Yogiraj gave me enough strength that how to fight with the disease. I want to have few questions from you. Is 4th dose of vaccine necessary?
Sir, still now we have data that above 60, if we give multiple doses apart from our usual 2 doses, is actually affecting a lot, and it is helping. But below 60 age, we still lack data.
And what should be the interval after the 3rd one?
Sir, from a government officer, it's 9 months. But there are data that it could be reduced up to 4 months.
4th one?
4 months. 4 months interval, 4 to 6 months interval.
4th dose after the 3rd
Till we
month.
get enough data above 60, better to continue multiple doses.
You are showing hope that probably you are reaching the end of the game.
Yes.
You are 100% confident in your mind?
So I am not that 100% confident, but the number of ARDS cases will be very low and will be restricted to 1 or it can be managed by 2 or 3 hospitals.
Some disease will be there like ordinary influenza,
like
and mortality will be much less.
Yes, sir. Mortality in influenza is high also. We don't test for that.
And very controversial question, I apologize for that. In my lifetime, I have not seen any disease which involves from the neonate to the old age, from heart to lung, brain to kidney, pancreas. Any age group, any, I should call it as a race, any religion. I have not seen any disease without any predilection involving on. Is this really a artificially created virus, genetically engineered, or natural virus? I have never seen any disease where the fetus is affected within the mother and an old age at the end of the day. Cardiology, neurology, all subjects are involved from hair to nails. So, what do you think? This is a controversial question. Or you can tell after the program personally. Thank you.
Okay, last question, only time can save, so we cannot. Yes, one, quick.
Yes, this is the
Yes.
most important thing.
Inequality.
And
yeah.
you cannot sustain by donation of vaccination. You have to arrange vaccination from there within.
Thank you, Jogiraj. Truly speaking, I should say that Jogiraj became the face of the COVID fighting for West Bengal. And because of him, we could generate strength among the particularly junior doctors and even the senior doctors. We are really thankful to you. And we still hope that wearing mask and vaccine is going to prevent us. What Sir has asked, that is a policy matter. Truly speaking, it is very difficult to say at this moment from any one of us that what will be the vaccination pattern in future. But whatever it is, usually it is seen that giving vaccine definitely is
helps.
helpful. I wish and pray that the way we have fought, Bengal as had fought the last 2 or 3 waves, if at all the 4th wave comes, we again will fight and we will win. Thank you.
Thank you.
Thank you, sirs. And I would request our honorable chairperson, sirs, to please felicitate Dr. Jogiraj. Thank you. And I would request Dr. H.S. Pathak to please felicitate our chairpersons. To Dr. Debashish Bhattacharya. So our chairman is felicitating Dr. Debashish Bhattacharya and to Dr. Shamur Banerjee. And Dr. Pradeep Mitra. Now let's move on to the inauguration, and to coordinate this inauguration, I would hand over the mic to Dr. Mary De Cruz.
ডক্টর জ্যোতির্ময় পল আসছে না? জ্যোতির্ময়
Good afternoon, everybody, and a warm welcome on behalf of the Association of Physicians of India West Bengal chapter to all our distinguished guests, faculty, and esteemed delegates. We will now begin our inaugural program, and I will call on the dais all our dignitaries. I request Dr. H.S. Pathak, Chairperson of the API West Bengal branch, to please come to the stage. I also call on Dr. Amal Kumar Banerjee, Chairman of the Indian College of Physicians West Bengal chapter. And I request Varsha to felicitate them with flowers. I call on our Honorable Chief Guest, Dr. Debashish Bhattacharya, Director of Medical Education, West Bengal, to please come to the dais. I call on Dr. Siddharth Niyogi, Director Health Services, to please come to the dais. I also call on Dr. Ajoy Chakraborty, Officer on Special Duty, Uttar Kanna. Dr. Jyotirmay Pal is not here today with us, but I now call Dr. M.K. Roy, Secretary of the Indian College of Physicians, West Bengal branch. Dr. Shibendu Ghosh, Scientific Chairperson, API West Bengal branch. And last but not the least, Dr. Parthasarthi Karmakar, Secretary of the API West Bengal branch. Please come to the dais. Dr. Ajoy Chakraborty, are you here, sir? I request Dr. Das Ghosh to please felicitate with the flowers. Request Dr. Das to please give the flowers for felicitating our guests. I now call on Dr. H.S. Pathak. Felicitate Dr. Ajoy Chakraborty. I now request Dr. H.S. Pathak, Chairman of the API West Bengal chapter, to give his welcome address.
Good afternoon. On behalf of API West Bengal chapter, it's my pleasure to welcome Dr. Devashish Bhattacharya, Director of Medical Education, Government of West Bengal, Dr. Ajay Kumar Chakravarti, DHS, Dr. Siddhartha Niyogi, also Director of Health Service, Government of West Bengal, Professor M.K. Roy, who is Secretary ICP Forum West Bengal, Dr. P.S. Karmakar, he is the organizing secretary of this program as well as very dynamic secretary of API West Bengal, Dr. Amal Kumar Banerjee, who is in fact chairman of ICP Forum West Bengal, and Dr. Shivendu Ghosh, who is the organizing the scientific chairperson of our branch. I also welcome all chairpersons, speakers, very senior members of our API who are present over here. I also welcome all postgraduate trainees and participants, and also welcome all members of the pharma industry. In fact, this program on 1st May was initiated in 1999 when Professor Kanailal Banerjee was the chairman of our branch, and Dr. Amal Kumar Banerjee, who is present over here, was the secretary. And this program has been continuing for years together, physically, except last 2 years when we had to conduct virtual program during this pandemic period. In fact, there was a proposal from our branch that in West Bengal, May Day is celebrated in some other way, but in API, we are also celebrating on 1st May. So we suggested that to start in all states, the scientific program on 1st May, and that should be called API Day. Now today, regarding our program, our organizing secretary, Professor P.S. Karmakar, with active cooperation from Professor Udas Ghosh, from Professor Jyotirmoy Pal, from Professor Nandini Chatterjee, and scientific chairperson, and others also. They have prepared a very vibrant academic program, and I think everybody will benefit from this program. Thank you.
Thank you, Dr. Pathak. And now I would request our chief guest, Dr. Debashish Bhattacharya, DME, and all other dignitaries to please come down for the lighting of the lamp for the official inauguration.
या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या कुन्देन्दु तुषारहारधवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या
Thank you so much, delegates. Please come back to the stage. And now I request the chief guest, Dr. Debashish Bhattacharya, to say a few words.
Good afternoon. For last 2 years, we were not meeting each other except virtually. And the physical meeting has just started. But I felt that still more involvement of our junior doctors would enrich the strength of API. And I still hope that, as I just said in my last session, that all of us, even if the fourth wave comes, we will fight together. And API definitely will be the major group to help the government in fighting COVID, if at all it comes as a fourth wave. I wish and pray these scientific sessions will enrich all of us, and the exchange of views will also influence our junior doctors who can really carry the torch beyond their own domains. I sincerely hope that this two-day program will really come as a scientific feast to each and every one of us who have joined. Thank you. God bless.
Thank you so much, Dr. Bhattacharya, for reposing your faith in API to help the government fight. I now request Dr. Amal Kumar Banerjee, Chairperson, ICP West Bengal Chapter, to say a few words.
Good afternoon, respected dignitaries on the dais and my friends and colleagues. I'm really very glad to be here on the occasion of May Day CME of API West Bengal branch. Harishankar Pathak, Dr. Partho Karmakar, Shivendu Ghosh, Jyotirmay Paul, Udas Ghosh, and the whole executive body of API, including Nandini Chatterjee, who is editor-in-chief of our Bengal Physicians Journal. They have worked hard to give a meaningful and updated shape to the scientific program. I wish all the success of this program, which would help to update ourselves and also to enlighten the young and budding physicians of our state. Thank you.
Thank you, Dr. Amal Banerjee. And I now call on Director Health Services, Dr. Siddharth Neogi, to say a few words.
Good afternoon to everyone. I have actually appointed just as DHS on last Thursday evening. So suddenly I was invited to this program, and for that I thank the organizer of the Association of Physicians of India. So physicians are the pivot of the health system, whether it is COVID or other diseases. Then come the surgeon and other people. So to be present here is my privilege. And we hope either we are in the government sector or private sector, we have to work together to make West Bengal a disease-free state. Thank you.
Thank you, Dr. Neogi, for your kind words. I now request Dr. Ajoy Chakraborty, Officer on Special Duty, Uttar Kannada, to please say a few words.
Most welcome to you all. I am just very fortunate to meet you repeatedly again and again. And you see, we are depending upon you most because you see, the medicine is the ultimate of the medical subject. Because I do not know, many of us never meet a surgeon. Many of us never meet a gynecologist at all in our life. Maybe we didn't meet the dermatologist or psychiatrist, fortunately. But I don't know any one of you or me has never met a medicine specialist. And ultimately, everything is dependent upon the medicine. And now, in the auspicious gallery of the galaxy of the leaders of the state, I am telling you, lot of challenges are there in front of you. What are the challenges? The challenges of new coming, emerging disease and repeating the dengue, the old disease coming again, tuberculosis to eliminate, dengue to, you see, again, this time, this year, maybe dengue is biting again. The last 2 years, dengue was little bit suppression, but this year, what you are seeing, that dengue is already taking the upper hand. Now, these are the diseases where, you see, not only the individual person, but the whole system collapse. The public health collapse right away. And the thing is that in that juncture, the maintaining the protocol, deciding the protocol, what will be the guideline of the treatment of the newly emerging disease, we are depending upon you very much. And like the previous years, like the COVID pandemic, how we have fighted together in the last episodes of dengue, how we have fighted together because of your enthusiasm, your knowledge, your collective wisdom that lead us to develop the protocol and to abide by the protocol and to ensure that protocol is followed by everybody everywhere. So that too, in this way, we will fight together. And this association has helped a lot. And I just hope that this association will guide us in future also in the same way. Thank you very much. Thank you.
Thank you, Dr. Ajay Chakraborty. And now I request Dr. M.K. Roy, Secretary of the Indian College of Physicians, West Bengal branch, to say a few words.
Good afternoon, everybody. Dignitaries on the dais and off the dais. At the very outset, I'd like to extend my heartfelt thanks to all the delegates who have come in spite of a little bit of COVID still there and have this conference successful in a physical manner. We do feel that in future, we are not going to have virtual meeting. Rather, we will have these types of physical meetings. And probably this is the 22nd year of our May Day observations. Though for last 2 years, we could not arrange it physically. Once we did it virtually. An ICP forum of West Bengal has been formed at least 1.5 years back, and it has come into its full form. And we are trying to hold a lot of peripheral CMEs, especially in the last part of this month, we will have CME in Malda, the city branch. And in the month of June 12th, probably, we will be having another CME, peripheral CME on behalf of ICP forum under the banner of West Bengal chapter of ICP and Murshidabad branch at Baharampur. And some of you, please try to attend these meetings. We will announce the date accordingly. And we do feel and hope that in future also, with your help and support, we will be taking away the ICP forum, the sister wing of API, in a better way and to a great extent. Thank you very much.
Thank you so much, Dr. Roy. And now I request Dr. Shibendu Ghosh, Scientific Chairperson, API West Bengal, who with his team has put this academic feast together.
Thank you very much for allowing me to have a speech in this August gathering. I should not be there between the hungry tummy and the time constraint that is going on. In continuation of Dr. Ajay Chakraborty's speech, I think the medical profession, particularly physicians, in the near future is going to have a debacle. Debacle if we do not have our clinical medicine properly involved in our teaching system, first. And second, if we do not have artificial intelligence properly supplemented in our teaching and training program, both of them will make a debacle for the physicians at large in globally as well as in Indian and nationally. So that is one of the very big issues. I'm very much thankful for all the members of the executive committee, particularly our Secretary API chapter, Dr. Partho Karmakar, and all other members, Nandini, Jyotirmoy and others, to overcome my shortcomings to prepare this scientific program. And with these few words, may I stop here to have the deliberation by other dignitaries. Thank you very much.
Thank you so much, Dr. Shibendu. And now I request our Dynamic Secretary, API West Bengal Branch, Dr. Partho Karmakar, to say his vote of thanks.
Good afternoon, dignitaries on the dais, as well as learned gathering there. Good afternoon, everybody. It's really a very proud moment for all of us to organize a physical midterm update on this very nice evening or good afternoon. And here we have got so many important personalities on the dais. And first of all, I am very much thankful to our DME sir, Professor Dr. Debashish Bhattacharya. He is so academic and so knowledgeable in his discipline, and being so busy, he gets only little bit of personal time on Sunday. Even in our request, he couldn't defy that, and he has come and given a few hours over here. We are really very much thankful to you, sir. Now, another very important dignitaries, and I am over him with his greatness. I requested him just today evening, today morning, with reference of our DME sir. That is, you can well understand, that is our newly posted DHS sir, that is Dr. Siddharth Niyogi sir. And he accepted my invitation then and then, in spite of his busy schedule, and he has come over here and he has spent few hours with us. I am really thankful and grateful to you, sir. Now, I come to Dr. Ajay Chakraborty. He is with us for last 2 years. And whenever we have approached him, with his extreme capabilities, being so busy a personality, with his extreme capabilities, he has extended his helping hands for any purpose for in health service category. So I am also really thankful to you for coming over here and to be present over here for few hours. Now, coming to our chairperson, that is Dr. Harishankar Pathak. I am so lucky to be organized secretary or to be honorary secretary of API West Bengal chapter when I have got Dr. Pathak as my chairman. So he is so all the time he is giving our enthusiasm, encouraging us, and whenever we are in any problem, he stood by the side of all us, all the executive members, and boosted us for better work. I am really thankful to you, sir, for your cooperation for last 2 years. Now, we are having here one stalwart, that is our Dr. Amol Kumar Banerjee. He is past dean, past president of National API, and at present he is chairman of ICP, that is the academic wing of API. So he's stalwart in the sense that whenever we are in any problem, so far organizational problem is concerned, we want his suggestions, and with his rational and logical sort of decision, he helps us a lot to tide over the crisis. So I am really, really thankful to you, Dr. Amol Kumar Banerjee, sir. Now I am coming to our honorary secretary of ICP. He is none other than our beloved Dr. M.K. Roy. We call him our academic guru. Whenever we are going for any sort of academic discussion, if he is not present, dhare bhare thik kate na. So all the time I have a talk with him that we are going to organize this sort of academic things. You please block the date. So all the time he tries his level best to block the dates, and all the time he tries to stay with us whenever there is an academic. Now I coming to our another very important person, that is Dr. Shivendu Ghosh. He is all the time by my side to help me to work out so far the scientific topics are concerned, along with other very important EC members, that is Dr. Udas Ghosh, Dr. Nandini Chatterjee, Dr. Jyotirmoy Pal, and Dr. Shoikat Datta, and I can see Dr. Partho Sarkar, Dr. R.N. Sarkar. There are so many others, Dr. Supriya Sarkar, everyone is, Dr. Ananda Bhakti, everyone is there who helped me a lot and made my work easier for organizing this sort of big conference over here. So I am thankful to all the EC committee members, all the dignitaries present over here for helping me, for extending their helping hand to their great extent. And last, but the presence of whom matters most for a conference to be successful, that is you, sir. The learned gathering in front of me, if they would not have been here for last 2 days, this conference cannot get the success. So I am really thankful to all of you, sir. And with this short speech, I like to invite you for the lunch, and all the scientific programs that are still left, we will definitely organize it after the lunch. Please come for lunch. And I request all the dignitaries and all the learned gatherings, have your lunch, because all of you are very hungry and empty stomach cannot be wise. So please fill up your stomach, and after that we'll start our academic program once again. Thank you very much. Over to Dr. Mary D. Cruz for nice conduction of this inaugural ceremony. And we will come back over here at 2:40 sharp to start our post-lunch sessions. Thank you, sir.
Thank you so much to all the delegates and the dignitaries on the dais. We now conclude the inaugural program. Thank you very much.
ঠিক আছে স্পিকার তুলবো ওকে ওদিকে ক্যামেরা এরকম এইরকম আচ্ছা 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 হুম হচ্ছে হ্যাঁ শিওর
Good afternoon, everybody. I request all our delegates to please come on the dais and have their seats. We will be starting our scientific sessions immediately. The delegates are requested to please come on the please come in the hall and take their seats. We will be starting our scientific session as soon as possible. All the delegates, please.
Good afternoon, everybody. Those who have completed their lunch, please come inside. We are going to start our post-lunch session very soon. Otherwise, we will get late. So please come inside. We will start our program very soon. And PGTs who are competing for quiz, please contact Dr. Atanu Chandra or Dr. Udalak Chakraborty. Because total there are 9 teams, so some elimination round will be there. So please contact Dr. Atanu Chandra and Dr. Udalak Chakraborty immediately. Before going for quiz, there will be one elimination round because there are total 9 teams. I request Dr. Shoikat Dotto, please start the proceeding
Okay,
within 2-3 minutes.
yes, I request everybody to please come into the hall and take their seats because we'll be starting our scientific sessions immediately, else it has already been delayed. So I request everybody to please take their seats. I request all the postgraduates to please come in the hall and take their seats. An elimination round will be held now. For that, please contact Dr. Otanu and please occupy the last 2 rows so that elimination rounds are held as early as possible. The postgraduates, please occupy the last 2 rows so that the elimination rounds are held as early as possible. And let's now move on to our next session. To chair this session, I'd invite Dr. Siddhartha Niyogi, the Director of Health Services, Dr. Supriyo Sarkar, Dr. Dipanjan Bandopadhyay, and Dr. Niladri Sarkar to please come on the dais.
Welcome to our post-lunch session, and thank you to the chairs who are already here. I would now request in this session on radio imaging, some of the most difficult decisions that we have faced based on the current pandemic. Today we have none other than Dr. Parthasarathi Bhattacharya, eminent pulmonologist of the city, who will be speaking to us on basics and post-COVID CT thorax. I am sure this will be a very enlightening session. Please welcome, sir.
Thank you, ma'am.
I'm really grateful to the organizers for giving me this topic. In the next 20 minutes, what I'm going to do is to talk on basic understanding of HRCT chest. It will be followed by pattern identification for abnormalities, then clinico-radiological interpretation, and finally a bit on HRCT in COVID-19. HRCT chest is a very important investigation. In fact, it's a very detailed and very delicate investigation. It's interesting because it gives a lot of information, but few things are very important. In this talk, I will touch the basics only, and I'll try to make as many as possible carry home messages. Let me start with chest X-ray and HRCT. You can see the HRCT chest and chest X-ray, both are similar to some extent. The left side of the chest X-ray is the right side of the interpreter. So if I look at the HRCT chest, the left side of mine is actually the right lung. So that orientation has to be kept while interpreting it. Sorry, it's not. While reading an HRCT chest. Understanding of the normal anatomy is very important. I am not going into details. And these bits are important for chest X-ray as well as HRCT. There are so many terms, CT, HRCT, CCT, MDCT, etc. I've just given a simile with multiple slices of a potato. There are some thin slices and there are some thick slices. Thank you very much. So the thick slices are actually averaging of the thin slices. And well, and this is CT scan. This is, you can see very well the structures are seen. You have seen the blood vessels. There is some abnormality out here. If this is CT, and if you look at this, this is HRCT. You can have much better delineation, sharp image. So this is a difference. So once you wish to look at the lung parenchyma, it is always HRCT chest. There are a lot of technical things. I'm just skipping them. So let me start. What is window? I think these basics to be learned by everybody. Here you can find a very good black and white contrast. Dark black and clearly sharp white with a sharp margin. This is aorta, this is pulmonary artery, right and left, this is trachea, this is esophagus. You can see the soft tissue around. This is called mediastinal window. In this window, you can see the mediastinum very clearly. There's one more window. This is called lung window. It is also black and white, but not just black and white. Black and gray, you can say. You can see a lot of blood vessels, a lot of streaky shadows. This is lungs. So this is called lung window. So we have got two windows, lung windows and mediastinal windows. You have to understand these windows before you go to interpret HRCT. This is the difference between the two. This is normal HRCT chest, a cart with lung window. See the pleural surface, it is sharply delineated and absolutely clear. The blood vessels in the outer third is very few. And in the center there is heart. This is a fissure, which is very thin, and this is absolutely normal. I'm giving this image to have a mental impression of what is normal. There are some special notes. This is abnormal. You can see a lot of white shadows at the dependent part of the both lungs. And if you have such shadows, you have to have a prone film. The shadow has cleared. So prone film is important if you have a basal dependent parenchymal shadow bilaterally. In this particular cut, it looks normal. There's nothing specific, but if you're a little vigilant, this area looks slightly hazy, and this area looks slightly hyperlucent. Well, this is an inspiratory film. If you make an expiratory film, the same whole thing changes. You can see a lot of air spaces trapped here, and this trapped air is looking hyperlucent. There is area of ground glass opacity or haze. So this is a kind of mosaic. And for any parenchymal lung disease, you have to have an expiratory film. So you have learned how to look at the HRCT chest. You have learned what is a window. And you have learned two small bits. One is inspiratory and expiratory, prone and supine film. So these are important to understand and interpret HRCT chest. Let us give some examples. This is a mediastinal window, contrast enhanced. You can see a filling defect, that is a pulmonary embolism. This again a mediastinal window. The root of the pulmonary artery is of same diameter or slightly larger than that of aorta. This is a case of clear-cut case of pulmonary hypertension. This sign is 100% specific. This is the left lung is absolutely black. The right lung, the right side shows the liver. The abnormality is dilated veins, dilated hepatic veins, indirectly indicating high pressure in the right atrium. That is secondary to pulmonary hypertension. Okay, so you can have a lot of information from these shadows. Let us see some example of lung windows. This is the normal. You can see increased density and lot of small cystic spaces being arranged in palisades from pleura to the center. And this is called honeycombing. Well, after that, once we have learned this, we have to learn what is the skeleton of the lung. The skeleton of the lung, this is my hand-drawn picture. This is the bronchovascular tree, and the pulmonary skeleton is along the bronchovascular tree. We call this axial skeleton. There is a skeleton outside, close to the periphery. We call it peripheral skeleton. And if you follow a bronchovascular branch, then we land to this peripheral skeleton. This part you cannot see normally. This is pulmonary artery, and accompanying is a bronchus. And they end at the center of the secondary pulmonary lobule. So this structural identification is very important. Here it is the same thing. There's a pulmonary artery which is carrying deoxygenated blood, and there is a bronchial branch which is also accompanying it to the center of a area which is called secondary pulmonary lobule. The wall of this secondary pulmonary lobules called interlobular septi. They carry the pulmonary vein, which is dark red, carrying arterial blood. So many times, if you see the report, a lot of things been written, centrilobular, perilymphatic, etc. So this is the basic of centrilobular and perilymphatic structures. This is how the lung looks in cut section, and this is how it looks in CT scan. And this is the picture which I have drawn earlier. The bronchus actually leads to the centrilobular bronchi. In this lobule, there are intralobular parenchyma, which is not seen. This is beyond our visual capability. So, well, this is the lung parenchyma. These are the two examples. Here you can see the lobules are seen, and these lobules have got smooth boundary at many places. These beautiful lobules with interlobular septi being uniformly distended with a central shadow. This is because of interlobular septal congestion from acute heart failure. So if there's a patient have myocardial infarction and acute heart failure, such image can give a diagnosis immediately. This is a distribution of different types of nodules and different types of shadows. The pleural surface, the fissures, they actually carry the lymphatics from the periphery. Once it reaches the center, these lymphatics merge to the central axial skeleton. So if you have nodules, it is called perilymphatic nodules that sits on this pleural surface or the fissure. There are multiple nodules on the fissure on the right side. There are multiple nodules on the pleura. This is a condition called, you can see nodules on bronchovascular markings as well. These are the perilymphatic nodules, and the differential diagnosis is very few. This patient has sarcoidosis. And this is another patient of the same disease where the nodules are much bigger in size with a lot of coalescence, making a kind of mass shadow on the left side. This is also a case of sarcoidosis. So I'm not going into details of nodules. There's an exercise, this is random nodule, which we call miliary nodularity. There's also an exercise for short of time, I'm not going into details. In the periphery, you have seen 3 arrows, and these 3 arrows are showing 3 curvilinear structures, which are not touching pleura. They are away from the pleura. And in between, there are fine septi. This is called interlobular septi. And this is interlobular tree-in-bud appearance. And this is classical of a pathology that is actually filling up the minor bronchioles and distending it. Let us reach now an interpretation algorithm. First, look for the position, look for the types of the window, look for the density and the skeleton. And this is very important. You have to decide the density is either high or low. There are multiple pathologies that can cause high density, multiple pathologies that can cause low density. And sometimes they mingle together to make mixed densities. I'm not reading out the causes of high or low density. So let us pass to the examples. In the examples will come later, but in the examples we'll call about the pattern identification. You can see this pleural surface is clear. There is no nodule sitting on the pleura, but there are small, ill-defined nodules all across the lung. These are all centrilobular nodules because they are not touching pleura. And these ill-defined centrilobular nodules are seen classically in hypersensitivity pneumonitis, acute stage, acute or subacute hypersensitivity pneumonitis. These are certain patterns. You can see the hand through this paper, and but you cannot see the details. This is called ground glassing or haze. But if you cannot see anything at all, that is actually consolidation. So this is the best way to differentiate. You can see the bronchovascular tree through this haze. So there is ground glassing. There is also a bit of ground glassing and bit of consolidation. This is a mixed opacity ground glassing of different kinds. Some areas are slightly lighter, some areas are slightly darker, but the interlobular septi are also, prominent. So it's a kind of crazy paving being taken as a similarity from this pavement. And this is also a kind of crazy paving. So there is a differential diagnosis of crazy paving also, and we find a lot of crazy paving in the area of COVID pneumonia. This is honeycomb, and you can see honeycombing. If this small cystic spaces are more than 2.5 centimeter in diameter, they are cysts clearly, and they are not honeycombing, although they can take place in fibrosis or the pathologies where honeycombing is seen. This is a beautiful art of mosaic, and you can find similar mosaic in lung, which I have shown you earlier. And this is an expiratory film. Why? Because if you look at the center, there is a sickle-shaped trachea. The esophagus has been bulged into the tracheal orifice, tracheal lumen, and this is because of forced expiration. And the air trapping has been very clearly delineated. This is called mosaic appearance. This is a very complex. There are a lot of findings out here. There are a lot of ground glassing, a bit of crazy paving, a bit of mosaic. There's a bronchiectasis in the right side, lower zone. A lot of other findings. There are perilymphatic nodules as well. So it's a very complicated cut. And this, in fact, gives examples, so many things being together. This has been placed because it's a mixed problem. This is hyperlucent problem, left upper lobe showing a lot of bullous and emphysematous changes with scars. Extensive panacinar emphysema in a case of smoker. These are shadows with low density. So the density determination helps us to differentiate between different kinds of shadows. In summary, check whether it is really an HRCD cut, see through the two windows, concentrate on the lung window, try to understand the anatomy, look for the density, look for the abnormality, mind the special situations, prone versus supine, and finally take history, take examination into the consideration, and also other impressions while giving a report. I'm not going into exercises because time is running. These are very interesting exercises. You can see pulmonary artery is so big, the accompanying bronchus is small. This is again a case of pulmonary hypertension. No, it's not what. Let me pass through HRCT in COVID-19. There may be changes in acute stage, there may be changes in subacute stage, and there may be changes in post-COVID lung. So in acute stage, we'll know what is going. This is the usual array of findings been found with time. It starts with ground glass opacity, peripheral, small distribution of ground glass opacities, then consolidation, then leading to reticulation, and finally to recovery. And you see the time limit. 0 to 4 days is a pure GGO. Consolidation is after that from 5 to 8 days. From 9 to 13 days, consolidation along with reticulation, and recovery in the stage 4. And the maximum tissue density occurs around the 10th day. There is a common scoring system. If RT-PCR is positive, it is stage 6, whatever be the stage of the density. But 4 and 5 are highly suggestive of COVID. Otherwise, in 1 and 2, there may be COVID, may not be COVID at all. 1 means normal, there is no infection. Well, let me talk a few words about the tempo of the changes. You can see how it is changing over time. And this is very important. The red area is basically ground glassing. If you see from day 0 to day 24, the red area actually widens by day 24. So if you see ground glass, it doesn't mean that it is the early stage. It may be the late stage. In fact, ground glass converts to consolidation. Consolidation converts back to ground glass before it reappears, disappears. And in the late phase, you can find reticulations. So these are the tempos for short of time. I'm going a little slow, a little fast. Here you can see what can be the fate of these shadows. They will either recover or persist or worsening. The dotted line says the possibility is not certain, but persistence is known. In certain patients, some patients, there is persistence of abnormality. If we follow that SARS-CoV-1 infection, even after 15 years, 5% of the patient had persistent abnormalities. So we expect some patients may remain abnormal as long as they survive for COVID-2 as well. I'm quickly passing to another slide, which is very important. These are the signs which can predict persistence and continuation of the COVID. This slide is very important. The patient is elderly, heart rate is more than 100 per minute. Hospital stay is more than 17 days. The patient had ARDS. Non-invasive mechanical ventilation was given, and the lesion with CT score more than 18. The odds for having prolonged abnormality radiologically is very high, varying from 1.4 to 6.6. For ARDS, it is 6.6. So that's all. Thank you very much. My suggestion is that ask to yourself before ordering for an HRCT. Should not be done in each and every case. Interact with the radiologist and restrict to limited cuts if possible. Thank you very much. Sometimes the shadow looks better than the original. HRCT sometimes gives such a wonderful information as if we are looking at the pathology in our naked eyes, and good interpretation of HRCT can lead to a lot of help to a physician concerned.
Thank you so much, Dr. Parthasarathy, for that excellent talk. And I now
Madam,
request
please.
the chairperson.
Madam, please. This is our duty. Thank you, Parthuda, for giving us a nice how to see the HRCT, the patterns of HRCT, and also the changes we have learned from the COVID period. Parthuda, one thing is that in the COVID period, we learned that some shadows we think earlier it is a heart like fibrosis, they disappears. Do you have any comment on this?
Yeah, COVID has given us a lot of lessons. We had a perception that traction bronchiectasis, reticulations, they are markers of fibrosis. Even honeycombing also. In COVID has shown that these are all fake. Sometimes you see even these shadows getting disappeared. So what we call the hallmark of fibrosis may not be fibrosis. It may be fibrosis in formation, and they might resolve. We do not know what is the situation in our body between pro-fibrotic and anti-fibrotic system working simultaneously. It is depending on the pro or anti-fibrotic system's dominance, we find different kinds of lesions.
One confusion. Is GGO opacity always synonymous with COVID infection?
No, not at all. Not at all. GGO is actually a description of opacity. It can develop from alveolar pathology. The alveolar pathology may be simple exudative pathology or even maybe fibrosis. 10 to 20% of the GGOs are actually fibrotic GGOs. And rest of the GGOs are usually some kind of exudation or some kind of oozing within the alveoli that actually blurred the shadows. So GGO is not a pathognomonic of COVID. It can occur in a hell lot of situations, starting from heart failure to COVID, to infections, to hypersensitivity pneumonitis, to many other pathologies.
I've got only very simple question, because we are divided about the lung fibrosis, microvascular thrombosis, anticoagulant, antifibrotic agent. Can you explain where we should go in the COVID era? That is one of our very big problem for us.
Very important question, very shrewd question. It's important to look for everything. If you look at a CT scan of COVID, you have to see what is the time after the onset of the disease the scan has been done. In acute stage, people first did not include acute thromboembolism into the list of COVID findings in HRCT. But if you are vigilant, you can find clues for acute thromboembolism, especially in a slightly smaller arterioles in a huge number of patients. So you have to take into account that too. You have to take into account the patient's basic status. You cannot expect, HRCT cannot explain if a patient has got a disproportionate shortness of breath with disproportionate desaturation. You must think yourself that you are missing something, and that is possibly some thromboembolic event. There are definite clues in HRCT chest or CECT chest in particular. So we must look for everything, the all spectrum possible. And if you're really vigilant, you can give a report which can go tally the physiology very well.
Thank you, Parthoda, for your nice talk. Then I invite my co-chair to invite.
So just stand there, we will be giving you. May I request any of the chairpersons to please wind up the session, and then we'll hand over the memento as Dr. Parthasarathy will be leaving. Thank you so much, Dr. Parthasarathy. And now we move on to the next topic by Dr. Moinak Mukhopadhyay, elderly lady with syncope, post pacemaker status.
Good afternoon, everybody. It's really a matter of great honor for me to address this august audience. I'm grateful to the organizer of API, and I'm really grateful to my professor and mentor, Professor Dr. Nandini Chatterjee, for her constant encouragement. So I have been given the task to simplify the approach towards the pacemaker ECG. So I'll try to justify that within the coming 15 to 20 minutes. So this is a case of an elderly lady with syncope. She had a pacemaker implantation of something around 14 years back, and she came to the emergency in a collapse state. And this was the ECG, and you can see over here, this is a very clear-cut case of the 2:1 AV block with no pacing spike, and very clearly it's an exhausted pulse generator, which I'm going to discuss next. So today's our learning objective will be to learn what are the types of the CIEDs available. CIED is the electrical implantable device, the different components of that. How do we give the nomenclature to the devices, the principles and dysfunctions, with a special emphasis on the pacemaker ECG interpretation. So commonly there are two types of the CIED available. One is temporary, there is the temporary pacemaker, and the permanent. Permanent can be transvenous, epicardial, or subcutaneous. But the portfolio at present is quite big. We are having the different kind of pacemaker like single or dual chamber. We are having ICD, that is the shocking device. It can be single and dual chamber. CRTP, that is the resynchronization therapy. It can be a pacemaker type or defibrillator type. Physiological pacemaker, which we are regularly doing at present in Kolkata, that is pacing at the site of the bundle of His or the left bundle branch. Leadless pacemaker, which is also regularly doing, and implantable loop recorder. So first of all, I would like to show some pictures, because as a physician, we'll be having two important things. One is the ECG and the X-ray, through which we will be able to identify the device. You can see over here that, may I have a pointer, please? In this X-ray, you can see in the left-hand side of the patient, there is a pulse generator, and there are the two coils which are going inside the heart. One is towards the atria, there is the atrial lead, and the other one towards the ventricle, there is a ventricular lead. Now, this is a single chamber pacemaker. You can see the pulse generator and the lead over there. And the tip of the lead is the cathode, whereas the anode, in previous the unipolar pacemaker, the anode was actually the pulse generator itself. Whereas nowadays in the bipolar pacemaker, the pulse generator is somehow, the anode is to some extent located over here. The cathode is over here, the anode is over here. But previously in unipolar pacemaker, it was the pulse generator which was considered to be the anode. The importance of this image is that you can see over here that most of the times the lead is looking towards the downwards. So whenever you are evaluating whether there is any dislodgement of the pacemaker lead, you will have to consider it. But again, there is some fallacies. This is a physiological septal lead placement. Here you can see, it's not like that the previous one, the lead is looking upwards. So whenever, if you're considering whether there is any dislodgement of the lead, always consider that nowadays it is not always possible that you will get to see the lead is always looking downwards. There may be cases of the septal lead placement where the lead will be located towards the septum. So consider this also. Now this is a CRT. Here the difference is that there are three leads. One is the atrial, other one is the ventricle, and the third one is towards the in the tributaries of the coronary sinus. So if you are seeing the 3 leads, you will have to consider that this is a CRT. Another interesting observation in this X-ray is that this white color sleeve, whenever you will be able to see in any device X-ray, this white color sleeve, this has to be an defibrillating device. That is only in CRTD or in ICD, you will be able to see this kind of dark white sheet, which is not present in normal pacemaker. Now, this is a Micra, that is a leadless pacemaker. And this is the X-ray of a Micra patient. You can see that it is a small capsule-like thing, which is located towards the apex. So what are the sites of pacing? Commonly, it is for the atrial lead is the RA appendage. For the RV lead, it is the RV apex or floor. But again, you will have to remember that there are the possibilities of RV outflow tract pacing, septal pacing, bundle of His pacing, left bundle branch pacing, coronary sinus, and epicardium too. So whenever we are evaluating the X-ray of this kind of patient, we will have to keep all this in mind. But most commonly, almost in 99% of cases, you will be able to see the lead located in the RA appendage or the RV apex or floor. So how does a pacemaker work? In a very simplified way, it is nothing but a gatekeeper or security guard. Pacemaker watches what is happening within the heart, what actually the native rhythm is, whether there is any native QRS is coming or not, just like a night watchman. Then after watching what is happening in the heart, pacemaker tries to feel, that is the sensing capacity of the pacemaker. He feels that whether I should do something or I should just stop doing anything. And after the feeling, pacemaker either do something or it just rest. Like in a simple example, if pacemaker feels the patient's own heartbeat is giving a QRS complex, then pacemaker will feel that I should not do anything. I'll just observe it and wait for the next beat, whether it is coming or not. And if the next beat is not coming, pacemaker will again start functioning. And it's not the pacemaker at all should be incriminated for all the dysfunctions, because if the heart or the myocardial tissue doesn't obey the pacemaker's current, it will not be possible for the pacemaker to do its actual function. So the last and the most important thing is that heart or the myocardial tissue will have to obey, that is the capture function. So the sensing, it is nothing but the ability of the pacemaker to detect an intrinsic depolarization. So what is happening within the heart electrically, pacemaker will have to sense it. Otherwise, it will not work properly. We always come across the nomenclature like VVIR, DDDR. So what is this? The first is that there are the 4-letter nomenclature system. The first one is designating which is the chamber that is pacing. So if the nomenclature is VVIR, that means it is pacing only the ventricle. The next letter is, which is the chamber that is being sensed. The VVIR, again, the next V means it is sensing only the ventricle. So it will never pace the atria, it will never pace the ventricle. The third one is VVI. I means that is, it is getting inhibited whenever it is sensing any intrinsic signal from the heart. So whenever there is a native QRS generated within the heart, the pacemaker will get inhibited. And if there is no native QRS, the pacemaker will get triggered and give a electrical complex. And the fourth one is the rate responsive. I will discuss it just in the next slide. So in case of the DDDR, that means it will pace both the ventricle and the atria. It will sense both the ventricle and the atria, and it will respond in a reciprocal manner. Like whenever there is a P wave intrinsic, the atrial lead will get inhibited, whereas the ventricular lead will get triggered, and the reverse and vice versa. So that is a nomenclature system. There are all other ways are out there, the VVO, VO, DDD, VDD, but most of the times we do get only 2 types, that is the VVI and DDD. So what is the rate response? Whenever we are resting, our heart rate in a resting state, but whenever we are working, we need more cardiac output, so the heart rate should increase. Modern day pacemaker is having this kind of the rate responsive ability, so it can increase the heart rate to some extent. So what is AV synchrony? In dual chamber pacemaker, there will be a synchronous contraction of the atria and the ventricle. They are married together, whereas in a single chamber pacemaker, it is not possible. They are to some extent divorced. So in an asynchronous pacing, it is the VVI pacing, whereas the synchronous pacing, it is the DDD pacing, or it can be VDD, but VDD is not very commonly done. So let us just consider only the DDD. So these are the 3 prototype kinds of ECGs. One is the atrial. The first panel is the atrial. You can see over here. This is the atrial spike followed by capture of the myocardium and showing the P wave, and then after the native QRS. So this patient was probably having a sick sinus syndrome where it is dependent upon the pacemaker's P spike or the atrial spike. Now next one is the VO mode, where the P QRS is dissociated completely, whereas only the pacing spike is occurring over the QRS and being captured and the QRS being generated. There is no spike before any P wave. So this is a ventricular pacing single chamber. Whereas in DO, that is the dual chamber pacing, you can see the spike before the P wave followed by the spike before the QRS and being captured. One thing I would like to draw your attention towards over here, that in case of a native QRS, the QRS duration is always narrow, provided the patient is not having any underlying bundle branch block. But whenever there is a pacing QRS, the QRS is almost always wide. The reason is that the ventricular lead is being paced in a single ventricle within the RV. So naturally, the complex which is being generated, the current will propagate from one ventricle towards the other. So there will always be a inherent bundle branch block pattern in a pace rhythm until and otherwise we are using a CRTD where we are putting both the leads over the LV and the RV, or we are putting the lead over the septum through which we can generate a narrow QRS. Otherwise, in almost always we will get a wider QRS, and this is important. So again, this is a spike and capture of an AI pacing. That is the atrial pacing. You can see over here, this is the biggest spike of the unipolar type followed by the P wave, and there is the native QRS complex. Again, this is a VVE, same note. Now this is here in this ECG, I would like to draw your attention. This is a single chamber pacemaker, and here the pacing spike is smaller. Why? Again, this is the pacing spike is bigger, and next here the pacing spike are smaller. Nowadays, most of the times, even the pacing spikes are so small, it is to some extent even invisible unless you are looking for it very carefully. The reason is, the first one was the unipolar type. There is the cathode is over here, whereas the anode is over here. So naturally the current area is extreme, the field is very big. So naturally you are getting the spike bigger. The problem with this kind of that, whenever this field is big, there will be more chances of the external interference. Whereas the modern, most of the times what we are using nowadays is the bipolar type, where the entire electrical circuit is located over here. So naturally there will be less interference to the external electrical activities like muscle twitching or like that. Now, a dual chamber pacemaker works in 4 ways. So let us start from this third complex. Here the patient has got his own P wave followed by a own QRS complex. This is the A-sense V-sense. Whereas if there is a spike before the P wave, this is the A pace followed by patient's own QRS, that is the V-sense. And here this is patient's own P wave followed by a paced QRS. This is A-sense V pace. And in the maximum possibility that both the P and QRS is being paced, that is A pace, V pace. So these are the 4 ways how a dual chamber pacemaker can work. So what are the types of pacemaker failure? It can be of 2 types. One is the failure to sense, other is the failure to pace. Now, the failure to sense can be of 2 types. One, pacemaker is under sensing, that is, it is not looking properly, or it is over sensing, or it is looking too much. The second possibility is failure to pace. Now, there can be 2 other possibilities. One is there can be complete output failure, that the pacemaker is not giving any current at all. That was our case in that elderly lady where we have seen no pacing spike at all. So battery is completely exhausted, nothing is working. And the other chance is battery is giving the spike, whereas the myocardium is not being able to capture. That is the failure to capture. So let us come to the failure to sense. Here the first one is the oversensing. It means that pacemaker looks too much and does nothing. So no pacing artifact when it should be. If you look at this ECG, there is the pacing spike followed by a QRS, then only P wave, no QRS. So ideally pacemaker should give a pacing spike and there should be a QRS complex. So it can be a possibility that pacemaker is oversensing. What does it mean? That pacemaker feels that there is probably some QRS which actually is not there. This is called oversensing. It is looking too much. There is nothing, but it is thinking that there is something. This is called oversensing. Or it can be a possibility that the pulse generator or the battery is completely depleted, so it's not being able to give anything. There is an output failure. So if I get this kind of ECG, there are 2 possibilities. Either it is a failure oversensing or it's an output failure. The second one is undersensing. That means it doesn't look at all. That pacemaker is basically blind, it doesn't look at all. Pacing artifact is present when it should not be. Like in this case, there is an intrinsic QRS complex and pacemaker should give no pacing spike, but it is giving. So it is not sensing this native QRS complex. So this is an undersensing. So what are the failure to pace? This is the pacemaker lead tip and this is the myocardium tissue. So the current is coming, it will have to fire this tissue. So it can be a problem over here. That is the output failure, which was in our case, and it can be problem over here. That is the capture failure. So both of them are possible. So there is the pacing spike, but no capture. This is the capture failure. The commonest possibility is that there is a lead dislodgement. The initial part of the first few weeks, pacemaker after implantation, the lead may get dislodged, and there may be pacing artifact, but no capture. Whereas this is the failure to pace. It can be because of the oversensing, or it can be because of the complete exhaustion of the pulse generator. Again, you can see over here, this is the pacing spike, no QRS, but again, there is an intermittent capture and the capture failure. These are the capture failure. Again, this is a ECG of the capture failure. You can see the spikes, but no capture. So in a nutshell, I have drawn this picture to help to understand the entire dysfunction. Just concentrate on the QRS complex. This is a pacing spike, followed a QRS complex. Suppose the pacemaker been programmed to give a pacing spike every per second. There is a 60 beats per minute. This is the normal pacemaker function, spike and capture, spike and capture. Then all on a sudden, there is a straight line. So there should be another spike. It is not happening. So it can be failure to pace. It can be failure to sense. That is output failure or oversensing. Just do one thing, use a magnet. Magnet decreases or stops the sensing function of the pacemaker. So the moment when we are doing a magnet, the sensing function will go away. So again, the pacemaker will start showing the spikes. So if it happens, then it is a case of oversensing. We can just treat this by proper programming. Or if even after application of the magnet, there is no spike at all, that means it is a complete output failure and the pacemaker pulse generator had to be replaced. I will take just 5 minutes more. Then there is a native QRS. There is the 80 beats per minute. Native QRS rate is more than the pacemaker beat. So it has overcome it. Intrinsic beat. And after this intrinsic beat, all on a sudden, there is a spike. It should not come. So this is a failure to sense. That is an undersensing. Then again, there is after 60 beats, there is a pacing spike, but it is not being captured because it should have been captured. It is a failure to pace. Now someone may ask me that if there is a spike, why this QRS is not present here? It should have been captured. The reason is that the tissue is already in refractory period, so it cannot capture at that point. But here, when there is no refractory period, beyond the refractory period, it should capture the tissue, but there is no capture. So this is a capture failure case. Then again, there is the reversal of the pacemaker's normal function. So in this picture, I have tried to depict the entire dysfunction that is possible. So this is another slide that the residents who are present here can take a snapshot of these. So the first of all, the moment when you are seeing the pacemaker ECG, just try to locate whether there is any pacing artifact or not. If there is a pacing artifact, try to understand whether the pacing artifact is coming timely or not. If it is coming timely, then try to see whether it is capturing or not. If it is capturing, that means it is a normally functioning pacemaker. Now again, if the pacing artifact is coming normally, timing is okay, but the muscle is not responding, that means there is a capture failure. Next, the pacing artifact is there, but it is coming untimely. And naturally, there is no muscle response. There is the undersensing part that I've discussed. And again, if there is no pacing artifact and the pause is present, that means, and there is no muscle response, there is an oversense or output failure. So what a magnet does, we have already discussed.
Can we wind up?
Just 2 minutes. 2 minutes. Yeah. So again, the magnet and CID, the rate is increasing. You can see over here, magnet rate. This is the depleting pulse generator. Even after putting a magnet, the rate is not increasing. Different companies had got different magnet rates. When the depleting pulse generator is there, the magnet rate will gradually go down. That is one indicator or a clue that we take up. Sometimes, very rarely, you can get a pacemaker mediated tachycardia, which is very rare nowadays. You can just put a magnet over there and you can stop this phenomenon. You will be able to see that many a times pacemaker is actually functioning properly, but because of some superadded pathology, you are seeing that the pacemaker is not working. Like in this case of a hyperkalemia, it appears like the pacemaker is not working, but when after the correction of the potassium, the pacemaker was fine. You can diagnose the ACS even with the background of the pacemaker ECG. Even with the pacing rate, whenever the pacing rate is from a certain lower limit to an upper higher limit, pacemaker can act properly. But if the heart own rate is higher than that, there will be something called pacemaker Wenckebach or 2:1 AV block just to decrease the chance of the higher pacing of the ventricle. It can happen. So not all pause is bad. Just try to look whether the P wave rate is high or not and act accordingly. So just on my last slide, just go back to the year. It was a case of exhausted pulse generator. Patient was admitted for pulse generator replacement. old documents were sought, and it was found that she had 14 years back underwent a DDDR pacemaker implantation for 2:1 AV block, but then lost to follow-up. And the pulse generator replacement was done, and it was an uneventful recovery and follow-up. And you can see over there the classical DDDR pacemaker, where the patient is completely dependent on the atrial pacing and the ventricular pacing too. Thank you very much. Is there any doubt? I would like to clarify that.
Thank you, Moinak, for an exposition which was basic, fundamental, and important for us to understand. But I believe we need to practice this day in and day out if you have to remember. If there be any questions from the audience, or if there be none, we can close the session. I think, thank you, Moinak. Thank you very much.
Thank you. Thank you.
For your amendment to be presented by the chairpersons. And meanwhile, I'll request Dr. B.R. Hazra to please come and give the mementos to the chairpersons. Now I request Dr. Hazra to please give the mementos to our chairpersons, Dr. Siddharth Neogi, to Dr. Dipanjan, Dr. Supriyo Sarkar, and Dr. Niladri Sarkar. I'd now like to hand over to the organizers for the rest of the session.
Let's move on to our next session. And to chair this session, I would invite Dr. Alok Ghosh, Dr. C.K. Jana, and Dr. Jyotidev Mukhopadhyay to please come on the dais. Dr. Alok Ghosh is a past chairman of the API West Bengal chapter. Dr. C.K. Jana, he was my teacher and he was a professor of medicine of RG Kaur Medical College and Hospital. Dr. Jyotidev Mukhopadhyay, he was professor and ex-head Department of Medicine of IPGMER. Chairperson, sir. Yes. And to start the session, I would hand over the stage to the chairpersons.
The first speaker of the session is Professor Sujoy Ghosh. He needs no introduction. He is a good teacher, a great academician, a great clinician, and above all a scientist. And his topic of discussion will be breaking barriers of insulin initiation in tune with Indian patient need. So Professor Sujoy Ghosh, please start.
Thank you, respected chairperson, sir. Thank you and my regards to all my respected seniors, teachers, colleagues, and juniors. At the outset, I would like to thank API West Bengal for having given me this wonderful opportunity to interact with you. And I have firstly a disclosure that this is a pharma-sponsored talk. The slides have been provided by Novo Nordisk, but I will try to be as neutral in terms of the talk as possible. So I have been asked to talk on breaking barriers of insulin initiation, the problems and challenges in India. And that's the flow of my talk. We do understand that in India, we have certain specific problems when we are talking about management of diabetes. The first of which is our lifestyle. We all had lunch and a significant proportion of our lunch is carbohydrate. So carbohydrate intake is predominant source of energy intake in Indians, which therefore probably accounts for very high postprandial glucose levels. And in India, due to various reasons, you will see that our patients are reluctant to go on to insulin. We'll talk about those reasons. And therefore, most of our patients are on multiple oral anti-hyperglycemic agents. And if we are thinking of switching patients onto insulin, it has to be a relatively simple regime. We as doctors, when we were students, I think there were 2 chapters in pharmacology that everyone dreaded. One was antiarrhythmics and the other was insulin. The antiarrhythmics have become easier because almost everybody gets amiodarone nowadays and sorts out most of the problem of the antiarrhythmics. Insulin still remains a bit of a complication, not just for doctors and obviously for patients. Now, this slide is Dr. Shashank Joshi's study. We were one of the centers. The START study, which shows that, for example, here in Eastern India, 60% of our dietary intake is from carbohydrate. And the slide that is not shown here is Monier's study from the Western world, which suggested that at higher HbA1c levels, postprandial glucose contributed mainly to HbA1c. But once the blood glucose level comes down, the postprandial glucose contribution is relatively lower. But if you look at the Indian population or Asian population, the contribution of postprandial glucose seems to be high, whether you have a relatively lower HbA1c or whether you have a higher HbA1c. Now, if we are going to eat 3 meals a day, each one of which is predominant in carbohydrate, then that prolonged postprandial peak relatively leads us to almost a non-fasting state for 50% of the time and almost in a postprandial state in the rest of the 50% time. So essentially telling us that we need good postprandial glucose coverage. Therefore, if you're thinking of the Western world where they start insulin with a basal insulin alone, is it going to work? It's probably not going to work in an Indian scenario. 1, because we have a high carb diet. 2, it's not going to control your postprandial glucose. And the other thing is, when in the Western world people are started on insulin, they are relatively early on in the disease where there is some amount of basal insulin deficiency. By the time we start insulin, the patient not only has basal insulin deficiency, but also prandial insulin deficiency. So therefore, we probably need to initiate insulin therapy in most of our patients with not just basal insulin, but also prandial insulin therapy. So coming to the second bit about the barriers. Now, we in India and the rest of the world as well, we are not different. We treat to fail. You start lifestyle. When it doesn't work, you add a drug. When that doesn't work, you add another drug. When that doesn't work, you go on adding another drug. On the contrary, if we are aggressive from the very beginning itself, then probably if we have that kind of an approach, then over a period of time, the degree of uncontrolled hyperglycemia and the risk of complication probably goes down. Now, again, here you can see this is a study of Asian Indians compared to Pima Indians. It is clear that where in the Pima Indians, the predominant problem is insulin resistant, in Asian Indians, the predominant problem is beta cell dysfunction. So we are far more insulinopenic compared to our Western counterparts at similar degrees of hyperglycemia, telling us that insulin might be useful in a significant group of our patients. When we are talking about the inertia of insulin uses, the problem is not just with the patient, it's a problem with the physician as well. We as physicians are often hesitant and we decide upon, no, the patient is not going to want to take insulin. So we are worried more about our patients and saying, patient will have fear about injection, patient will have fear about hypoglycemia, patient will not want to take insulin. And we are worried that there will be problems of literacy because you think that the patient is not intelligent enough to store insulin, draw insulin, monitor insulin therapy, check blood glucose level, will not be able to go for dose adjustment. And the other major challenge is that, as doctors, We are more of prescribers rather than a team player. You need a dietitian, you need a diabetes educator, you need a counselor who is actually going to motivate the patient, support the patient, help the patient through the process of insulin initiation and titration. And what I tend to do in my clinical practice is, say for example, a patient is already on 2 or 3 drugs. I know that this patient is going to require insulin in the near future. Patient will often come and tell us, Dr. Babu, insulin deven na. So I tell them, before you leave my clinic, please take the first prick. See how it feels. Because the patient feels every injection will feel like either the tetanus injection or the IV venous sampling. The fact that the needles are so thin, you have to help the patient overcome the fear. So when he goes back with an additional tablet, knows that I will have to go on to insulin, say 6 months, 1 year down the line, the patient is much more comfortable in accepting insulin in such circumstances. And we as doctors are to blame in the sense that we tend to tell the patient, do this, do that, cut down on your diet. Eta jodi na koren tale kintu insulin diye debo. So don't use insulin as something of a punishment or something of a, don't make the patient feel that he is a failure, because patients come and say, doctor, I have tried my best, but still you are saying I need insulin. So explain to the normal natural history of diabetes that insulin is an inevitable requirement. The disease is progressive and it is not your fault. So the possible solutions I've actually indirectly talked about, that is, you have to have a discussion with the patient. You have to have realistic goals about the patient, explain that the treatment changes are a normal part of the natural history of the disease, explain that insulin is actually good for the patient, because a lot of people think insulin, last stage. There's nothing like that. So you've got to explain to that and address the fears, be compassionate, have empathy when you're addressing the issues that the patient is facing. So finally, coming to the last bit, that is individualizing therapy. And because it's a sponsored talk, as you can see, this talks about the co-formulation of degludec and aspart. So all of you are aware that in this co-formulation available as Rhizodec, you have insulin degludec as 70% and insulin aspart as 30% pre-mixed in a vial or a syringe. So once you inject the co-formulation, what happens is you have 2 bits, that is the aspart hexamer and you have the degludec dihexamer. Once it is injected, the aspart quickly releases from the subcutaneous space and the dihexamer forms multiple longer chain, which slowly releases so that you have a good component of a basal insulin. So this is one of the clinical trials. Remember, any clinical trial can be designed to show that any insulin is better than whatever other comparator you want. But to think of the basic principle, this is a trial looking at individual who is on a basal insulin alone versus Rhizodec. So now obviously, because if you're comparing an insulin which has got only a basal component versus an insulin which has got both basal and prandial control, if you have patients who have both fasting and PP defect, obviously the Rhizodec is going to benefit in terms of HbA1c reduction, even though with similar fasting glucose control. The PP, obviously, when you have a prandial component, will do better. The risk of hypos are slightly lower numerically, and more number of individuals will achieve targets of less than 7% if you use a co-formulation versus any basal insulin without actually having further hypoglycemia. So if you look at IDEC, aspart, because it's got the prandial component, obviously, even if you have a high carb diet and a high postprandial glucose level, it will work. And individuals who are uncontrolled on multiple oral agents, they are going to be benefited from such a therapy. And you can start therapy with Rhizodec and you can go on. So this is an insulin with which you can initiate insulin therapy and you can also intensify insulin therapy. Maybe you've started it once a day, then you can go for twice a day, and whatever dose you started with, you can always up titrate. So this is from our own RSSDI ESI practice guidelines. So of the numerous insulins that we talk about, IDEC aspart is also recommended as one of the options of insulin initiation. So to summarize, we do understand that in Indians, we have high carbohydrate diet intake and therefore not surprisingly high postprandial glucose values. High carbohydrate intake and high postprandial glucose intake, of course, are independent risk factors for cardiovascular disease and mortality. Studies have shown that there is significant correlation with postprandial glucose with A1C than fasting glucose in the Indian context. And therefore, any insulin which has got both a prandial as well as a basal component is going to be very effective in the Indian scenario. Thank you very much for your patient hearing.
Thank you. Thank you. Any question, any suggestion from floor? Any question?
Right. The cost is, of course, more than, say, for example, if you're looking at human premixed or even analog premixed. Now, you have to decide upon which insulin you are going to use in which individual, basically on a couple of things. One, of course, is cost. But if you think that somebody is taking, say, for example, a very heavy breakfast, does not take that heavy a lunch, then you give something like Rhizodec. The prandial component will be very well controlled and the risk of hypoglycemia will be lesser and the fasting will be better controlled. But remember, you should not be comparing insulin A versus B. Every insulin has a place in management of diabetes. It has to be individualized.
Any earlier combination? These are new, costly ones. Earlier combination, any suggestion?
So you can see, if there are various ways of looking at it. If the costs were same, I would say analog insulin premix is better than human premix. But the difference is very, very subtle. For example, if you look at the Cochrane review, there is very little difference in terms of the hypoglycemia benefits. But there is some amount of benefit. So if you are unable to afford, human premix is good enough. If you're able to afford, Rhizodec is probably better than, say, Novomix.
So this is treatment related barrier. So what is your suggestion regarding cost of therapy and insurance?
Sorry, sir?
Insurance and cost of therapy.
Insurance with this?
Yes. Role of insurance.
Role of insurance?
Yes.
Right. Unlike the Western world, in India, we have very few insurance companies who are going to actually reimburse for any therapy in diabetes. There are 2 or 3 companies who are currently doing it, but at a much higher premium. So that's the challenge and the problem.
Yes, let us wind up this session. If you've got any other question, or if you have got no question, let us wind up the session.
Thank you, sirs. And I'd request our honorable chairperson, sirs, to please present our token of appreciation to Dr. Sujoy Ghosh. Dr. Ghosh, sir, please accept the memento from our chairpersons. Thank you, sir. And to present that mementos to our chairpersons, I request Dr. S.B. Ganguly to please come up on the dais. Everybody seems to be asleep. We don't have any applause. I don't know. So many are here, but we don't have any applause. Thank you. That proves that you are not asleep. Thank you. Thank you, S.B. Ganguly, sir. Thank you to all our chairpersons and thank you to the speakers. And before moving on to the next session, I invite Dr. Atanu Chando to please declare the qualified teams who have qualified for the quiz, the final rounds. Dr. Atanu.
So we have one team from NRS Medical College led by Dr. Aradhya Bagchi, one team from Ajikar Medical College led by Moni Shankar Bhattacharya, and one team from CNMC led by Anushtu Mukherjee. And we had 3 teams from Calcutta Medical College and 2 teams from IPGMA. That's why we conducted a eliminator round. And in that round, 3 teams have been qualified. So one team led by Dr. Kaushik Kormakar from IPGMA, they have qualified. And another 2 teams, they both scored 7 marks. That's why both of them are qualified for the main round. So one team from MCK led by Obhinabo Dotto and another team from IPGMA led by Devrup Sengupta. So these 6 teams have been qualified for the main round of the quiz contest.
But we don't have any applause again. The postgraduates have qualified and there's a big round of applause for everybody who had participated. And we missed one thing. And so I'd request our Honorable Secretary, sir, to please present memento to the last session's reporter, Dr. Mary De Cruz. Ma'am, please.
It's my proud privilege to offer a memento to our most active person, that is Dr. Mary De Cruz.
Okay, thank you. Thank you, sir and ma'am. So now let's move on to the next session of Professor Shyamul Sen Memorial Oration. To conduct this session, I request Dr. Nandini Chatterjee to please take over the mic.
Good afternoon. Our next session is dedicated to the memory of a towering personality in the field of neurology, Professor Shyamul Kumar Sen. This session will be a competitive short paper session. Each lecture will be of 6 minutes with a 2-minute discussion and interaction with the chairpersons. Now, may I invite the chairpersons for this session, Professor R.N. Sarkar, ex-HOD, Medical College, Kolkata, and governing body member API, Professor M.K. Rai, ex-professor, National Medical College, and Secretary ICP West Bengal, Professor S.B. Ganguly, ex-professor, Medical College, Kolkata, and governing body member, and Professor Madhu Chandakar, HOD Oncohematology, Peerless Hospital, Kolkata. Now, I would request Professor M.K. Roy to say a few words as a tribute to Professor Shyamul Sen. Professor Rai had done his post-graduation under Professor Sen. Professor Rai, please.
Respected chairperson, sirs, distinguished members of the House, my junior colleagues, it's really a proud privilege and fortunate opportunity for me to speak a few words about a legendary figure in the field of medicine and neurology, where I had an opportunity and privilege to work for more than 2 years at Vivekananda Institute of Medical Sciences. He was my direct guide and an excellent teacher, mentor, and a philosopher. Whatever I have learned today, very small thing even in my life, like collecting pebbles in the seashore, it is due to him. So, with a broken heart, I pay my best homage to his feet. And just for the newer generation, I like to narrate a few words about this illustrious personality, what he was. Professor Sen is a legend in the field of neurology in India and pioneer in neurology teaching, training, research, in eastern region of this country. He was born on 1st April 1922. That is today, this year is the birth centenary. He was born in the district of Bankura, West Bengal. Dr. Sen graduated from Medical College, Kolkata in 1945. He worked in United Kingdom, and you will be surprised to know he worked under two legendary figures, Lord Russell Brain and Edwin Bickerstaff, and trained in clinical neurophysiology. Later, he established the Department of Neurology in Medical College, Kolkata, as well as in BIMS, that is Vivekananda Institute of Medical Sciences, Calcutta. He was in charge of the Department of Neurology at the Institute of Postgraduate Medical Education and Research, Kolkata, and Bangalore Institute of Neurology, where he started active teaching and training in Diom Neurology residents. He was a brilliant teacher, compassionate physician, and a successful administrator. He had been the key person to found the West Bengal branch of Association of Physicians of India. He became the president of Association of Neuroscientists of Eastern Region. He became the president of API West Bengal chapter from 1980 to 84. He also was the president of API Center in 1985 and president of Neurology Society of India, NSI, in 1988. Professor Sen became the first dean, that is ICP, in 1990-91. That was established under the auspice of API with effect from 1986. Unfortunately, in 2003, he suffered from a stroke and was left with marked expressive dysphagia. Despite such impediment, until few months prior to that, he regularly used to attend most of the neurological teaching meetings in the city. He will be always revered and as a loved teacher, guide, and mentor to all those who had been in touch with him by this illustrious personality. Thank you very much.
Thank you, Minal, for those words about Professor Sen. And it's our privilege to honor him in this centenary year. Now, we have this rapid fire session. We have 7 participants. I will call Dr. Bibha Bhagat, geriatric sleep disorder. Now, time is 6 minutes, 2 minutes for interaction. This time is have also an important point.
Otonu, please give the timers. And so that we can understand that they completed the 6 minutes.
Good afternoon, my respected teachers and my dear colleagues. My topic for presentation today is geriatric sleep disorder. This topic is so relevant because we live in an aging world. The elderly population is the only age segment of the population that is expected to grow substantially in the next quarter century. Few areas in current medical practice present a challenge quite as daunting as that of geriatric sleep disorder, because this is complicated by normal aging process and associated medical conditions and other co-administered medications. So having a sound knowledge is very important, and it can be a valuable component for elderly care population. The sleep architecture in elderly differs markedly from that of young individual. The light sleep, that is stage 1 and 2 of NRDM, increases, resulting in more awakening. The slow wave sleep, that is deep sleep, decreases in duration from 25% in younger individual to 3% in elderly individual. The depth of slow wave sleep also decreases significantly. There is also decreased amount of REM sleep. With aging, there is loss of neurons in suprachiasmatic nucleus of hypothalamus. This results in reduced melatonin surge. And this results in dysynchrony of endogenous circadian rhythms, including sleep-wake cycle. Having discussed the pathophysiology, let us now come to the common sleep disorders in elderly. They are advanced sleep-wake phase disorder, sleep disorder breathing, insomnia, periodic limb movement disorder, and rapid eye movement sleep behavior disorder. There is advanced sleep-wake phase disorder in elderly. The elderly people feel sleepy in the evening time, even in socially inappropriate setting. They are also unable to sleep beyond 5 a.m. in the morning time. There is early onset melatonin secretion in the evening time, and bright light therapy and blue-enriched phototherapy helps them to reset their circadian clock to a more socially acceptable circadian sleep schedule. Sleep disorder breathing. Recurrent episodes of apnea and hypopnea during sleep causes arousal and hypoxemia. This is associated with increased cardiovascular mortality and cerebrovascular mortality, and also causes earlier cognitive impairment. The treatment is mainly based on the reduction of the obesity, continuous positive airway pressure, and hypoglossal nerve stimulation. Now let us discuss about insomnia. Insomnia needs evaluation when it is associated with significant impairment of daytime functioning. We have to evaluate the patient by taking proper sleep history, that is timing of insomnia, sleep schedule, sleep hygiene, daytime symptoms, and other associated sleep behavior. We have to also take history regarding coexistent medical disorders like any painful conditions like neuropathy or rheumatological disorder, dyspnea from any causes, or any dementia like Parkinson's disease or Alzheimer's disease. We have to also take history regarding symptoms of certain psychiatric disorder like depression, mania, hypomania, psychosis, anxiety, etc. The treatment is mainly based on treating the associated mental and physical illness. We have to also adjust the type, doses, and timing of medication that can cause insomnia. We have to also treat the breathing-related sleep disorder. Non-pharmacological therapy like optimization of sleep hygiene and cognitive behavioral therapy form the mainstay of treatment, and their effect persists even after termination of therapy. If in patient we are non-responsive to those measures, we have to give psychopharmacotherapy in the form of benzodiazepine anxiolytics like alprazolam, lorazepam, etc. Non-benzodiazepine medications like zolpidem, zalipron, azopiclone, they are also very effective, having fewer side effects. Now coming to periodic limb movement disorders. There is complex involuntary limb movements involving the triple flexion reflex with extension of great toe and dorsiflexion of foot that last for about 0.5 to 5 seconds and occur every 20 to 40 seconds interval during NREM sleep. There is no gender difference as such. Use of SSRI and tricyclic antidepressants may lead to this kind of disorder. We have to treat the patient by avoiding alcohol, caffeine, tricyclic antidepressant, and dopaminergic agents like levodopa, ropinirole have significant role. Now coming to rapid eye movement sleep behavior disorder. The prevalence of REM sleep behavior disorder increases with age, and there is no such gender, and this is more common in males. About 2% of individuals of more than 70 years have this disorder. The causes may be primary or may be associated with neurodegenerative illnesses like dementia with Lewy body, Parkinson's disease, or multiple system atrophy. The treatment in REM sleep behavior disorder, the atonia associated with REM sleep is incomplete, and as a result, dream is acted out physically. So while treating the patient, we have to make the environment safer by padding of the bed and removing the sharp objects. Antidepressant medications like mirtazapine is helpful by virtue of its REM suppressing effect. Now coming to the conclusion, Sleep company in older adults need to be approached on a patient-by-patient basis. The caregiver must be educated about the physiological changes in sleep pattern of the elderly, and proper diagnosis is very important to avoid inappropriate use of hypnotics. Medications should be reviewed frequently with preference to limit pharmacological intervention. Thank you.
Thank you. You have just finished in time. Now, you said that there are some other, you have to answer questions because 2 minutes for interaction, no? Now, there are other, what are other problem in the geriatric, like what about restless leg syndrome?
Restless leg syndrome may also occur in the elderly. If there is associated anemia, diabetes, or vitamin B12 deficiency, then the prevalence of restless leg syndrome increases.
Or whether you want to give some drugs and which drugs you prefer actually.
If non-pharmacological.
Because you have to distinguish between primary and secondary.
Yes.
So if the patient has any comorbid conditions, most of the elderly people suffer from the chronic obstructive lung disease, obstructive sleep apnea, chronic renal failure, cardiovascular disease. So this is a big chunk which can cause the insomnia.
Yes, sir.
So you have to exclude those things first. Out of, if you have after exclusion, which drug, when the pharmacotherapy you advocate, and which drug you prefer?
If there is no evidence of obstructive sleep apnea, then we can use benzodiazepines. The benzodiazepines may be shorter acting agents are more preferable, like lorazepam, alprazolam, etc. And non-benzodiazepines drugs are very, very preferable because the side effects are very less, no chance of exaggeration of obstructive sleep apnea as well. And one of the drugs, that is azathioprine, is very effective because this correct the 4 domains of insomnia. That is, both it treats sleep onset insomnia, sleep maintenance insomnia, and it also increases the efficiency of sleep. So that is preferable.
Okay. Then tell me one most serious complication of these geriatric sleep disorders.
Okay. So geriatric sleep disorder increases the cardiovascular mortality, like prevalence of hypertension increases, it might lead to active myocardial infarction. Thank you, sir.
No, one question more. Okay.
One question from the floor.
2 minutes, sir.
2 minutes, sure, sure. Okay. Next, take it on.
Now I call upon Oritra Kumar Rai. He will be talking on e-cigarettes, cancer, any association. E-cigarettes and cancer, any association.
Good afternoon, my respected teachers and dear colleagues. Myself, Dr. Oritra Kumar Rai, currently working as senior resident in the Department of General Medicine, RGKar Medical College and Hospital. And today's my topic of discussion is on e-cigarettes and cancer, any association. So what are e-cigarettes? An electronic cigarettes or e-cigarette is a handheld electronic device that simulates the feeling of smoking. These devices have various names, including e-hookahs, e-cigs, electronic nicotine delivery systems, vapes, vaporizers, and vape pens. They come in a range of shapes and sizes. They can look like pipes, pens, cigars, USB flash drives, or maybe in other forms. So how do e-cigarettes work? There is a mouthpiece, which is a cartridge fixed to the end of a tube. Inside is a small plastic cup containing absorbent material soaked in a liquid solution. There is an atomizer which hits the liquid, causing it to vaporize so that a person can inhale it. There is a battery which powers the heating element. There is a sensor which activates the heater when the user sucks on the device. There is a solution which is the e-liquid or e-juice, which contains a combination of nicotine, a base, which is usually propylene glycol, and flavoring. Now coming to vaping. So what is vaping? The use of e-cigarettes is often referred to as vaping because many people believe e-cigarettes create a vapor which is then inhaled. But in reality, e-cigarettes produce an aerosol which are made up of teeny particles which is different from a vapor. Now the question is, do e-cigarettes contain nicotine like the conventional smoking? The e-liquid in most e-cigarettes contains nicotine, the same addictive drug that is in regular cigarettes, cigars, hookahs, and other tobacco products. However, nicotine levels are not the same in all types of e-cigarettes. one brand of e-cigarette, namely Juuls, have significantly higher amount of nicotine per puff than some other types of e-cigarettes and cigarettes. There are some e-cigarettes brands that claim to be nicotine-free but have been found to contain nicotine. Now, what is in the aerosol of an e-cigarette? Although the term vapor may sound harmless, the aerosol that comes out of an e-cigarette is not water vapor and can be harmful. The aerosol from an e-cigarette can contain nicotine and other substances that are addictive and can cause lung disease, heart disease, and cancer. Now, the contents of an e-cigarette vapor, it contains mainly nicotine, which can affect brain development of fetus during pregnancy. It contains propylene glycol, vegetable glycerin, hazardous metals such as lead and cadmium, volatile organic compounds, flavoring chemicals, acetaldehyde and formaldehyde, which are cancer-causing substance that may form if a liquid overheats. Now, this picture shows the effects of vaping into the pulmonary system. And as we can see, there are airway inflammation and injury, as well as alveolar inflammation and injury. This picture depicts a computer tomographic scan of the chest obtained from patients with vaping-associated lung injury. Now, this is a pathway through this is a picture which depicts the effects of how the nicotine leads to stimulation of tumor initiation, progression, and metastasis. As we can see from the picture, nicotine leads to stimulation of tumor initiation, progression, and metastasis through two different pathways. One is the direct pathway and is the indirect pathway through increased sympathetoadrenal system activity. Now, coming to the direct pathway, nicotinic receptors are expressed on the surface of the tumor and immune cells, thereby enabling nicotine to directly affect the tumor microenvironment. Binding to the nicotinic receptors, nicotine may potentiate cancer cell survival, tumor cell proliferation, metastasis, invasion, epithelial mesenchymal transition, and angiogenesis. It can also reduce cancer cell apoptosis. Nicotine may also stimulate proliferation and angiogenesis through the induction of norepinephrine and epinephrine synthesis in the colorectal and pancreatic tumor cells. Now, coming to the indirect pathway, it has been found that sympathetoadrenal system stimulates both carcinogenesis and processes related to tumor progression and metastasis. These important effects are induced by norepinephrine release from the nerve terminals and tissues innervated by the sympathetic nervous system, as well as by epinephrine and norepinephrine release from the adrenal medulla into the systemic circulation. Now, the actions of the epinephrine and norepinephrine, which gets released, leads to potentiation of it potentiates the induction of DNA mutations, activate oncogenes, induce tumor-promoting inflammation, inhibit anti-tumor immunity, directly stimulate the proliferation of tumor cells, protect cancer cells from apoptosis, potentiate both neoangiogenesis and lymphatic vessel rearrangement in tumor tissue, and it also stimulates the mobility and deformability of tumor cells, leading to metastasis. Now, coming to some important research, Park and colleagues showed that exposure to clinically relevant concentration of e-cigarette vapor conditioned media enhanced cancer-associated processes of at-risk airways, including a demonstrated capacity for malignant transformation. It was also demonstrated enhanced colony growth in encouraged independent assays and increased cell invasion associated morphologic changes were also demonstrated. Researchers also demonstrated that e-cigarette aerosol increased the pro-inflammatory cytokines IL-6 and IL-8, which through the STAT3 signaling cascade promotes lung cell cancer growth. There are some other researchers. In 2018, Stodds and colleagues demonstrated e-cigarettes induces tumor and metastasis promoting factors. It was also demonstrated that e-cigarettes enhance both the migration and stemness of non-small cell lung cancers. Don Massey and colleagues supported significant epigenetic changes in the oral cells of users of e-cigarettes. Now, what are the recommendations from the clinicians? Individuals, especially smokers, should be informed of the potential interconnection between e-cigarettes and cancers. Information about the stimulatory effect of nicotine and other chemicals inhaled from e-cigarettes on cancer initiation, progression, and development of metastasis must be specially provided to oncological patients and individuals with a predisposition to cancer. Now, to conclude, it is obvious that our understanding of the effects of e-cigarettes, especially long-term, is still fragmentary. Further preclinical and clinical studies focusing on elucidating the potential mechanisms and pathways interconnecting e-cigarettes and cancer are necessary. Thank you.
Okay, hello.
Yes, ma'am.
So why is there any concern about e-cigarettes and what is the legal scenario now?
Okay. Ma'am, e-cigarettes, as we can see, e-cigarettes contains all the harmful materials that are
Can you
contained in
name some of
content-
the harmful
I
ones?
have mentioned
You were
formaldehyde,
in such a
acrolein,
hurry, we couldn't.
formaldehyde, acetaldehyde, acrolein. It also, they are all carcinogenic, and mainly it contains nicotine, which leads to tumor initiation, progression through the, both the direct.
Silica is there,
Huh?
silicates, you have to say,
Yeah, yeah.
silicates are there, which causes the acute lung injury.
Yeah. E-cigarettes contain all the materials that are contained in the conventional.
So why
smoking.
did FDA allow e-cigarettes?
Because they are the incidence of lung cancer and all other harmful effects that a conventional cigarette can cause, the incidence is much lower in e-cigarettes. But still the chance of having a lung cancer and other carcinogenic effects is, though its incidence is low, but still it persists.
Okay, Arithro, the thing is actually India has banned. Since September 2019, we have e-cigarette ban. The reason is young people are getting more attracted towards e-cigarettes and ultimately they are taking up tobacco. So it is the nicotine effect
Yeah.
which is causing the harm.
Yeah.
So in India with the adolescent going for smoking, we have a different scenario than USA or UK. And as you said, the microenvironment leads to damage in the lung, which ultimately can cause lung cancer
Cancer,
as
yeah.
well. So we don't have in e-cigarette the tar. So remember that we don't have the tar that is there in the tobacco, which is the main carcinogen. But ultimately with the lung injury, repeated lung injury, we do get lung cancer possibility. Any other question?
It's nearly about 1/4 lesser than that of conventional cigarettes. Exact figure I don't have.
Yeah. Because the e-cigarettes actually has been banned in India.
Yeah.
This is number one. And it does not show any, some of the studies have been done, which does not show that it is anyway superior to the typical tobacco smoking. Rather, it is hazardous.
Yes, sir.
And it can be also taken by the adolescent because it is found in the small pen drive, like USB drive, small pen, so they can hide it inside their palms and they can take in the school, and during the sleep, sometime they find some leisure hours, they smoke, and that ultimately lead to some sort of abortment and sometimes punishment. So they leave it and they go to the tobacco smoking. So that is the reason, this is the most important reason for the ban in our country. I don't think it is right at this moment, it has got any place.
I've got very silly questions. For centuries together, yes, for centuries together, Indian people used to have hookah, which the nicotine or other materials passes through the water.
Yeah.
Does it has got any significance as far as the carcinogenicity, toxicity to the lungs are concerned? Does it have a less effect as the substances are going to the water?
So in hookahs, the amount of absorbed nicotine is around 1 mg. And in conventional cigarettes that we smoke, that is around the amount of absorbed nicotine is around 1 to 2 mg.
Shibenda, no method of smoking is harmless. Even vaping for the young, the vaping with this e-cigarette is harmful. Vaping. E-cigarette ke vaping bole, smoking bole na. So vaping.
So, thank you.
Thank you.
Now our next candidate is Dr. Ankon Pathak. Obesity and severe COPD is COVID-19 outcomes. Obesity and severe COVID-19 outcomes.
Good afternoon, everyone, respected judges and all the senior faculties. We'll be discussing on obesity and COVID-19 outcomes. So obesity initially was described as a state of excessive adipose tissue concentration leading to chronic health deterioration and long-term complications. And this was thought that endothelial dysfunction, being the root cause of concern in obesity, contributes to its increased mechanism of death and mortality in COVID-19. Until and unless this very article in Diet Doctor came about the relation between obesity and COVID-19. Following soon, this was one study which set the alarm bells ringing about obesity and COVID-19 being the two sides of the same coin. And following which we had our very own Indian study published in the Lancet journal by Dr. Santosh Kumar and his team, which said that the pandemic of obesity and COVID-19 is going to be the talk of the town for the next few years. If we actually look into this forest plot and how it actually occurred, we can see that unanimously almost all the studies went on to suggest that there was a definite positive correlation as far as obesity and COVID-19 outcome trials are concerned. If we actually go by our postgraduate trainee days where we studied about the aspect called obesity paradox, where we were initially taught that yes, although obesity patients do suffer from an increased risk of ICU admissions and morbidities, however, it is striking to notice that these patients do not have increased mortality as far as the other patients are compared with normal body weights. However, if we go back in date and compare the death rates in patients with influenza, parainfluenza, and rhinoviruses in comparison to the other normal diseases, obesity does tend to have a higher incidence of rate of infections and more morbidity and mortality. So this was what the details of all about obesity and COVID-19 came about, wherein in a state of excess adipose tissue concentration, there is elevated fatty acids, endoplasmic reticulum stress, and hypoxia, giving rise to an increased incidence of M1, increased prevalence of M1 macrophages, together with increased preponderance to develop higher levels of CD4 and CD8 T cells, reduced TREG cells and Th2 cells, which leads to a state of chronic inflammation, thereby giving rise to increased mortality. If we talk about the various systems and obesity, it obviously leads to a state of pulmonary restriction, leading to a fact we very well know about VP mismatch, respiratory muscle fatigue. And if we actually compare and contrast all this to an already immunocompromised host, we can be very sure that this patient these group of patients will do poorly as far as morbidity and mortality in COVID-19 is concerned. As far as thrombotic risk is concerned, obesity for all its complications is a known risk factor for development of venous thromboembolism, which includes both the DVT and pulmonary embolism. The major players behind this is actually chronic inflammation and a state of impaired fibrinolysis. An early study from Wuhan reported that mortality from COVID-19 was associated with significantly higher levels of D-dimer and FDP. Regarding immune functions, obesity is obviously associated with an increased rate of production of pro-inflammatory cytokines, TNF-alphas, interleukins, and interferons, and associated with increased activation of Th1 and 17 helper cells, and a reduction of anti-inflammatory Th2 and regulatory T cells. So if I have to sum up and say that SARS-CoV-2 virus in an obese host gives rise to an increased incidence of viral entry via the ACE2 receptor expression and an increased tune of viral spread, giving rise to a state of acute inflammation, together with leptin resistance in obese subjects with impaired immunity, is actually a ready recipe for increased incidence of mortality and morbidity. In obese individuals, there have been found that testosterone concentrations are lower in severe obese subjects, and lower testosterone patients are associated with reduced respiratory muscular activity and exercise capacity. However, to make things clear, there was a study done in Japan to treat patients of obesity with COVID-19 with testosterone injections, which again went on to show that this was not clinically feasible. As far as viral load and obesity is concerned, adults with obesity do tend to have higher viral loads and a longer shedding time with influenza virus. And during the 2009 influenza H1N1 pandemic, it was seen that higher BMIs and obesity was recognized as an independent risk factor with increased disease severity. To the last part of the talk, and whether COVID actually affects vaccination, the answer is yes, to a certain degree, only because of the reason why, because obesity is a driver of poor effector T cell mechanism and impaired memory T cells. And we all know that memory T cell responses do tend to play a very important role as far as vaccine efficacy is concerned. So to sum up in a nutshell, obesity and COVID-19 is not merely due to endothelial dysfunction and insulin resistance and its other comorbidities, it does tend to increase the impaired pulmonary perfusion associated with chronic inflammation, respiratory compromise, endocrine dysfunction, and immune dysregulation. So thank you.
Thank you. Thank you very much, Ankan, for your nice presentation. So, there are a lot of studies on outcome of COVID and your obesity. So, in most of the studies, they have shown the important three parameters. One parameter is that admission to hospital, one is your fatalities or death, and one is admission to ICU. Okay,
Yes, sir.
so do you find any J-shaped curve in any of the studies?
Yes, sir. In fact, there was one of my curves, this was a typical J-shaped curve. It was a typical J-shaped curve wherein it was found that even both undernutrition patient and overnutrition patient actually suffer from increased incidence of COVID mortality.
Below
And-
20 MI, below
Yes, sir.
20 MI also
and
got
also
the,
above 30 as well. And the other aspect is the obesity paradox, wherein, sir, in spite of patients who are suffering from severe obesity, we expect them to suffer from increased mortality rates. But it was actually seen that obese subjects, in spite of having higher morbidities, do not tend to have worse mortality in ICU patients.
In any obese person, the cardiovascular complications will be more.
Yes, sir.
And what is there in COVID person any special significance about pulmonary embolism in COVID, which is the most serious cause of death?
Yes, sir. Actually, it was the studies have seen that because it is a prothrombotic condition, there have been increased incidence of venous thromboembolism, and also because of associated rise of D-dimers and FDP, it is probably a prothrombotic state leading to increased incidence of pulmonary embolism.
So obesity is an independent risk
Yes,
factor?
sir. Not necessarily COVID itself, but
Not
it is-
because of the comorbid,
Yes,
other
no, sir.
comorbidities, it's an independent risk. Thank you.
Obesity, COVID with hypertension, without hypertension. Is there any mortality deficit, mortality increased with hypertension, without hypertension
Sir,
in obese patient of COVID?
Number of studies that I have gone through, I have not found there have been any difference between COVID with hypertension or COVID obese without hypertension. sir.
now, Dr. Shubham Bhowmik. Thank you, Ankan. Dr. Shubham Bhowmik, he will be talking on BP cuff measurement and fallacies.
Page down. No? A very good afternoon to all of you. So starting my topic, that is BP cuff and measurement fallacies. So we'll be going directly to the equipments first. So there are broadly two categories of equipments. That is, one is the mercury sphygmomanometer and one is the non-mercury sphygmomanometer. The non-mercury sphygmomanometer basically are of two types. One is the hybrid sphygmomanometer and one is the aneroid sphygmomanometer. These are non-automatic. The one that you see on your right is the hybrid sphygmomanometer. It is basically an aneroid device with a digital interface. Next one we have is an automatic sphygmomanometer. There are two types again. The one on your right is very familiar. That is the one we use in our ward, also in home for home BP measurement. And that is the upper arm oscillometric device. The one on your left is continuous oscillometric device, which is used in our ICUs. Now, according to the latest recommendations, the AHA 2017 and also the multiple recent guidelines recommends an automatic BP machine, an automatic BP machine that is seen on your left-hand side, upper arm bicep, to be used for standard measurements. Although the mercury sphygmomanometer is the most accurate and considered to be the gold standard, the Scientific Committee on Emerging and Newly Identified Health Risks 2009 has banned the device due to mercury toxicity. Calibration of an aneroid sphygmomanometer against a mercury device should be done every 6 months. Now coming to the origins of error, I'll be discussing them alongside the points of BP measurement. First step is selection of strategy. That is whether we want to measure by ambulatory BP measurement or home BP or office-based BP measurements. Next is proper preparation. So this is the proper preparation of the patient. The patient should be comfortably seated for at least 3 to 5 minutes. He or she should not smoke, have coffee or exercise 30 minutes prior to the test. Bladder should be emptied. The room should be quiet and comfortable. And as you can see, the patient's arm is rested on the table and his feet is lying on the floor. The patient and the examiner should not converse. They should be silent, and an appropriate sized cuff is used. Next is the selection of cuff. Now for selection of cuff, the width should be 20% more than the limb diameter or 40% of arm circumference, and the length should encircle more than 80% of the limb. The width is to length ratio should be 1:2. As you can see, the highlighted part shows a normal adult with an arm circumference of 27 to 34 centimeter, having 16 centimeter width and 30 centimeter long BP recommended cuff. Now, first we prepare the patient. Next thing we will check is what is the profile of the patient and whether the arm circumference is equal to the BP cuff size. If it does not, if it matches, then we can go to the conventional procedure of measuring the BP in the brachial artery. However, if it does not match, then we can use a thigh cuff. If we do not get a thigh cuff, we can use this same arm cuff over the forearm and measure the radial artery instead. The center of the cuff bladder should be over the brachial artery, and the lower margin of the cuff should be at least 1 inch above the antecubital fossa. First, use palpatory method, then use the auscultatory method. This is very important. Palpatory method is used to identify the systolic pressure. After that, we'll inflate the cuff to 20 millimeter mercury over anticipated systolic pressure, and then we'll deflate. And the deflation should not be more than 2 millimeter of mercury per second. Measure BP ideally in both the upper arms and also one lower limb at least. Then we come to a very familiar slide, that is the Korotkov sounds. There are 5 phases, but I will like to shift your focus to the different the phase between the phase 1 and phase 2, that is Ki and Kc, and that is the auscultatory gap. Now this may be missed if we directly proceed for the auscultatory method rather than doing the palpation first. So in errors in measurement, as I said, inappropriate sized cuffs may cause errors. Underestimation of blood pressure may also result if the bladder is protruded outside the cuff, and rapid deflation or slow deflation may cause errors. Now, this is a slide taken from the 2020 ISH guidelines. Now, according to this slide, I just have given this slide to show you that the definition of hypertension varies with the strategy that we use. That is, for office BP, it is more than equal to 140 SBP and more than equal to 90 DBP. But in case of ambulatory BP measurement or home BP, it will vary. Second, this slide also I have taken to show you that the category of high normal BP is a high risk candidate. And in this case, if in office BP we get a high range normal BP, then we should collaborate our findings by doing ambulatory BP and home BP measurements. This is important because there are 2 entities, that is the white coat hypertension and masked hypertension. White coat hypertension is elevated BP in the office, but normal BP on ABPM or HBPM. Masked hypertension is non-elevated office BP, but elevated BP on ABPM or HBPM. Now, white coat hypertension has low cardiac risk, but the masked hypertension has a very high cardiac risk, and the risk is almost equal to those with sustained hypertension. Last, another error that may arise is a pseudo hypertension, that is misleadingly high blood pressure measured with cuff as compared to intraarterial needle. Now, this we can do a bedside maneuver, that is the Osler maneuver, to differentiate this, and we can suspect this if the if the blood pressure do not match with the other clinical findings. So my take-home message, the very first thing that I should say is that while measuring the BP either in our clinic or in the ICU, we should not jump to conclusions immediately after measuring the BP at once. We should look at the patient profile, look at at the cuff we are using, the equipment that we are using, and whether his BMI is normal, greater or less. So that is very important, and that will decide his drugs. Second, all measurements should be clinically correlated. And according to the latest guidelines, that is the ICH to 2020 and the 2021 US Preventive Task Force guidelines, though ABPM, that is ambulatory BP monitoring, is the best method, but home BP monitoring is encouraged rather than the other strategies. Thank you.
The blood pressure of the leg by the cuff you use in hand, blood pressure will be more or less.
Sir, first of all, the blood pressure that we measure in the arm, the same cuff cannot be used in the leg. So, yes. Sir, in that case, I think a better measurement will be given if the arm cuff is used over the forearm and is measured over the radial artery. But if we measure it over the thigh, in that case, since the arm circumference is more, so there will be an overestimation of BP.
That means blood pressure will be high.
High.
That is the thing.
Yes.
Now, you tell me one thing, that how many cuffs one physician should keep in his chamber?
Sir, at least one cuff is what, that is a standard cuff.
3 is recommended. Because 22 to, there are 3 recordings
Yes.
you have shown. So you have to keep 3 at least. And one important point you have shown here that palpatory method is important. But if you use an automated instruments, how do you go for the palpatory method?
Sir, in automated instruments, the palpatory method cannot be done with an automated.
So in your take-home message, you have shown that it is the automated machine.
Sir,
But,
because guidelines are actually suggesting, because in all the manual BP measurements, the error chances are more.
Sphygmomanometer, the previous mercury is going to be obsolete, though it is the standard.
Yes,
but
yes,
it's
that
going
is
to
the-
obsolete.
But mercury is gold standard. It is the
Right.
most accurate.
What should be? Yeah. Right. Yeah. What will be the ideal time of taking home blood pressure?
Sir,
monitor?
for home BP measurement, actually, we should maintain a BP log. That is for 7 days, and the measurement will be taken in the
Because
morning.
there
and-
are dips, no, diagonal variations are there.
Yes, BP has diurnal variation. So in the morning and evening, both times the patient should record and he should maintain a log for 7 days.
Any question from the floor? Yeah.
Am I clear?
Yeah.
So guidelines suggest that it should be used, but basically the idea is we should not rely on one reading. We should do multiple measurements and then we should take the average. At least 3 measurements should be done and the average should be taken from the last 2 measurements.
Important problem is that loss of nighttime BP drop is a very important issue for the diagnosis of the hypertensive problems. If you do only by measuring your methods, is it a very important?
No.
So what is the time when you will think that oscillometric or ABPM should be replaced by the home blood pressure monitoring?
So ambulatory BP measurement is the only way we can differentiate between departs and non-departs. No other measurement can actually.
Absolutely, you are right. And in response to your question, it is the ideally there is nowadays there is a machine. Probably this company CISPAR or something like that. I have purchased one. They actually take the 3 readings and then you just put on the M, that mean will come out. So 3 readings are important to make the one standard blood pressure. Single reading will give you one idea, so another reading will be different, third reading will be different. So mean reading is important.
But 3 reading, hello, but 3 readings should not be taken on the same day.
Not in the same day, but they are doing in the same day. This machine is doing the same
so
day.
that is
but
not the ideal
ideally
way
it should be
to get
done in space between the days.
But, Gaonkar, the signal may be different. Suppose a patient came to me to know his or her blood pressure. Then I take Sunday, Monday, Tuesday. Tuesday evening, I will declare her blood pressure.
What is the what is the guideline that you should take at least 3 measurements in coming? If today some patient is hypertensive, he has come for the first time to your chamber, so you wait. If it is more than grade 2, that is 160 by 110, 100 or 110, you have to initiate therapy. But if it is in the borderline or grade 1 hypertensive, you should wait because it is not going to harm that patient.
That
by
is for a
waiting.
different, this
Yeah,
is a
yeah.
different story. That is a different story. Okay, thank you.
Yeah, Dr. Nair.
Now, Parinita, Nanjit, please come.
ঠিক আছে। Good afternoon, respected teachers, my colleagues and seniors. Today I am going to discuss artificial intelligence in cancer therapeutics. To understand that, we first discuss what is artificial intelligence. It is a branch of computer science which aims to evolve intelligent machines that simulate various human cognitive functions. In 1956, American scientist John McCarthy first coined the term artificial intelligence. To understand how it works, we have to understand two terms. One is machine learning and another is deep learning. What is machine learning? Machine learning basically a subset of artificial intelligence that focuses development of algorithm which use input data and statistical analysis to draw an inference without being explicitly programmed. And another thing is deep learning, which is an evolution of machine learning, uses multi-layered artificial network for extraction of higher level of features. The most popular variation of DL are CNN, that is convolutional neural network, and recurrent neural network. Regarding applications of artificial intelligence, in every aspect of our life, it has its applications. From healthcare, from drug discovery to patient data management, from precision oncology to next generation sequencing, in every aspect of healthcare, artificial intelligence has its footprints. In cancer diagnostic also, incorporation of artificial intelligence helps us to serve larger population, remove opportunities for human error, achieve greater safety and accuracy, and cut cost and time. Artificial intelligence in oncoimaging, mainly two important uses. One is cancer screening and another is clinical decision making and prognostication. To know that, we have to understand radiomimetics. What is that? This is extraction of a large number of image features from radiation images with a high throughput approach. This radiomimetics has its application in automated cancer screening to the use of image-based signature for precision oncology. This is the fundamental steps in radiomimetics pipeline, basically to understand region of interest. Now, regarding application, this artificial intelligence has been used in automated contouring of radiosensitive organs at risk and auto planning of radiation dose distribution, thus to save time and avoid excessive exposure. Also, it can predict response to new adjuvant chemotherapy in different cancers. Greater than 85% accuracy has been achieved in diagnosis of nodal and extranodal metastasis in case of head and neck cancers. These are the notable studies on application of artificial intelligence in oncoimaging. Among them, tumor detection and classification in breast cancer, early prediction of pathological complete response to new adjuvant chemotherapy in HER2 overexpressing tumors in breast cancer need to be mentioned. Also, artificial intelligence has its step on radiogenomic also. We can identify IDH mutation in gliomas. In oncopathology also, we can prepare a virtual optimal slide from a standard microscopic slide, which can further undergo different processing to have illustrated features. We can diagnose and prognosticate the tumors. These are the notable studies on application of artificial intelligence on oncopathologies. Among these, automated Gleason scoring of prostate cancers, automatic classification of ovarian cancer, detection of breast cancer in lymph nodes, and tumor classification and prediction in lung cancers is need to be mentioned. Also in translation oncology, which deals with various molecular pathways involved in tumor genesis, artificial intelligence has its application. It is now being increasingly utilized for their drug development and predicting the sensitivity of cancer cells to therapeutics. These are the notable studies in artificial intelligence in translational oncology also. But in spite of limitless possibility, it has some limitations also. These limitations are extrinsic limitations and intrinsic limitation. Extrinsic limitation due to human heterogeneity of human body. Each patient is a different clinical scenario and each tumor can behave differently in individuals. So a large volume of data is necessary for making a successful module. There lie ethical and legal issues concerning data collection and uses. Also, there is knowledge gaps. We clinicians have very little knowledge regarding the artificial intelligence used in clinical devices. And also the data scientists have very little knowledge regarding oncology management and protocol. So this knowledge gap must be addressed. And so to sum up, there is numerous chance of artificial intelligence from diagnosis to treatment in cancer therapy, but we must overcome the challenges also. So to conclude, artificial intelligence cannot be a foolproof panacea, nor it can replace the human being. We must keep humans in the loop and at every control, apex of every control to judge the clinical scenario. Thank you.
Hello. Ms. Poriniti, thank you for presenting something which is so close to my heart, because by now I have a lot of publications in artificial intelligence in cancer diagnostics. And my area of interest, yes, my area of interest has been typically lung cancer, where with the help of artificial intelligence, this is for the audience, we can really pick up those lung masses or nodules which must be biopsied and leave the ones which are unnecessarily being intervened and create fear amongst the patient. So my question to you is, what do you think will be more important in therapeutics? Is it the machine learning or the deep learning?
Ma'am, deep learning is an evolution of a machine learning.
Yes, so ultimately you will need the deep learning because you will have an algorithmic based approach.
Yes.
Is it?
Yes.
So
we have to draw conclusions. Or deep learning has an hierarchical authority. It can gain input from the previous memory also.
Yes.
But from machine learning.
Correct. So in therapeutics, your approach will be very individualistic approach.
Yeah.
That is what you're aiming.
Each patient has a different clinical
So
scenario.
correct. So I think the beauty of AI will be personalized approach. Am I right?
Yes.
That is what you're claiming. Any other question?
Any question from the
Few days ago, few months maybe, Dr. Sundar Pichai has posted to almost every Indian how to assess the vascular age and the quality of life of a person just by looking into the retinas. Do you think that will come up, particularly those who have advanced disease, as a part of the quality of life? The therapeutic armamentarium can be managed that way, depending upon the vascular age of the patient. Is it possible? Maybe some complicated. The quality of life assessed by only putting some retinal vessels out there. Can you assess the treatment modality as far as the quality of life is concerned in cancer?
I don't think this is her area of interest. I think most important question which
Subject wise, you ask any question in relation to cancer. But your question is very relevant. That was discussed, and it does. It very much does. The retina is one of the sensitive structures.
okay, T sharpener, G counter. Anyway,
Now the last.
no, one message which you should give in cancer therapeutics, your AI wanted to find out which are the patients who will respond.
Yeah.
Which is very important. You are using such very, very costly drugs, very, very costly radiation machine, you must understand who will respond and who will not. I think that is the most important point.
That I have mentioned, that translational oncology.
Yes,
You should
translational oncology. From bench to bedside it is going. Thank you.
Okay, thank you very much, Purinita, for your nice presentation. Now there is an announcement. There is an announcement from our chairman, API, Professor H.S. Pathak. He has announced that this is a competitive session and we have got 6 candidates today. So there will be first, second and third prizes officially declared at the valedictory session. And there will be 4th, 5th and 6th position also. So Professor Pathak has announced gladly that all will be given some awards, but
All
they
of them
must
are
have to stay. They must have to stay up to the valedictory session. That is the only one condition. Without their presence, if someone on their behalf comes for accepting the prize, we are not going to give that. So they will have to be on the valedictory session. 6 prizes will be given. First 3 will be declared as the winners, and rest 3 will be the consolation prizes on behalf of API West Bengal chapter by Professor H.S. Pathak. 3 from the API side and 3 from your side. Very simple. Yeah, of course. Next.
Prescribing long-term care by Dr. Shambhu Samadkar.
Thank you, Chairperson, sirs and madams and respected delegates. So it is a real honor to present this very important topic, which is core of my discipline, that is clinical pharmacology, that is deep prescribing in long-term care. So why deep prescribing is important in long-term care? Because of one very important issue, that is polypharmacy. If we can consider the 2 sides of Atlantic Ocean, the Europe and America, both of those areas, we can see the prevalence of polypharmacy is almost 40%. And here polypharmacy means numerically more than 5 drugs per prescription. And which is very threatening, that ambulatory elderly cancer patients, they are almost 84% of them taking more than 5 medications. And around 43%, they are taking more than 10 medicines. In India, the situation is again very challenging. The pooled prevalence of polypharmacy is almost 50%. Hyperpolypharmacy, that means more than 10 medicines per prescription, is almost 31%. And unfortunately but true, that potentially inappropriate medication use in India is around 28%. So what is polypharmacy? There is 2 types of definition. One is numerically and one is qualitatively. So numerically, it is defined as more than 5 medications used per person. It includes not only the prescribed drugs, but also the over-the-counter drugs, the complementary or supplementary different types of Ayurvedic medications, everything. But qualitative definition is much more important, and that defines the appropriateness of therapy and where the potential benefits outweigh the potential harms. So that is why the definition of potential inappropriate medication is very important to know. That is the medications with ineffectiveness or high risk benefit ratio for a particular individual or group of individuals. So another definition is there by WHO for one ambulatory patient. If for one particular indication he is taking more than 2 medications, that is also considered as polypharmacy. But here I just want to mention and emphasize, not all polypharmacy is irrational. There are also rational polypharmacy. In case of HIV, in case of tuberculosis, in case of complicated diabetes, there are rational polypharmacy also. So better to accept the definition of potentially inappropriate medications. And polypharmacy always is associated not only with inappropriate medications, but also the underused medications. And that is what's shown in one paper, that the relationship of polypharmacy and underprescribing. And that is why we need deprescribing. And deprescribing is not about just denying the effective treatment to eligible patients, but also it is a positive patient-centered intervention with inherent uncertainties there are, which requires shared decision-making, informed patient consent, and closed monitoring of the effects. So we need deprescribing. Sometimes before that, we need to diagnose the problem first. Then we need to take a therapeutic decision. And finally, after taking that therapeutic decision, we need to check whether that decision is helping to alter the natural history. So good prescribing is not just a snapshot, one prescription writing. It is a continuum. And that includes therapy initiation to dose titration to changing or adding dose. Then finally, the switching or ceasing some drug therapies which is going to harm. And before deprescribing, we need to evaluate the risk of polypharmacy. And there are lots of tools by which we can assess the risk, starting from Beer's criteria to stop criteria to there is some medication inappropriate index. And generally, this principle is very important while we need to follow while doing the deprescribing, that is clinical pharmacological review, reconciliation, and feedback of drug therapy. There are different parts of that concept, starting from to check whether there is any omission, commission, where there is some transition related issues like medication errors, different pharmacokinetic, pharmacodynamic rationale, and very importantly, often missed the affordability and availability of the drugs. Now coming to one case, a 61-year lady, diabetic, asthmatic, hypertensive, coronary artery disease with dyslipidemia, persisting peripheral edema for last 6 years, low back pain for 3 months. After falling in the bathroom, there is atrial fibrillation for 4 years back, asthma exacerbation leading to multiple visits in year, anemia, knee replacement done 3 years back. The patient is metformin intolerant. Now you can see the medication list. I am not going in details because there is lack of time, but I think this will be you can think of yourself and how we can actually address this medication list. And sometimes what I want to focus here, you can see naproxen 500 milligram BD. It was prescribed by one orthopedic physician for only 3 days or 4 days while she was suffering from fall. But the patient is taking over-the-counter drug. So we need to consider everything holistically. I am just going in the last slide because the algorithm, which is, I think, most important, we need to assess whether there is no benefit to particular given therapy. Then we need to check whether there is harm outweighs the benefit. Finally, the symptoms or disease for which I am prescribing, and while I am prescribing, then the symptoms is reducing or not, that is most important. And if I am using one statin to a patient who is suffering from pancreatic cancer, who is going to die maybe after 6 months, whether that is actually appropriate, we need to check. And what is most important, while we are deprescribing, we need to assess the withdrawal symptom, because withdrawal symptoms may arise some other atrocities that we need to take care of. And that is why one of the motto of deprescribing is prevention of this type of cascade, prescribing cascade. But one mantra we should follow, that is no blame, no shame, and no name. And with that, I just want to again thank the organizer for giving me this opportunity. Thank you very much.
Thank you, Shambhu. What is the meaning of that? No blame, no.
Yeah, so if I am doing some deprescribing to other prescribers, when a prescription came to me for this type of review, reconciliation, and feedback. So if I am doing some negative remarks, so that is very bad, I think. And that is what we should all follow while doing this type of deprescribing practice.
No medical judging.
Yes, sir?
No
Yeah,
judging.
yes, sir. Yes.
Now, I have got a small question for you. When especially this is applicable deprescribing in a geriatric age,
Yes, sir.
because there is a huge list of drugs they take. And whenever any patient comes to me for a neurological problem, I find that they've got cardiovascular problem, diabetic problem. So there are 3 or 4 prescriptions. So I try to make one single prescription. It takes some time. I just ask you, what are the things you need to take into consideration when you deprescribe the drugs? Whom are to be included in the because some of the people are cognitively not sound, some patients. So who are to be included when you are deprescribing the drug?
Yes, sir. Fine. The most important thing is that when the patient is taking multiple drugs, that is polypharmacy. And as you had mentioned that the elderly subjects, then we need to check. There is one very useful index, that is medication inappropriate index. There is 10 questions. And if we just check that 10 questions with that particular prescription, we'll get the answer. And we can do accordingly by deprescribing the specific drugs, which is not going to help the patient. And sometimes while doing deprescribing, we need to consider different types of OTC drugs too. I am not, due to paucity of time, I cannot discuss that case. But in that case, it was found the patient is taking naproxen for long duration without any indication. Patient is taking over-the-counter prednisolone for his asthma control. As the patient was prescribed with one MDI, which is containing salmeterol and fluticasone for COPD control, but that was costly. So that was she cannot buy that. Instead of that, she is taking that prednisolone tablet. So we need to take every issues, and while doing deprescribing, again we need to check the cost. The same patient is taking one insulin, that is Lispromix, which is very costly. So while doing the deprescribing, we may consider some human mixed insulin in this case. We may advocate, instead of salmeterol fluticasone combination, we can advise that patient to take that budesonide and formoterol combination, which is much cheaper, which may help the patient not to buy prednisolone over the counter to control his asthma symptoms. Yes, sir. That is very important, sir. That is also very important.
And another important, most of the time we see that patient is taking hydrochlorothiazide or chlorthalidone, and side by side has been prescribed uric lowering drug, uric acid lowering drug.
Yes, sir.
This would also be now last question.
Yes, sir.
I have got a patient admitted. Patient is taking
Sir,
heart failure.
1 minute, sir. Show that slide. This slide.
Yeah. Patient is having a heart failure management along with aspirin. Developed GI bleed. I stopped the aspirin and put the patient on clopidogrel, replacing that. But the patient died after 48 hours. And patient sued against me in the court. How I want to escape from that? Is it possible that deprescription can be protected legally?
Yes, sir. There are, if we can justify the deprescribing medico-legally, we can justify it. The court should not sue us. If we medically justify the deprescribing process, then we can the court cannot sue us. Sir, this is what I was showing, because this you were telling this same case that happened. Thank you, sir. Thank you.
Thank you, Shambho. I just have a comment for all the participants today. All the topics were very relevant. So relevance of the topic was nearly full marks to everybody. And most of you finished in time, except 1 or 2 overshooted, but very well managed as far as time. And slides were also quite standard. But what I found is everybody is trying to read everything in the slide, except Shambho. Everybody is trying to read all the things written in the slide. But that way it doesn't register to the public sitting in front of you. So make a gist and tell that when you present the slide. These were the comments I had.
Thank you. Thank you, everybody.
Pod. I congratulate all the participants for giving such crisp, well-researched talks. And now I would request the chairpersons to hand over mementos to our beloved participants. I call upon the stage Vibha, Oritro, Onkon, Shoham, Porinita, and Shambho. চলে এসো। Now I request Professor P.S. Kormokar to hand over mementos to the chairpersons.
I forgot to offer memento to our most valuable organizers and most beautiful organizers, rapporteur, that is Dr. Nandini Chatterjee, Madam. Thank you. I forgot it.
Should not have.
Now we are having only two exciting sessions left. One is quiz and another is our another is our two lectures. So there is a request from various corners that as quiz is very exciting and all the not only the participants but as well as the organizers as well as our audiences want to participate. So that's why the quiz will be arranged at last of the academic session. So for that reason, so the two lectures has been preponed before quiz competition. So I request our beloved young faculties and PGTs to come forward. They are from the very beginning, I'm seeing they are on the rear side. So one day you will definitely be on the front side. Why not from today? So please come forward. Please come forward, sit over there, enjoy two more lectures. Then you will be actively participating. Okay. So now the two lectures, that is the last session before quiz, last but one session. And this session will be chaired by Dr. Uttam Biswas, Dr. Uttam Biswas, are you here? Yes. He is Associate Professor of Bardhaman Medical College. He is all the way from Bardhaman to here, and he is spending all his total time over here and listening to all the lectures from the very beginning. Thank you, Dr. Uttam Biswas. Please have your seat. Now, another very active, our active API member, he is residing at Malda. So he is one of the very active faculty over Malda Medical College. I request Dr. Piyush Kanti Mandal to come over the dais. Oh, I am so sorry. Okay, okay. The 30th. Sorry. Acha, let Uttam Biswas be there. Okay, let Uttam Biswas be there. And another, oh, just the reverse. And the Dr. Ananda Bagchi sir, please come over the dais. You stay. Dr. Ananda Bagchi sir and Dr. Shoikat Datto, they will chair the last but one session. Dr. Shoikat Datto. Not Dr. Shoikat Datto. Dr. Ananda Bagchi is a senior consultant physician attached to Damnam Cantonment Hospital, and Dr. Shoikat Datto is Professor and HOD Department of Medicine, Kuch Bihar Medical College. So I hand over the podium to Dr. Ananda Bagchi and Dr. Shoikat Datto to initiate the proceeding. Over to Dr. Datto and Dr. Bagchi sir.
Respected seniors and colleagues and my beloved students, this is the penultimate academic session of this year's midterm API conference. There are 2 lectures in this session. First, loss of appetite myths and facts, which will be delivered by none other than Dr. Udas Ghosh, who needs no introduction. He's a professor of medicine in Medical College, Kolkata. And second talk will be delivered by, second talk will be on immunity booster in the new era, which will be delivered by Dr. Tanuka Mondal, who is a senior resident in RG Kar Medical College. I, on behalf of my co-chair, Dr. Shoikat Datto, invite Dr. Udas Ghosh to deliver his talk. Dr. Udas Ghosh, please.
Good evening to everybody. My topic is a loss of appetite, myths and facts. In my topic, I will discuss within a 15 minutes overview about the appetite, a physiology of appetite regulation, literature review, epidemiology, loss of appetite, convalescence road to recovery, and evidence generation insight from the physician and investigator initiated study, and myths and facts, and lastly conclusion. So what is appetite? Appetite is a desire to food, sometimes due to the hunger. And what? And hunger is a complex system of physical and hormonal signals that cause what is known as hunger. And decreased desire to eat is termed as anorexia. So our topic is the loss of appetite is the anorexia. So anorexia is basically divided a temporary anorexia and long-lasting anorexia, a brief anorexia, prolonged anorexia. A brief anorexia is a ubiquitous to all, almost the acute illness, is mainly due to the cause of acute illness, and prolonged anorexia mostly in serious and chronic underlying disorder or psychiatric disorders. What is the physiology of appetite? It is a complex phenomena due to the hunger, satiation, and satiety. Is it, no, I have already said the desire to eat the food is the appetite. Hunger is either may be normal or excessive, or it may be low. So our topic is basically low hunger, is the loss of appetite. Hunger is the sensation that promotes the food consumption. Satiation is the sensation of fullness during eating that leads to a meal termination. And what is the satiety? Satiety is the fullness that exists between the eating occasion. Duto khawar pore mone holo ki tipti kore khelam. So it is basically regulated by the interplay of the brain, mainly the hypothalamus of the brain, GI tract, and the adipose tissue, or the glucose, temperature, or other metabolic state. So it is the role of hypothalamus is due to the feeding interaction between the feeding center and the satiety center. Feeding center in the lateral hypothalamus and the satiety center in the ventromedial nucleus. So when a patient eats or a person eats, this is the lateral nucleus of the hypothalamus activation, and after taking the meal, when the satiation occurs, and then it inhibits the lateral nucleus through the ventromedial nucleus of hypothalamus center. So basically it is the feeding center and satiety center interplay which regulates the hunger and satiety. So not only that, it is a mechanism of appetite regulation which is due to adipose tissue and glucose and body temperature, and due to the lipostatic hypothesis, GARD peptide hypothesis, glucostatic hypothesis, and thermos. I am not going to details of about that. And it is basically either reduced food intake or early satiety, and that leads to the loss of appetite. So in the hunger reduction, it is mainly the peptides are the ghrelin, orexin, a neuropeptide, and agouti related peptide, whereas the satiety is related by leptin, 5-hydroxy tryptamine, glucagon like peptide, other peptides, and cholecystokinin. This is the interplay of these peptides which result in the balance between the hunger and satiety. So basically etiology of the loss of appetite either may be physical, either infection, autoimmune, or malignancy, or the psychological, mainly the stress, either anorexia nervosa, bulimia nervosa, and body dysmorphic disorders, or maybe it is due to the drug induced. So the etiology either may be a lot of the disease like a cancer, ascites, some medication and radiation, hypothyroid, diabetes, adrenal insufficiency, either GI disorder, and also some psychological disorder like anxiety and depression, which may cause the loss of appetite or anorexia. So in if a patient comes with a loss of appetite, you have to check for either whether it is a short duration or a long duration. If it is associated with a fever or not. If it is associated with a fever, probably it is the infection is the main cause. Then you have to just examine the patient carefully and think of whether it is associated with the abdominal pathology like a cholecystitis, cholangitis, or appendicitis or not. Or most important cause is the UTI, particularly in the elderly patient. So in the presence of UTI, patient may have present with a anorexia only without the symptoms of urinary tract. So you have to check for the CBC, urine, and CRP, most important, and urine culture. That will help you to diagnose the cause of anorexia. But if it is not associated with the fever, then you may think of acid peptic disease, hepatitis, fatty liver, or the probably drug. You have to check for that, the serum bilirubin, ALT, and other viral markers. But in case of a long duration, whether you have to check whether it is associated with a significant weight loss or not. Significant weight loss in more than 5% weight loss within a 6 months, or a loss of 500 gram in a week or two. If the no significant weight loss, there is a thing of IBS, acid peptic disorder, early kidney disorder, or liver disorder, or psychiatric illness, then you have to check for the other blood parameters, including the CRP, and treat accordingly. And you have to wait and observe for 6 months. If the patient is okay and it is there no recovery, then again re-evaluate the patient. So if there is a significant weight loss, then you have to see the warning signs, particularly malignancy, chronic liver disease, diabetes, chronic kidney disease, and other viral infections. So you have to check for the all, and also the upper GI endoscopy, colonoscopy, and also imaging of the chest and abdomen. So if the etiology is found, and treat the accordingly. So these are the, algorithm for the loss of weight, diagnosis and treatment protocol. Now what the literature says? The literature says the 3% prevalence of loss of appetite and 91.1% fatigue associated with the various health condition. According to the recent survey, it is seen that acute illness is commonly associated with the loss of appetite, and children are more prone to develop undernutrition and stunting growth due to the loss of appetite. Up to 30% of elderly patients with have an anorexia of aging, and this is the old age problem. So due to the old age, the patient have lost their appetite, and near about 30% of the elderly patient may have a anorexia of aging resulting with a sarcopenia, rather a muscle loss. Patient may lose the weight. So it is the undernutrition which cause the decreased immunity and increased risk of the disease. There is a much more chance of infectious disease, and there is a loss of appetite and decreased nutrient absorption and increased calorie need, which resulting the undernutrition. So this is a vicious cycle, and that cause the undernutrition and also loss of anorexia. So we have to examine the patient properly and treat accordingly to cut this vicious cycle. So what happens during the illness? So if the patient have an infection, there is a physiological changes like a negative nitrogen balance and muscle proteolysis and leukocytosis, and also stimulation of pituitary adrenal axis. And not only that, there is also behavioral changes which lead to food intake reduction, but body due to rather stimulate immune system, and also result the also energy conservation, resulting the inhibition and elimination of the pathogen by way the body rather combats with the infection. So in an infection patient, particularly in a, not only that viral or bacterial infection, there is a release of cytokines, the result of anorexia, and also reduce the albumin synthesis and muscle wasting. That you know that in a COVID infection, there is a patients may develop loss of anorexia and the weight loss. So what is the way to road to recovery? So if the importance of the convalescence that it begins in the first day of illness or injury, so adequate nutrition must be instituted whether the patient is acute or chronic illness. So achievement and maintenance of regained strength depends upon the adequate nutrition intake. So you have to give a stress on the nutrition intake, and that result in faster recovery. 21% reduction in length of stay with the active nutritional intervention. So if the patient you treat immediately with a nutritional supplement, the patient may recover. So what is the approach of management? Goal of therapy is to correct the micronutrient and vitamin deficiency and deliver the adequate protein and moderate non-protein calories in a well-nourished patient. So three things are important, not only protein and calorie, but micronutrient and vitamin deficiency is much more important to reach the goal. So not only that, other pharmacotherapies are the important is the beta-zepin, cyproheptadine, Dronabinol is a drug, is an antiemetic used in a cancer-induced nausea and vomiting. There is other also, metabolic, other male hormone, testosterone hormone derived anabolic steroids, and also the progesterone derived steroid, and also the fish oil that may help in the treatment of anorexia. So role of appetite stimulating drugs is also important, but apart from that, the multivitamin and minerals is also important, which also increase the appetite and intake of fresh food, and also nihil length is increased after supplementation in the children. So the important, not only that, but also we have some home remedies in the loss of appetite. We can use the amla, ginger, black pepper, golmorish, ilachi, and joan and others. So we use as a rather in a homemade recovery, but there is some rules of feeding. So worrying about the non-eating can further affect the appetite. And it is better to include variety in a food serve. Try not to skip the meals. Make an effort to eat regularly, even if it is only a few bites. Small frequent meal and snacks throughout the day are advised. Some people may have a better appetite in the morning. It is better to advise a large breakfast in them. Try eating and the bedtime snacks. So these are the common, forms to rather correct the loss of anorexia. But important, what is the cross-sectional survey, which is done by one of our important API members. Our objective was the perception of the doctors regarding the loss of appetite during the illness, and assess the management approach and assess the perception of appetite stimulating tonic in the clinical practice. And this is published in Journal of JAPI of Association Physician of India in 2020. And it is Mongesh Tiaskar, our secretary, who has the original article on a perception approach and management of loss of appetite in a cross-sectional and questionnaire-based physician survey. And it has been done in a consultant physician 70, pediatrician 70, and general practitioner 150. And total 300 doctors was under this study. And 5 regions was taken and 15 cities across the India. It has been seen 95% of general physicians reported the patient experienced loss of appetite during the acute as well as chronic illness. And more than 90% of the physicians reported the patient experienced loss of appetite, the acute and chronic illness. And all pediatricians experienced loss of appetite during the acute illness, and also more than 90% during the chronic illness. So what is the treatment? They have done a study with a particularly appetite stimulating medication with the primary objective to evaluate the effectiveness with a 1 week therapy, and also secondary objective was that after 2 weeks. And this study was a 50 patient with the loss of appetite of the age of 18 to 15 years with the different variables and characteristics. And they have study was done with the different questionnaires, and ultimately it has been seen that acute and chronic illness showed a statistically significant improvement at a week 2 from the baseline. So no event of change on dose and change of study during the intolerance of the drug, and that the conclusion was that effectiveness of appetite stimulating medication in both acute and chronic illness, and statistically significant improvement within 1 or 2 weeks, and no significant safety concern were identified. So the adequate appetite and optimal nutrition plays a key role for the recovery of acute and chronic illness. And more than 95% of the physicians reported they have loss of appetite during acute and chronic illness, and improvement occurs in the appetite within 3 to 4 days. And the appetite stimulating tonic containing the lysine, zinc, and multivitamin is effective and safe in the managing of loss of appetite in acute and chronic illness. But what are the myths and facts? The myths and facts are that if you do not feel like eating, it is okay, better to skip a meal. It is a myth. The fact is that you should not do this thing, particularly older adult. If you skip the meal, then it will be cause harm. So another myth is that dividing meal in a half and keeping the leftover in a
Dr.
fridge
Ghosh, you have 1 minute left, please.
to save the money and time, but it should not be, but it may cause food poisoning and other health hazards. So another myth is there, once you are hit 65, it is really too late to start following a healthy lifestyle. So better not to do any lifestyle maneuver, but the fact is that it is not the age, it should be done in also in that age also. The in myth is that it is natural for the senior to lose their appetite. It is common, but it is actually not. If the senior person having a loss of weight, you should inquire the patient, I mean, to diagnose the patient, what is the cause of the loss of appetite and treat accordingly. So seniors can eat as much fat, salt and sugar as they like if they are not overweight. This is the myth, but fact is the healthy weight people too can develop heart disease, and balanced diet is most important. So in my conclusion, what you feed your mind determines your appetite is a Tom Ziegler, is a son of Zig Ziglar. So it is the not only the food, you can determine what you desire our mind to be fed. So it is the not feed, it is the academic rather a hunger. It is the postgraduate, you should have a intention that what are the studies you have to do, what are the feeding you have to do, and do accordingly, and your rather hunger should be like that, so that you can feed in such a way. So in the, this is the last, by feeding in the right thing is the most important, not only in your diet, but also in your academic feeding. Thank you very much. And this part is sponsored by the Abbott and the maker of the Betonin syrup.
The session is open for discussion, and thank you, Dr. Ghosh, for this presentation. So we can allow, I think, 2 questions.
By pharmaceutical houses, but this has been not included in your.
I have shown you in my slide that the drugs, pharmacological drugs, which increases appetite. Cyproheptadine is one of the drugs which increases the appetite, and it has been proved that it increases, but long-term use is not necessary, not required, and should not do these things. For a temporary patient of rather acute illness, you can use it for a temporary basis.
Any question from the junior friends? Students, anybody wanting to ask any question to Dr. Ghosh? Dr. Shirendra Ghosh.
I've got a very, maybe a very small question, that a patient, particularly younger children, would have observed the mother is the culprit of underfeeding because of the force feeding. What is the role of counseling in each age group about the feeding, underfeeding, overfeeding, after you have excluded the diseases, obviously?
No. I have mentioned you that the cause of anorexia is one of the important causes, a psychological disease. So not only the elderly patient, but also the children, particularly the adolescents. So you have to analyze whether the psychological depression, anxiety, or other disorder is there, and for that counseling is necessary, and treat the psychological stress and treat the patient. So it is important, the psychological component is very much important to exclude the cause of anorexia.
Thank you, sir. So I think we'll call upon our next speaker.
Okay.
Actually, over the last 2 years, immunity has been the talk of the time. While fighting the COVID pandemic, we had been dealing with the immune system, how to boost up immunity, what to do with our immunity, and so on. So let us see what our young friend, Dr. Tonuka Mondol, is having up her sleeves. Dr. Tonuka Mondol for presentation on immunity boosters in the new era.
Good afternoon. I would like to thank the organizing team of Midterm Update 2022 of Association of Physicians of India, West Bengal branch. With that, I would like to dive into my topic of immunity booster in the new era. Now, first I would like to start with the overview of the immune system with specifically on vitamin C. I would like to give an overview, and next I would like to talk about the factors affecting vitamin C level, body stores of vitamin C in immunity, vitamin C deficiency and genetics, role of supplements, and finally coming to the summary. So as we know that the immune system consists of the anatomic and the physiologic barriers, which are the first barriers, and followed by the innate immunity and the adaptive immunity. Of the immune system, the acquired and the innate immunity has the acquired one, we have the T cell immunity and the B cell immunity, and the innate immunity, the immunity that we are born with, is bloodborne or it has the physical barriers, which is the first line of defense. The physical barriers consist of the skin, the mucosal membrane, the saliva, the flushing action of the urine, and the tears and the stomach acid. Now, as we will go forward, I will talk about the innate immunity, which consists of the natural killer cells, the dendritic cells, the mucosal invariant T cells, the invariant NKT cells, and the innate lymphoid cells. The adaptive immunity consists of the T cells, which mediate the cellular immunity by the controlling of the intracellular pathogens and controlling the tumors. The B cells, which mediate the humoral immunity by controlling the extracellular pathogens and mediating allergy and hypersensitivity. The T and the B cells cooperate for effective immunity. The T cells help and may need, needed by the B cells for the B cell activation, and the B cells may present the antigens to the T cells. Now, the immune function consists of the 5 systems: the complement system, the phagocytes, the T cell immunity, the B cell immunity, and the mucous membranes. The link between the nutrition and immunity is very important. The macronutrient deficiency, which consists of the protein and the calorie deficiency, is mainly seen in the as the cause of immune deficiency worldwide. Micronutrient deficiency and the elements and the vitamins, which consists of iron, zinc, copper, selenium, and the vitamins, may cause the decreased immunity. And the overnutrition, which means the increase or the excess of macronutrients, may also cause a decrease in immunity. With that, let's go into the timeline of vitamin C, as my topic mostly relates with that of vitamin C. So in 550 BC, as you can see in the upper right corner, that there is the Ebers Papyrus, which states for the first time regarding scurvy. In 400 BC, Hippocrates described the symptoms. In 1747, scurvy and citrus was linked by James Lind, as you can see his photo on the right-hand corner. Next, we can see the photos of Dr. Albert, who had invented the hexuronic acid and was awarded the Nobel Prize in Medicine in the year of 1937. Next, the last but not the least, has the photo of Dr. Walter Hayward, who was awarded the Nobel Prize in Chemistry for his work with carbohydrates and vitamin C. Now, what is the essentiality of vitamin C? Vitamin C is not synthesized in the human body. The enzyme required for the production of vitamin C is missing in humans. Thus, vitamin C is an essential micronutrient that must be taken in adequate amounts to prevent the deficiency. The factors which affect the vitamin C levels in plasma: the dietary intake, the vitamin C absorption by the gastrointestinal tract, which may be decreased and lead to the decreased level of vitamin C. Distribution in body fluids and uptake by the tissues. Irreversible metabolism of vitamin C or utilization, and vitamin C excretion by the kidneys. Now the body stores, it should be remembered that up to 2 grams of vitamin C can be stored in our body. High levels of vitamin C is seen in the cells and in the tissues, but in the extracellular fluids, it is at very low levels. It has the 2 forms. One is the ascorbic acid, which is the reduced form, and the other one is the dehydroascorbic acid, or DHA as we commonly know it. It is the oxidized forms. Now the ascorbic acid form is the most predominantly available form in the body. Now the absorption, how does the absorption of vitamin C take place? The absorption of vitamin C is mainly, it is better ascorbic acid form of vitamin C is mainly absorbed in the ileum, while the DHA form, it is absorbed more in the jejunum. The peak plasma vitamin C concentrations are achieved during ingestion of that of 120 to 180 after the minutes after the time of ingestion. Now, regarding the physiology and the biochemistry of vitamin C, ascorbic acid, as I had told you, is the oxidized form. So it is it is the reduced form, and it is oxidized finally to DHA, which enters into the cells via the GLUT channels. This process is called the ascorbic acid recycling, and it maintains the ascorbic acid content in the body. The recycling process may be inadequate during the disease, or most commonly seen among the smokers. Thus, predominantly, these types of individuals suffer from the lack of vitamin C in their body. Now, the vitamin C, what is its activity in our day-to-day life? It helps in increasing the collagen, thereby increasing the barrier integrity. It decreases the hypoxia-inducible factors. It decreases the DNA methylation. It decreases the histone methylation. And it increases the amidite peptides. It increases the catecholamines, and it increases the carnitines, which ultimately leads to the increased metabolic energy. And there are yet some cofactors which are yet to be invented, where vitamin C may act as the cofactor. Now, what is the effect of vitamin C in immunity? Immune cells are extremely prone to oxidation, and high content of polyunsaturated fatty acids are there in it. And thus, high antioxidant concentrations are required. Antioxidant and oxidant balance is critical for immune cell function, because it maintains the integrity of the cell and it maintains the function of the cell. So here in this table, as I have shown that what is the effect and the function of vitamin C in epithelial barriers, in phagocytes, in B and T lymphocytes, in the inflammatory mediators. You can go through it. I will not go entirely through this table. So what is the role of vitamin C in innate immunity? Vitamin C helps in leukocyte function. Leukocytes accumulate vitamin C, resulting in values that are 50 to 100-fold higher than the plasma concentrations. The maximum vitamin C concentration may reach up to 100 milligrams per day after the intake of food. Vitamin C helps to regenerate the cellular and the membrane antioxidants, glutathione and vitamin E. Vitamin C also helps in phagocytosis. It enhances the neutrophil migration in response of chemotaxis, increases the phagocytosis of the microbes, stimulates killing of the microbes, and supports apoptosis. Vitamin C thus supports the resolution of the inflammatory response and decreases the tissue damage. Vitamin C and apoptosis, the crucial link of cellular death, is very, very important. Vitamin C deficiency delays the neutrophil apoptosis, and the neutrophils fail to undergo morphological changes associated with apoptosis. Not recognized or phagocytosis by the macrophages, and the necrosis of the neutrophils and of the surrounding tissues occur, which ultimately leads to cell death. The vitamin C in adaptive immunity acts by working on the B and the T lymphocytes, which also accumulate the vitamin C in very high levels via the sodium vitamin C transporters. On T lymphocytes, it helps in development, maturation, and differentiation of the human T cells. It also helps to protect the cells from the oxidative damage. In the B lymphocytes, it helps in development, maturation, and differentiation of the B cells, and also helps in antibody production. The deficiency of vitamin D cells, of vitamin C, the deficiency of vitamin C and genetics. Now, the required demand for Indian population of vitamin C in males, it is about 80, whereas in females, it is only 65. But when the female is pregnant, it increases by 15 and it comes up to 80. In lactating mothers, it is 115. Now, what does the vitamin C deficiency does? The prevalence of vitamin C deficiency is the highest as recorded among the Indians. The factors which include is the tobacco use, biomass fuel, cooking styles, age, genetic makeup, and influence the vitamin C levels. As you can see in the teeth and the gums, the effect of scurvy, and there is bleeding spots in the skin in the upper left image. Now, the demographic factors that determine the vitamin C status are that the males are more likely to be deficient of vitamin C than the females. The comorbid conditions in the elderly increase the chances of developing vitamin C deficiency. Cooking of vegetables and fruits can reduce the vitamin C content by near about 40%. The supplement usage prevents vitamin C deficiency. In India, factors such as harsh climate and high level of pollution negatively impact the vitamin C status of the body. Now, as I had said, smoking and biomass fuel, approximately 31% of the male smokers compared to that of 11% of the non-smokers suffer from vitamin C deficiency. Smoking and chewing tobacco and cooking with fuels such as wood and crops has been shown to cause decrease in vitamin C levels. Tobacco and inhaling fumes from home and cooking fires also create oxidative stress, thereby decreasing the vitamin C levels. Smokers require almost 20 to 80 milligrams per day of vitamin C in the regularly diet intake. There is a study which shows that the prevalence and the risk factors of vitamin C deficiency in the north and the south part of India, the two-center population-based study done in people over 60 years of age. In the geriatric population, it was observed that more than 73% of the northern Indian population, elderly population, suffered from vitamin deficiency. And in south, it was nearly about 45.7%. The deficiency was seen to increase in age, whether it is from North India or from South India. It has been shown that haptoglobin is a major genetic factor that influences the levels of vitamin C in our body. Out of the 3 variants of haptoglobin, haptoglobin 2-2 has a decreased ability to bind with hemoglobin, resulting in increased oxidation of vitamin C. 84% of Indians, we unfortunately carry the haptoglobin 2-2 variant, and Indians are thus predisposed to developing vitamin C deficiency. High dose of vitamin supplementation has been shown to ameliorate certain gene variant deficiencies and prevent the deficiency. Now, what is the impact of vitamin C on various infections, whether it be communicable or non-communicable? Now, the inflammatory response induced by the infections and subsequent high inflammatory mediators impacts the micronutrient status of the body. The levels of micronutrients reduced during the acute and the chronic infections. The micronutrients which are mainly affected are vitamin C, vitamin A, E, zinc, copper, selenium, and iron. Infections, both acute and chronic, adversely affect the micronutrient status of the body. Thus, these micronutrients should be supplemented during the periods of infection and disease. In diabetes, it is seen that the causes of vitamin C in the diabetic patients were found to be high level of oxidative stress that we all know, which is most likely caused due to hyperglycemia. The glucose ascorbate antagonism, which occurs due to vitamin C, which is structurally like glucose. It competes with glucose for transportation into the cell, and the hyperglycemic patients, the vitamin C cellular uptake is impaired. So the impact on the humoral innate immunity is seen that of low complement factor 4, decreased cytokine response, and in case of cellular innate immunity, it is seen that decreased functions of diabetic polymorphonuclear cells and diabetic monocytes and macrophages. The three mechanisms by which vitamin C prevents the end organ damage in diabetes is by acting as an antioxidant, and it inhibits the intracellular accumulation of sorbitol, and it reduces the glycosylation of protein. In case of hypertension, it has been seen that the hypertensive subjects has 15.97 millimole per liter lower than that of the normotensive patients. Serum vitamin C concentration is also inversely related to the systolic and the diastolic BP of these patients. Endothelial activation, oxidative stress, inflammation, and vascular smooth muscle dysfunction is seen as a hallmark of CVD in patients suffering from hypertension. CVD and hypertensive patients have impaired endogenous and exogenous antioxidant defense mechanism. These patients have a greater than normal response to oxidative stress.
Dr. Mondal, please wind up your slide.
Yes, sure, sir, I'll try. The three mechanisms by which vitamin C can protect the end organ damage in CVD and hypertension is that it helps in scavenging the highly reactive free radicals, it helps in production of nitric oxide, it improves the vascular endothelial function, and it inhibits the oxidation of LDL protein. In obesity, which is there is a chronic low-grade inflammation which always goes on with obesity. Persistent stress and inflammation leads to adipocyte apoptosis and release of chemotactic mediators. Obesity impairs the T-cell mediated immune surveillance and reduces the functioning of the memory CD8 T cells. Thus, there is also a deficiency of vitamin C recorded in the overweight and obese individuals who consume less than 51% of vitamin C than the normal individuals. So the role of supplements, I'll just finish in next two slides. Now the sources of vitamin C are oranges, as we know, citrus, fruits, amla, berries, kiwi, sweet lime, and vegetables like broccoli, peppers, spinach, kale, and potatoes. So the role of supplement lies that vitamin C is not stored in our body, so we need to supplement it. And thus we have to, since our cooking practices almost dissolve 20 to 40% of the vitamin C in our raw fruits and vegetables, so we have to supplement by regular intake of vitamin C supplements that help us to meet the vitamin C requirements in our body. Thus, to summarize, vitamin C deficiency is highly prevalent in India. Various factors cause vitamin C deficiency in our body, like chronic diseases, smoking, poor dietary intake, and vitamin C is extremely important for the proper functioning of our immune system, and its deficiency can cause impact the immune system adversely. Diet rich in vitamin C is important to meet with the body's daily requirement, and the supplements play a very, very crucial role due to the disease and the poor intake. With that, I would like to specifically thank Professor Shoika Datto, who is a professor and the head of the Department of General Medicine, MJN Medical College and Hospital, Cooch Behar, for helping me out with this presentation. Thank you so much. And it is a sponsored presentation by Abad. Thank you.
Thank you, Dr. Tonuka. Any questions? If there are no, yes, sir.
Vitamin C in chronic in patients.
How long, how much?
In patients, since in Indian population, we have seen that vitamin C is deficient individual, most of the Indian population is deficient in vitamin C. I would like to ask since it is an excess of vitamin C can be excreted out to the urine. So in debilitated and patients aged more than 60 years, I would ask them to take a chronic and a regular dose of vitamin C. Thank you, sir.
Thank you, Dr. Mondal. And so I think if there are no questions, let's conclude the session. And I would invite the speakers to come up on the dais to receive the mementos.
Request both the chairpersons to felicitate our two speakers. One is Professor Dr. Udas Ghosh. And Professor Ananda Bagchi is offering to Dr. Udas Ghosh and Dr. Soikat Datta to Tanuka Mandal. Thank you. Thank you very much for offering a very good session to all of us. Now we are passing on to our last but very important and exciting. Now Dr. Udas Ghosh is requested to give the memento to our respectable honorable chairpersons, Dr. Soikat Datta and Dr. Ananda Bagchi. To Dr. Ananda Bagchi, please. Okay. Thank you. And to Dr. Soikat Datta, to Dr. Ananda Bagchi. Thank you. So now we have come to the last session of 2 days academic extravaganza. And the last session is quiz, and we all are waiting very eagerly for the quiz session, because all the time it is very exciting, very neck to neck fight among the quiz team. So we are also expecting this year that quiz will be very, very interesting for all of us, from seniors to juniors, each and every one of us. So may I request Dr. Atanu Chandra of RGCA to come over the dais, and the podium is yours. And I request Dr. Atanu Chandra to call upon his two very important, another two faculties to help him out in this regard. So Dr. Atanu Chandra, please, you call your team and start the proceeding.
So good evening, everyone. So I would like to request another quizmaster, Dr. Uddalak Chakraborty, and scorer our beloved Piyush Da, Dr. Piyush Mondal, to come here on the stage. So we have 6 teams for the main round. So I will like to call the participants to sit over here. So the first team, team 1, is from IPGMER, led by Dr. Kaushik Karmakar. Team 1. So lottery has already been done, and according to the lottery, the sequences are Team 1, IPGMER, led by Dr. Kaushik Karmakar. Team 2, Arjikar Medical College, led by Dr. Monishankar Bhattacharya. Team 3, Team 1, IPGMER. So team 3, CNMC, led by Dr. Onustu Mukherjee. Team 3, CNMC. Team 4, NRS Medical College, Aradhya Shekhar Bagchi, team leader. Team 5, the second team from IPGMER, led by Dr. Devrup Sengupta. And the team 6 from MCK, led by Abhinav Datta. So we have all the 6 teams. So we would like to thank the organizers of API for giving us this opportunity to conduct this quiz competition, one of the most exciting sessions of today. So Dr. Uddalak, will you please describe the general rules of the quiz?
Yeah, sure. So very good evening, respected faculties, delegates, and the participants. It's been a long gap of 2 years. After that, you're right here for a physical quiz. I am Dr. Uddalak Chakraborty. I welcome you on this platform. So before we begin, I would like to tell you some general rules about the quiz. So we will be conducting 4 rounds. So participants, please beware of negative marking. Only the team leader will answer. That's very clear. I just need one clear answer from the team leader. No prompting, please. Do not fumble. Take your time and the team leader will answer. Okay. It's an all or none phenomena. And first answer will be taken as your final answer. So no second answer will be obtained. So whatever you answer in the first chance will be taken as the final answer. And the most important rule of this quiz master's decision is final until there is some divine intervention. So please consider that. So round 1 and round 4 will be conducted by Dr. Atanu Chandra. So I will hand over the mic to him. You need a sheet of paper, okay?
So you can have this in your bag.
I don't think we have a sheet of paper.
So in round 1, you will be described about some eponymous disease or syndromes, and that disease was became famous through the name of one famous individual. So you should either identify the disease or syndrome or identify the individual. So for the correct response, you will get +20, and for incorrect response -10. For no response, no number, and that will be a bonus. There will be a bonus opportunity, and in the bonus round, you will have +10 for correct answer and -5 for wrong answer, and no response, then no marks. So team 1, are you ready? Right. So team 1, question for team 1. So this person, he was born in London in 1755. His initial professional interests were primarily in politics. And in 1817, he published an essay on the sacking policy described as paralytic agitance. So name the person or the famous disease named by that person. You have 10 seconds. Right. So correct answer from team 1. So I would like to request the audience to encourage the participants. Thank you all. So +20 for team 1. So James Parkinson and the disease, Parkinson's disease. Team 2, are you ready? Right. So direct question for team 2. So he was a Bavarian born in 1864 in Germany, became a pathologist and a psychiatrist. He began observing a patient at one of the asylum in Germany for lunatics and epileptics in 1901. And when the patient died in 1906, he dissected the brain and augmented by the newly developed silver stains. And he identified some specific plaques and tangles. And he presented his findings the same year. Name the personality or the disease well known by his name. Team 2, 10 seconds. So will you please repeat? Alzheimer's disease. So right answer from team 1. So excellent answer from team 2. So team 2 will get plus 20. So the disease name is Alzheimer's disease. So next, team 3, are you ready? Right. So direct question for team 3. And this personality, he was born in Japan. And in 1912, he published a report on goiter with some infiltration by mononuclear cells. And specimens were reviewed by the American and British researchers. And the disease were well known by his name. So identify the personality or the disease named after him. 10 seconds. Excellent answer. So correct answer from team 3 plus 20 for team 3. Team 4, ready? So direct question for team 4. So he was born in Germany. This is a tricky question. He was born in Germany in 1720 and became well known for entertaining at different dinner parties on his estate after his retirement. He liked to tell all the tales of his military adventures, and most of them was over-exaggerated. And in 1785, an anonymous publication of the tales with the illustration associated with his name, and he was quite embarrassed by using his name, but that tales became very popular. And later, Richard Asher published a case series in 1951 by mentioning his name. And that was the line that was taken from the case series from Richard Asher, and that disease or disorder was very popular by his name. Identify the disease or disorder or the name of that famous person. So that over-exaggeration of some fanciful things that was being described by name of that person. So team 5, bonus, team 5, will you like to answer? Team 6? No, team 1?
Team 1 bonus.
Team 2?
Team 2.
Team 3? No.
Okay.
So question, answer from the audience? Anyone?
Anyone from the audience? Answer please.
Excellent answer. So this is
Munchausen syndrome.
So this is Baron von Munchausen, and the syndrome is factitious disorder or Munchausen syndrome. Excellent answer from the audience. And will you please mention your name? Sarah has also given. So
Dr. Shoikat Datta answered the right.
Okay. So next, team 5, are you ready? Right. So direct question for team 5. He was born in Germany in 1881, and during World War I, he observed a common ailment that was being associated with some sort of urethritis and in few soldiers, and the syndrome was named for him. But later he became very unpopular due to his Nazi contact, and some researchers also, they just proposed for removal of the name of this person from the disease. So can you identify the older name or the newer name of the disease or the person mentioned here? 10 seconds for team 5. So team 6 bonus. No. Team 1,
Team 1.
bonus? Right. So that is the right answer. Excellent answer from team 1. So this is Ritter syndrome and plus 10 for team 1. So last question of this round for team 6. Ready? Right. So he was born in Cleveland in 1869 and he was a leading neurosurgeon of his day. In 1912, he reported a condition that he referred to as polyglandular syndrome related to a pituitary disorder. And in 1932, he published his observations as basophilic adenoma of the pituitary, and the disease became popular after his name. So name the person or name the disease. Team 6, 10 seconds. No. So bonus for team 1?
Team 1.
No. Team 2?
Team 2.
Team 3?
Team 3.
Team 4?
Team 4.
Team 5?
5. Okay.
Okay. So answer from, any answer from audience? No, sir. Cushing disease.
Cushing, yes.
That is Cushing
That's the
syndrome.
correct answer. So with this,
We have finished round 1. So Piju sir, will you please tell the
Yes. The end of the round 1, team 6 scored 0, team 5 0, team 4 0, team 3 of CNMC 20, team 2 of RG Kar Medical College 20, and team 1 of IPGMER 1 is 30. So team 1 is leading in this round.
okay. So with this, we will move on to round 2. So in this round, just name the clinical sign which is being shown in the slide. For a correct question answer, you will get 20 points. If you make a wrong answer, it's minus 10. Scores have been declared, sir. Okay.
So we will start this round from team 6.
We'll start this from team 6.
Team 1, question 1.
Okay.
So direct question for
team 6. So a diagonal crease in the earlobe extending from the tragus across the lobule to the rear edge of the auricle, indicative of cardiovascular disease and or diabetes. What is the sign shown here? Team 6. Time up for team 6. Team 5. Team 4. Frank sign. Yes. Correct.
So correct answer. So plus 10 for
Plus
team
10 for team 4.
Team 4.
Okay.
So next question, direct question for team 5.
Next
Ready?
question, team 5. Yeah. So dullness on percussion beneath the left angle of scapula in massive pericardial effusion. Name the sign.
That is a easier one.
It's a very easy question. Team 5. Time up, time up. Team 4. You what sign? Yes.
So plus 10 for team 4.
Yes, yes. Correct. So now question for team 4, I guess. Yeah.
Right.
So name the sign which is being demonstrated here. Name the sign. Yes, correct. This is a Oppenheim sign.
Plus 20.
Plus 20, team 4.
Direct question for team 3.
Direct question for team 3. Unusual constellation of fever with relative bradycardia. What is the sign? Paget sign. Correct.
Excellent answer.
Excellent answer. Plus 20 to team 3. Question direct to team 2. Name the sign. Bostic sign. Yes, correct. So plus 20 to team 2. Now direct question.
Last question
to team 1.
for team 1.
A dermal hyperesthesia at the inferior angle of right scapula in acute cholecystitis. Name the sign.
That is again a easier sign.
Time up. So team
Six.
team 6, will you try?
No,
Okay, no. Team 5, answer for team 4. Any answer you have? Team 3? Team 2? So anyone from the audience? Boaz sign, correct. So with this, we come to an end of round 2. So scores, please.
So team 4 has come with a great performance, answering 3 questions and scored 40 in this round. At the end of the second round, team 6 is in 0, team 5 is in 0, team 4 is in 40, team 3 is in 40, team 2 is in 40, and team 1 is in 30.
So with this, we move on to round 3. So in this round, I will allot 2 questions for each team. These are spotters. You first see the spotters and give your answers. 10 seconds allotted for each question. The scoring remains, there is no bonus in this round. So if you answer correctly, you get 10. No answer, you get no points. If you answer wrong, you get -5. Got my point? So I will start with team 1. So the first spotter for team 1.
Team 1 ready?
Team 1, are you ready? Give me the full diagnosis. I need the full diagnosis. Okay. So actually, here they answered on the timer. Actually, the time was up. What to?
So they have uttered the subarachnoid hemorrhage before the time
Yes.
was over.
So we'll consider it.
So we'll consider
Okay.
it.
Correct answer. This is an aneurysmal subarachnoid hemorrhage. You can see aneurysm at the ACOM. So next spotter for you. What is your diagnosis from this ECG? Time up.
Time up.
So no bonus in this round.
So +10 and 0 for team 1. So answer from no bonus.
No bonus.
Answer
No
from
bonus.
audience.
Brugada syndrome. Yes. So now team 2, are you ready for your spotters?
So this was aneurysmal subarachnoid hemorrhage and Brugada syndrome. Then team 2. Look carefully.
Identify the faces. Name the faces. Yes, what face is this? Time up. So no answer from your side.
So answer from audience.
Leonine face.
So
It's very
this is
simple.
very obvious.
Very simple.
So second spotter for
Second spotter for team 2.
team 2.
What do you see? What do you see, or what is the diagnosis? Yes, very good.
Excellent.
Excellent. So this is the face of giant panda seen in Wilson's disease. So we'll accept that. So 0 and +10 for team 2. So now team 3, are you ready for your spotters? First spotter to you. Identify the faces. Very characteristic. Very characteristic. Very good. Excellent.
+10.
+10 to team 3 for the first spotter. I need some applause from the audience, please. So the next spotter for team 3. What do you see in the fundus?
The characteristic finding on
It is a very
retinoscopy.
characteristic finding. Name the finding.
Very specific finding for a specific disease.
Very specific finding for a specific disease. Time up. Anyone from the audience? Anyone? I can't hear you. No. This is not splash tomato. No, this is not hot spots. These are characteristic choroid tubercles in tuberculosis. Okay.
So +10 and 0 for team 3. So direct spotter
Question
for team 4.
Team 4. Give me your diagnosis. Okay, I will take scleroderma, fine. Diffuse systemic sclerosis. So
plus 10.
Plus 10.
Second spot.
Second spot. Very characteristic pigmentation. Give me the name of the drug. This is the drug-induced pigmentation. Name the drug. Very good. Amiodarone.
Excellent answer from team 4.
So team 4 plus 20. So now questions to team 5.
Ready?
Ready? What is your diagnosis or what is this condition? No, this is not erythema multiforme. They have given a wrong answer. So they will get -5. Anyone from the audience? Yes, this is erythema gyraatum repens.
So next spotter for team 5.
Closely identify the MRI. I have given another section as well. What is your diagnosis? What do you see? These are from my personal collection. What do you see? Neurocystic sarcosis. Yes, well and good. You can see diffuse cystic sarcosis even in the muscles also. Okay. So plus 10 and -5 for team 5. So team 6, are you ready? What is this in the X-ray? Give me your diagnosis or what do you see in the X-ray?
Look carefully, there is something abnormal.
This is not ICD.
Wrong answer. So
Wrong
-5.
-5. Anyone else? Yes, leadless pacemaker. Next question. What is this? Yeah, I will take that. Chronic calcific pancreatitis. So plus 10 for you. So we have finished round 3. So what are the scores of round 3 after round 3?
This round, everyone scored in this round. Team 6 scored in this round particularly 5. Team 5 scored 5. Team 4 scored 20. Team 3 10. Team 2 10. And team 1 10 numbers. So total numbers, team 6 is in 5. Team 5 is in 5. Team 4 is in 60. Team 3 is in 50. Team 2 scored 50. And team 1 scored 40. So team 4 is leading overall at the end of third round.
So now we move to round 4.
So this is the last round of today's quiz, and each team will get 2 questions, 2 direct questions, and there will be also bonus options. So for correct response, there will be plus 20. For incorrect response, -10, and in bonus for correct response 10, and for incorrect response -5. So time is 10 seconds. So we will start from team 6. Direct question for team 6. Look at the picture and the clinical clues. Team 6. So a 56-year-old man with sickle hemoglobin C disease and proliferative sickle retinopathy presented for a routine eye examination, and he was asymptomatic, and there is something seen in the anterior segment of the eye. What is that finding? Team 6, direct question. So what is the characteristic finding of that anterior chamber of the eye? No. So bonus for team 5. 4, 3, 2, 1. No. So any response from the audience? So this was published in NEJM just last week, 1 week back. Right. So this is the extensive iris atrophy of both the segment of the eyes, like auto amputation of spleen. So iris atrophy is very characteristic ocular finding of sickle cell disease, and that is often associated with proliferative sickle retinopathy. So no marks for this question. So second question for team 5. So a 37-year-old woman, sorry, team? No.
No, this will go on like this one.
Right, team 6-5. 37-year-old woman with idiopathic T-cell deficiency underwent computed tomography of the abdomen, and what diagnosis or what is the previous infection that is commonly associated with this finding? Which infection? Which infection characteristically gives this finding? Wrong answer. So -10 for team 5. So team 4, will you like to answer? Next.
Team 3,
2,
team 2, team 1.
team 6, no. So any answer from the audience? No, sir. So this is extensive splenic calcification. That is also seen in tuberculosis, but is a rare finding, but that is characteristically seen with histoplasmosis. So please, previous slide. So there you can see also some mediastinal lymph node calcification here and extensive splenic calcification, characteristic of histoplasmosis. So next question for team 4. So a 48-year-old woman with advanced cirrhosis presented with easy fatigability, jaundice, and abdominal distension, and there is anemia, high LDH, and low haptoglobin level, and Coombs antiglobulin test was negative. And the peripheral blood picture is given here. Identify the condition. What? Zeus, no. Wrong answer. -10 for team 4. So team 3, will you try? Team 2? No. Team 1?
Team 1.
Wrong answer. So -5 for team 1.
Team 1.
Team 6? Team 1. 1. Team 6? 5. So any answer from the audience? Excellent answer, sir. So this is acanthocytes, that is partial hemolytic anemia, non-immune hemolytic anemia that is common in cirrhotics. So this is partial or acanthocytes, partial hemolytic anemia. So next question for team 3, right? So team 3, direct question. So a 80-year-old man presented in the emergency department with 2 days history of abdominal pain and in the right upper quadrant of abdomen, and CT finding is showing this. So what is your diagnosis?
Time up.
Time up. Team 2.
Team 2.
Excellent answer.
Excellent
So +10. So you can see the rim of air around the gallbladder, surrounding the gallbladder. So this is emphysematous cholecystitis. +10 for team 2. Then team 2, direct question, right? So a 22-year-old previously healthy man presented to the outpatient clinic with a 6 months history of palpitation and chest discomfort. And there is no history of dyspnea or syncope. A systolic murmur was heard over the precordium on auscultation, and a snap of echocardiography is seen. What is your diagnosis? Team 2, that is an easier one.
Time up.
Time up. Team 1.
Team 1.
Will you try? No. Team 6.
Team 6. Team 5. Team 4. Any answers from you?
Excellent
Excellent
answer.
answer,
Excellent
yes.
answer. So this is systolic prolapse of the mitral valve. That is the MVPS, mitral valve prolapsing. So +10 for team 4. So the question for team 1,
Yes.
direct question. So that is a common scenario we face in day-to-day practice. There are 20 and that is often missed also. So 55 years old man with history of diabetes and hypertension suddenly develops some chest discomfort. ECG is showing this. And what is your likely diagnosis? Team 1. That is a common condition and that is grossly underdiagnosed condition.
Time up.
Time up. Team 6.
Team 6.
What? So will you please explain?
What do you see in the ECG?
Right. So they will get +10 for the right answer. But the typical finding in ECG, previous slide please. So that was sinus tachycardia along with the classical S1, Q3 and T3 pattern. That is acute pulmonary embolism. So +10 for team 6. So the second set of questions of this round. So will we start from team 1?
Yes.
No, এটা তো একটা রাউন্ডেই
This is a
চলছে।
continuous round, so we will not disclose the score.
না একটা রাউন্ডের মানে
Yeah,
এটা
this is the
লাস্ট
last.
রাউন্ড মানে রাউন্ডের মধ্যে তো স্কোর ডিক্লেয়ার করা যাবে না সো ডিরেক্ট কোয়েশ্চেন ফর টিম 1 so a 42-year-old gentleman had a preceding history of high-grade fever with headache, vomiting and polyarthralgia, generalized erythematous morphiform rash 3 weeks prior to his presentation, and following his recovery he has presented with this. And this was this patient presented to our OPD. And what is your current diagnosis? And what was the previous episode due to? So that is very classical of some previous infection. So identify that sign. Right. So correct answer. So this is chick sign or post chikungunya hyperpigmentation. Right. So correct answer. So big round of applause for team 1. So next question for team 2, direct question.
How much? Team 1?
Plus
Team 1
20. Plus 20. Plus 20.
Plus 20 for team 1. So team 2, direct question. So a 20-year-old male presented with recurrent symptoms, episodes of focal bilateral tonic-clonic seizures for last 5 years. And he also complained of a progressive asymmetry of his face since a decade, no history of trauma. And this patient presented to the neurology OPD of BIN. So
What is your diagnosis?
look at the pictures and what is your diagnosis?
Give me a diagnosis.
So no answer from team 2. So bonus for team 3.
Team 3, will you try?
Team 4.
Team 4.
5.
Team 5.
6.
Team 6.
1.
Team 1. Anyone from the audience? This is a very classical photo. Yes, sir. Coupe de Sever actually it will not involve the lower part of the face actually. This is a perirhombus syndrome.
That is
Facial
hemifacial atrophy.
Yes. This is very classical.
So next question for team
Team
3. Dear
yes.
question, right. So look at the pictures. A 40-year-old woman with a history of chronic pancreatitis and gastroesophageal reflux disease presented with fatigue, malaise, dizziness, difficulty in ambulation, diarrhea, easy bruising, and a diffuse characteristic rash over the extremities. So you can see the picture of the skin surface, dermoscopy, and the pattern of hair distribution, and the skin biopsy. So what is your diagnosis?
What is your diagnosis? Whipple's is wrong.
No, wrong answer. So
minus-
bonus for team -10 for
Min-
team 3.
Team 3 -10.
Bonus for
Team 4? Wrong.
wrong answer. -5.
For
Team 4.
Team
Team-
5? Team 6? Team 1? Team 2, you have any answers?
That was a skin biopsy.
Biopsy. Anyone?
So no answer from any of the teams. So answer from audience.
Audience? This has just been discussed.
So this has been just being discussed by Dr. Tanuka Mondal.
So this is
So this is Karvi. So parafollicular hemorrhage characteristic, that is there was ecchymosis, some corkscrew hairs on dermoscopy, and follicular hyperkeratosis and plugging. Huh? ছবিটা, হ্যাঁ। The corkscrew hair was seen in panel C, and the follicular hyperpigmentation with pitting in dermoscopy finding, and there is diffuse ecchymosis and hemorrhage.
Okay.
So direct question for team.
Question team
4.
Yeah,
Right.
direct question for team 4. So
A 30-year-old male without any pre-existing comorbidity that presented in the neurology clinic with perceiving a click in his ears. There is no other symptom. So look at the video and give your diagnosis. What is the condition?
what is your diagnosis? Very characteristic.
There was a clicking sound.
The patient could perceive a click in the ear. What is the diagnosis? Pass. Okay. Team 5.
Which one?
Okay. So palatal tremor will not do. Give me a diagnosis.
So team -5.
Palatal tremor will not do.
Team 6.
Team 6. Team 1. You have any answers?
No.
Team
Team
2.
2.
Team 3.
No.
Anyone from the audience? Yes, sir. This is essential palatal tremor. The characteristic click is essential palatal tremor.
So the last question of
No, it's
Yeah.
last 2 questions are there.
last 2 questions, I think. So
question
question
to
for
team
team 5. So 63-year-old man present with a long-standing history of sinusitis and 3 weeks history of frontal headache. The physical examination was unremarkable and the serum calcium level was also within normal limits. Just look at the radiography and give your diagnosis. Time up. So bonus option for team 6.
Team 6. No answer.
Team
1.
1.
Team 2.
Paget's
Paget's
disease, right.
disease, yes,
So
correct.
correct answer. So this is the cottonwool spot of the skull seen in Paget's disease. So +10 for team 2. And the last question for for team 6. So team 6 direct question. So a 56 years old male, known case of rheumatoid arthritis for last 10 years. Patient was also hypertensive and diabetic for a long duration. He was on different oral medications, around 8 to 9 medications, and he presented with gradually progressive dimness of vision. And ophthalmoscopy finding is showing this. Make your diagnosis. Due to excellent answer.
Excellent
So that is bullseye maculopathy due to chronic hydroxychloroquine therapy for rheumatoid arthritis. So +20 for team 6. So with this, the quiz session of today is finished. So final scores, please. So lastly, we like to congratulate all the participating teams for to be present here. So big round of applause for all the participating teams. And hope your approach in clinics will not be same as your quiz approach.
No doubt, all the team performed very well. They performed very well. However, because of the scoring system, we have to give some results. So team 5 of IPGMER, led by Devrup Sengupta. However, they have scored -10. Team 6 of Medical College Kolkata, they have scored 35. Give a big applause to them. Team 3 of National Medical College has scored 40. Team 1 of IPGMER, led by Kaushik Karmakar, and team 4 of NRS Medical College. Both of these teams have scored 55. So there is a tie. And RG Kar Medical College scored 70 with the highest mark. So congratulations to RG Kar Medical College. That's all. There is a, yes.
So we have a tie and we have a
Second position,
tiebreaker.
there is a tie.
I will give a spotter to them.
Tiebreaker round can be.
I will give a spotter.
So team 1 and team 4. We will have
Yeah, share
another
করবেন না, share করবেন।
tiebreaker round.
Share করবেন। Share করবেন না।
So we'll have one spotter for each teams. আচ্ছা কোন কোন টিম হয়েছে তাই?
Team 1 and team 4. IPGME are led by Kaushik Karmakar and NRS
direct
Medical College.
spotter for team 1, that is দাঁড়াও এটা হচ্ছে তোমার no negative marking.
You can try.
You can try.
This is a spotter.
Spotter.
Share the screen. Share. Very classical. Give me the diagnosis. The textbook's picture. This is a textbook. Lupus Parnio. Very good.
Right.
Seen in
how much?
Which
না এটা তো তোমার
type?
So no negative marking again. So second spotter for team 4. Fourth to
Team 4.
team 4.
NRS Medical College.
না 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 থাক। হ্যাঁ থাকবে ডেসক্রিপশন তো থাকবে।
So we have an elderly gentleman, recurrent falls, marked axial rigidity. What do you see in them, right? Very good. Hummingbird sign PSP. We again have a tie.
So again tie. So we'll have second round of tie.
Probably this is the last tiebreaker which I could afford. Okay, so I have a single question for you. Whoever answers this wins this quiz.
So you have,
Bazar,
they will raise their hands.
চলতে দিন না।
yes, if no one answers.
No negative for wrong answer.
না যদি কেউ answer
ও না wrong answer এর জন্য তাহলে নেগেটিভ হবে মানে
Once the round is complete,
yes. So this is a very question I give to. I will give opportunity both of the teams. Okay. First.
না না দুটো স্পটার দিতে হলে
I will give two spots.
আরো দুটো স্পটার দি।
Yes, I will give two spots.
এইটা দুজন টিমই ট্রাই করতে পারে।
কোনটা এটা তো
কোনটা? দুটোই যদি না পারে তাহলে কম্বাইন্ড উইনার হবে। তাহলে এই দুটো
তাহলে joint winners. Okay. Spotter for team 1. Another question.
তোমরা পারবে, তোমরা যদি পারো you are the winners.
So share this. So elderly gentleman who is very slow, walking very slowly, generalized slowing. This is a classical MRI sign. Can you identify the sign?
No negative marking.
No negative. Team 4, will you try? This is not Halliburton spots. This is not tiger eye sign.
ওরা বলতে চাইছে বলো।
What? Absent?
No, no.
This is putaminal rim sign.
So
okay.
this is the last quarter.
You can see the putamen. So this is the putaminal rim sign. And this is I will give you the last quarter, last opportunity. Screen off.
হ্যাঁ এটা তোমাদের। এটাও যদি কেউ না পারে বা দুজন মানে কেউ যদি না পারে, তোমরা যদি না পারো, কেউই না পারে, তাহলে উইল ডিক্লেয়ার অ্যাজ জয়েন্ট উইনার্স, জয়েন্ট সেকেন্ড প্রাইজ। হ্যাঁ
হ্যাঁ, ওরা যদি না
পারলে
পারলে
তোমরা
তোমরা
আসবে।
পারো।
আর ওরা যদি পেরে যায় তাহলে আর আসবে
পেরে
না।
গেলে আর আসবে। So please share the screen. So this is a real life case. 51-year-old male, progressive dysphagia for 3 years, upper GI endoscopy unremarkable, admitted in BIN in our unit, worked up for a long period of time. Finally, we ordered a base of skull CT. What is the finding?
Excellent answer.
Excellent answer. So
Will you
ultimately,
please identify the culprit vessel?
where is the vessel? Can you show? No, just you have pointer. You have
Pointer?
There's no pointer here. Oh, yeah. Pointer good.
So you can you mark here?
Come and mark
Here,
on the
here.
screen.
They have answered. So
This is the trachea, the next side of Vegas. This is the vessel. Okay, it is compressing the esophagus. So this is right subclavian aberrant compressing the esophagus. This is we diagnosed it few days back. Thank you. So with this, we come to end of this grand quiz. Thank you, everyone. Thank you, the organizers, for providing us the opportunity. And I wholeheartedly thank the participants. They have participated so well. Excellent quiz from our side. Thank you very much.
Team 4 of NRS Medical College stood second.
thank you, sir. Thank you, sir.
Thank you, sir. Thank you, sir.
So winner to declare.
So we declare the results.
So at the end, IPJMER team 1 led by Kaushik Kormokar stood third. Team 4 of NRS Medical College stood second, and the winner of today's quiz contest is team 2 RG Kar Medical College. So a big applause to them.
All the contestants, please sit for a few minutes more. On the back side, we will again rearrange the chair. Now we will start valedictory session. Before starting valedictory session, there is a time for felicitation of our quiz masters and scorers. They have done a splendid job. So I request Dr. Minal Kanti Roy and Dr. Anando Bagchi, please come over the dais. And Dr. Jyotirmoy Paul, please come over the dais. Dr. Jyotirmoy Paul has come all the way from Assam to here just to felicitate our quiz masters. So 3% will felicitate 3 followers all the way from Assam.
Our beloved friend, Dr. Piyush Kanti
Mandal
is organizing MAPICON. There is a API Malda chapter program in 29th of May. 29th May. All are requested to come. If anybody is interested to come, please contact with us with Kaushik, because ticket is to be booked. 29th May. So we will go 28th evening or to night train, or by Shatabdi 2 o'clock, and return by 29th night, either by Hate Bazare or whatever the train is available. And Murshidabad program, same program will be on 12th June. So anybody interested to go Malda and Murshidabad, please register name to Kaushik Dhar in our office.
So on behalf of our organizing committee, it is our extreme pleasure to present a small token of memento to the excellent quiz masters and also the scorer on behalf of API West Bengal chapter. First to Dr. Uddalok
Dr.
Chakraborty.
Uddalok
I request Dr.
Chakraborty by
Jyotirmoy Pal.
Professor M.K. Roy.
Hand over to Dr.
Now I
Atanu
request Dr.
Atanu
Jyotirmoy
Chando.
Pal to
Please,
pay-
Dr.
to offer the memento to Dr. Atanu
Dr.
Chandra,
Ananda
the
Bagchi.
real leader
To
of
Piyush Nandi
quiz.
Mandal.
Now Dr. Ananda Bagchi to our Piyush Mandal, another active person of the API from Maldives. So with these, there is the end of our scientific program for last 2 days. Probably you all have enjoyed a lot, but now we have come to the last session, that is valedictory session. So you may think that valedictory session is just for formality's sake. It is not that way, because from organizers' end, we are very much keen to hear comments, statement, your suggestions, whether it sounds good or bad from your end. I will call upon some of the PGTs to say their comment, how we can modify our program, our schedule, so that we can perform in a better way in our future. Any PGTs? Please keep silent for few minutes. Any comment from any PGT? We will have dinner, a short cultural program followed by dinner. So all of you are requested to sit back for a few minutes. Don't leave. There is a gala dinner. Please wait. After a very short period of gala cultural program. Please come. Atanu, Shoumitro, Partho, all come here. You all come. Ask them. Esona. So PGTs, any one of you, volunteer, come here. Feel free to say the way we can modify ourselves. Kaushik Karmakar from IPGMER. Your statement, please. One of the PGTs. Then I will call upon PGTs of RGKar. What is your opinion? Yeah, please come here. Hey, mic down, speaker down. Kaushik Karmakar. You are Kaushik Karmakar, yes.
Bolo,
what is your feelings?
What is your feelings and how to improve it, and why the PGTs are not participating? What's the reason? Better to be done. Bolo.
স্যার আমরা খুবই ভালো লেগেছে, আর এরকম একটা একাডেমিক এক্সট্রাভাগেন্সা যেখানে আমরা সমস্ত কিছু ওয়ার্ডের কাজকর্ম ছেড়ে তারপরে এখানে এসে এরকম একটা একাডেমিক সেশন, তার সাথে একটা কম্পিটিটিভ সেশন। আমি সব কুইজ পার্টিসিপেন্ট যারা ছিল আমাদের এই 6টা টিম প্লাস যে টিমগুলো এখন রয়েছে আগে যারা ছিল তাদের সবাইকে কংগ্রাচুলেট করতে চাই যে এরকম একটা নাইস প্রেজেন্টেশন। না স্যার আমরা খুবই ভালো লেগেছে কুইজিংটা।
না শুধু কুইজ না, তোমার কাছে সাজেশন জানা হচ্ছে কিভাবে আরো এটাকে অ্যাট্রাকটিভ করা যায় আমাদের প্রোগ্রামটাকে।
স্যার কিছু রাউন্ড হয়তো এক্সট্রা বাড়ানো যেতে পারে, বা ওভারঅল স্যার যেরকম হয়েছে আমার এক্সট্রা কিছু এখানে বলা নেই। খুবই ভালো লেগেছে এখানে এসে, আর এপিআই প্রতিটা প্রোগ্রামই আমরা খুব।
অনুষ্টুপ মুখার্জি ও কিছু বলবে, আমাদের পিজিটি, তাই তো? কোন কলেজ?
Sir, CNMC.
You introduce yourself.
This is Anushtup from CNMC. Good evening to all my dignitaries and senior professors over here. And the only thing that I can tell is that it has been an excellent 2 days of extravaganza. And as has been said by many of the dignitaries, many of the speakers, that it has been after 2 years that such a program is conducted offline. And as sir has mentioned that what can be the reason of PGTs of some less participation, that may be that everybody has taken the mindset has taken a backseat that everything can take is going on online. So I think if it is shared by us to our friends and to our colleagues that no, it is taking offline once again and we are meeting new people, and so if the propaganda is done by us, it is the responsibility on us to share it, so we'll have more success on it. Otherwise I don't think I am in a position to say anything about this because everything is so well prepared, well managed, and all the programs, all the seminars that were shown, they are of immense value to us. And I think this is all. Thank you.
Thank you, Anustup. Anyone from RGCAR, PGT, who has stood first in quiz competition? From junior teachers, many of them has appeared in the competitive sessions of rapid fire. Any one of you, please come forward. Sir, senior faculties, our respected senior persons are here. I can see Professor Baburam Hajra. Sir, do you have any suggestions to us for betterment in future? Oh, ওখানে একটু মাইকটা দাও না, ওখানে মাইকটা দাও না। আচ্ছা, রাইট। তা মাইকটা এখানে দাও, সিঁড়িতে উঠতে হবে না। ওখান থেকে বলুন স্যার।
অনেকদিন বাদে
ওইদিকে ঘুরে স্যার।
অনেকদিন বাদে
আচ্ছা,
অনেকদিন বাদে কনফারেন্সে এসে একটু ভালো লাগলো। প্রায় 2 বছর তো যেতে পারিনি। হ্যাঁ, 2 বছর পরে এই খালি ভার্চুয়াল কনফারেন্স আর এখন একটা অ্যাকচুয়াল কনফারেন্স হয়ে ভালো লাগলো। থিমস যে সাবজেক্ট গুলো চুজ করেছে এরা খুবই ভালো লেগেছে এবং বক্তৃতা যারা দিয়েছে তারা খুব আপডেটেড এবং আমরা খুব উপকৃত। এরকম আরো হোক।
আর কোন সিনিয়র পারসনস আছেন, কিছু বলবেন? তুমি রাখো, আরে সব লকটা লাগবে। সবচেয়ে বড় ব্যাপার যেটা অডিয়েন্সদের তরফ থেকে যারা 2 দিন পুরো ছিলেন, আমাদের টপিকস গুলো শুনেছেন, তাদের তরফ থেকে যদি কিছু বলার থাকে, প্রফেসর বাবুরাম হাজরা বলেছেন, আর কারো কিছু যদি বলার থাকে, যদি না থাকে আমরা এবারে আমাদের যে কম্পিটিটিভ সেশন গুলো হয়েছে সেখানে চলে যাব। তো আমাদের 3টে, হ্যাঁ বলো, এসো।
দুদিনের কনফারেন্স তো খুব ভালো হয়েছে, বাট যেটা আমার মনে হয় ইনকর্পোরেট করলে,
এখানে এসে ওইদিকে তাকিয়ে বলো, ফেস অডিয়েন্স, ফেস অডিয়েন্স।
দুদিনের কনফারেন্স তো খুব ভালো হয়েছে, বাট যেটা আমার মনে হয় যেটা ইনকর্পোরেট করলে আরো বেটার মনে হয় হবে, সেটা হচ্ছে যদি আমরা কোনো কিছু ওয়ার্কশপ টাইপের কিছু ইনকর্পোরেট করতে পারি আমাদের কনফারেন্সের মধ্যে, যেটাতে ডাইরেক্ট পিজিটিরা ইনভলভ হয়ে, মানে আগে ওয়ার্কশপ হয়েছে লাইক ইলেকট্রোলাইটস এইসবের উপরে, ফ্লুইড ইলেকট্রোলাইটস, এইগুলো যেগুলো মোর অফ পিজিটি লেভেলে, হ্যাঁ সেইগুলো করলে আমার মনে হয়
your suggestion is well taken, but this is the midterm update. We don't incorporate all those things. We will definitely, your suggestions will be taken care of, and we will definitely try to put some workshop in our annual conference. Okay.
Annual conference আমরা করি আর একটু করে নেব, আমরা আর একটু করে নেব।
Midterm update is a very short academic session. If there is no more opinion, may I get the permissions from our chairpersons to?
I think one more thing, we should, the sessions should be more interactive with the audience.
Yeah.
That is very important, because that if possible, that would be helpful. The interactive sessions.
Chairperson, sir? Is he here? Chairperson, sir? Kothay? Sir, with your kind permission, may we go for declarations of the result? If please come over here. Declaration of the result. So we had 3 sessions competitive. One is case presentations, another is our rapid fire sessions by junior faculties, and third is our quiz. So case presentations, there were altogether 4 cases, and this has been taken care of under guidance of our professor, Dr. Nandini Chatterjee. I will request her to come over here and to declare the result.
Congratulations to all who have participated in these competitive sessions in the midterm update of API West Bengal. The winner of the PGT case presentation is Dr. Shoubhik Sarkar from Medical College. The second prize is shared by Dr. Shelly Jain and Dr. Debrup Sengupta. Shelly Jain is from Arjikar and Debrup is from IPGMER.
Second, two persons got the second prizes.
First prize.
First,
First prize to Shoubhik Sarkar.
Shoubhik Sarkar. High round of applause, please. High round of applause. All prizes are cash prize, rupees 5,000. আমাদের ফটোগ্রাফাররা কোথায় গেল? All the best. For the second prize, two candidates.
The second prize, I call upon Dr. Shelly Jain and Dr. Debrup Sengupta.
Shelly Jain is here. Shelly
Dev.
Jain and
Debrup
Debrup.
Sengupta.
May I request anyone, if Shelly is absent, anyone from Arjikar? Would you please take Haritra?
Debrup Sengupta.
And on behalf of Shelly Jain, Haritra Ray will take the cash. 4,000 each for the second prize. On behalf of Shelly Jain.
Next, I'll be announcing the winners of the short lecture session by faculty. The first prize goes to Dr. Ankon Pathak from JNM Kollani.
Ankon Pathak, please. The cash prize of rupees 5,000. One day it will be 5 lakhs, but could be after 100 years.
Okay, the second prize goes to Dr. Parinita Ranjit from National Medical College.
Congratulations.
And the third prize goes to Dr. Shambho Shammazdar from School of Tropical Medicine.
Now coming to the last.
The other participants will be awarded prizes by our chairman, Professor H.S. Pathak.
All others who are there.
I call Dr. Bibha Bhagat, Dr. Oritra Kumar Ray, and Dr. Shoham Bhaumik.
Bibha Bhagat, Haritra Ray.
Shoham?
Consolation prize. Your
কি বলছেন? এগুলো অতনুকে
অতনু, 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 তোমার টিম নিয়ে এসো। Now coming to the last part of our prizes to our quiz team. So it has been well conducted by Dr. Atanu Chandra, Dr. Uddalak Chakraborty and Dr. Pijus Kanti Mandal. May I request all these three faculties to come over here to declare the result and offer the cash prizes of 6,000 to the first team, 4,500 to the second team, and 3,000 to the third team who stood third. So please declare the result. Result has already been declared. You please call upon the first.
Team Arjikar stood first. Team NRS Medical College stood second, and Team IPGMER 1 stood third.
Team Arjikar, please come.
Team Arjikar, please come up.
Don't make any more late, because everyone is very eager to take part in our cultural program. So 6,000 to Team Arjikar for standing first. Congratulations. Now,
Team NRS Medical College second.
congratulations.
And Team IPGMER 1 stood third. Congratulations again to them.
Congratulations.
Cash prize of
3,000.
cash prize of 3,000 rupees.
Congratulations. Nandini, আমারটা বাদ দিয়ে করবে না। আরেকটা তো। ম্যাডাম আমারটা। Now, thank you, and I request that our quiz masters and Dr. Pijus Kanti Mandal, Dr. Uddalak Chakraborty, and Dr. Atanu to stand over here. Felicitations of their very good work. We all enjoyed. Who didn't participate, but we all enjoyed. So, Dr. Shoikat Datto, please come. Dr. Udas Ghosh, please come. And Dr. Partho Sarkar. Three faculties will offer a small token of appreciation for their good work. Dr. Shoikat Datto to Dr. Uddalak Chakraborty, Dr. Udas Ghosh to our main quiz master, that is Dr. Atanu Chandra, and Dr. Partho Sarkar. He is offering a small token of memento on behalf of West Bengal API chapter, as a token of respect, love, and everything. Now, one very important thing. We are going to facilitate one very young faculty, very dynamic, very intelligent, and very tricky in all sorts of problems. I think you have guessed whose name I am going to declare. He is our youngest dean in all India, in ICP, the academic wing of API. A high round of applause, please. High round of applause, please. I request Dr. Jyotirmoy Paul to come over here. We want to felicitate. May I request our chairperson, sir, and secretary, sir, ICP, and chairman, sir. Both of them will felicitate this young, dynamic, very much energetic and intelligent dean, youngest dean. High round of applause, please. ফটো আমাকে পাঠিয়ে দেবে। হ্যাঁ, API গ্রুপ। আমি না না, কেন কেন বলুন, আছে মেমেন্টো আছে, মেমেন্টো আছে। না না, মেমেন্টো আছে। Now I am going to felicitate two very important persons. They are all the time work behind the curtain. So they are sometimes not being properly felicitated. So I request these two persons who are all the time, day and night, working behind the curtain. One is Dr. Kaushik Dhar. One is Dr. Kaushik Dhar, another, one is Mr. Kaushik Dhar, and another is Mr. Dilip Pal. Mr. Dilip Pal and Mr. Kaushik Dhar. They are working for last few weeks behind the curtain.
আমি শেষ ফেলিসিটেশন আমি ডিক্লেয়ার করছি। এই প্রোগ্রাম সাকসেস করার জন্য একজনের হাত আরেকজনের হৃদয় দুটো কাজ করেছে। সে হাত এবং হৃদয়কে আমি ফেলিসিটেট করতে চাই। তো হাত হচ্ছে ডক্টর পার্থ কর্মকার, আমি প্রফেসর মৃণাল রায় এবং প্রফেসর পার্থ সরকার এবং উদাস ঘোষকে হলো ফেলিসিটেট করতে। টু PS কর্মকার। আরে ওর পরে, আরে আমি যা করার করেছি, আরে এটা আমার ঘোষণা, আপনি ঢুকবেন না এর মধ্যে। ওই তো মেমেন্টো রেখে দিয়েছি তো দুটো, আরে দাও মেমেন্টোটা। দাদা এক এক করে, আগে পার্থ কর্মকারকে, আগে হাত, তারপরে হৃদয় যাবে। এবার আমি প্রফেসর পার্থ সরকারকে অনুরোধ করব, আমাদের হরিশঙ্কর পাঠক, মোস্ট ডাইনামিক চেয়ারম্যান এট দ্য এজ অফ 70।
Now, vote of thanks, the last part, but not the least. So, which is the must part of any conference. So, we have got 5 national luminaries, those who have come from different parts of India to Kolkata. Nandini Chatterjee, Madam, would you please come over here? She has already been felicitated, but once again, our chairperson, sir, wants to felicitate our Nandini Chatterjee, madam. Are you here? Please come over here while I am continuing with my vote of thanks. So our 5 national luminaries, Dr. Jayant Panda, Dr. Anupam Prakash, Dr. Sharma, that is Pradeep Sharma, Dr. B.D. Goswami, and Dr. Palaniappan. All has really made us a little bit wiser through their very good lectures. Now faculties and chairpersons of last 2 days, they have done and they have made justice to their topics. And I'm really thankful to all of them, national luminaries, as well as the speakers and chairpersons of the local region for spending their time over here for last 2 days. Now, all the EC members, I don't know why Dr. Jyotirmoy Paul felicitated me and our chairperson, but truly speaking, all the EC members worked hard to make it successful. So I am really thankful to all the EC members to be by our side to make this conference successful. I'm really thankful to all of you. Now coming to the office staff. So there are 2 types of office staff. One is those who are already working, that is Dilip Pal and Mr. Kaushik Dhar. They are working hard and they have already been felicitated. We are really thankful to both of them for working hard for last few weeks to make this conference smooth and successful. And another office staff who has worked for last few days and stayed 2 days by our side over here, those who are working in Swabhumi, and they have really helped us a lot in all sorts of problematic situations. They have helped us to tide over the crisis and to make the planning of our and the activities of our I will take another 5 minutes more, sir, please. So I am also very much thankful to the office staff of Swabhumi under the guidance of Mr. Shobik and Mr. Subrat Mishra. A high round of applause, please. And then coming to event manager, the Cubics team, the whole team under guidance of that lady, beautiful lady, that is Sanghamitra, and there is another beautiful lady smiling from there. And here they are all young chaps. They all have helped us a lot to make the conference successful. Now the pharma companies, without their help, we cannot hold any sort of conference anywhere, whether it is inside our medical colleges or outside. So I just read out the names of pharma companies whose contribution has really made us possible to make this program over here. So they are Juventus, Abbott, Zydus, Novo, Torrent, USV, Shine, Unique, that is JB Pharmaceuticals, Alembic, Eris, Sanofi, Alchem, and Sanotra. All these companies, because of their unconditional contribution, for their unconditional contribution, you have made us possible to make program over here. Thank you, all the pharmaceutical companies. Now, last but least, that is the audience. Without that matters most. Without their presence, without their interaction, no conference is successful. And last of all, I will definitely call upon our another very beautiful, active faculty. That is our Madam Professor Nandini Chatterjee. So she will be felicitated by our 2 doyen. One is Dr. Jyotirmoy Paul, another is Dr. Udas Ghosh. Please come over the dais. Dr. Jyotirmoy Paul and Dr. Udas Ghosh to felicitate our Madam Professor Nandini Chatterjee. Please come over here. So thank you very much. COVID is not yet out of the market, so please maintain safe health by wearing mask. COVID protocol is to be maintained. Thank you very much for your cooperation for last 2 days. Now I hand over the mic for our culture program to our Kaveri madam. Kaveri madam, please come over here and start the cultural program. Hey, মাঝখানে
replacement দেয় না এই করবো। And there is a drinks type. Oh, drinks not.
আচ্ছা, আমাদের এখানে এখন কালচারাল প্রোগ্রাম শুরু হবে, তার জন্য একটু স্টেজটা তৈরি করতে একটু সময় লাগবে, একটু প্লিজ আপনারা থাকবেন, 5 মিনিট সময় লাগবে, আপনারা একটু থাকবেন। এবং যেহেতু নতুন বছর এসে গেছে আর আমাদের সামনে কবিপক্ষ, তো আমরা রবীন্দ্রনাথের গান এবং কবিতা নিয়েই প্রথম শুরু হবে। আমাদের সঙ্গে যারা আছেন তাকে আমি ডাকছি, সুকুমার তাকে ডাকছি একটু, যদি একটু আপনি পুরো জিনিসটা একটু সিনাপসিস করে দিন। বিখ্যাত আবৃত্তি শিল্পী বলুন বা বাচিক শিল্পী সুকুমার ঘোষ, আপনারা অনেক সময় টিভিতে দেখে থাকবেন, উনি আমাদের এখানে উপস্থিত আছেন এবং পুরো ব্যাপারটা উনি সঞ্চালনা করবেন, পুরো প্রোগ্রামটা। আমি একটু ওনাকে ডেকে নিচ্ছি, উনি তাহলে একটু পুরো ব্যাপারটা কি কি জিনিস আমাদের হতে চলেছে সেটা একটুখানি বলে নেবেন।
আপনাদের সহযোগিতা বিশেষ করে এবং আমাদের এই মঞ্চ প্রস্তুতির জন্য আমাদের সহযোগিতা
काली गुप्ता नहीं करेगा बस, तो सब सुन लेंगे।
API with Windows chapter. API with Windows chapter. সম্মিলন হলো গতকাল তার সমাপ্তি হিসেবে আপনার এই সাংস্কৃতিক আপনারা সকলেই জানেন এবং অবশ্যই পশ্চিমবঙ্গের এই জায়গায় এই অনুষ্ঠান হওয়া উচিত। যেহেতু পয়লা বৈশাখ সত্যজিৎ এবং সামনে রবীন্দ্র জন্মোৎসব, সেটিকে মাথায় রেখে আজকে আমাদের নিবেদনে রবীন্দ্রনাথ গান ও কবিতার একটি মোটামুটি ভাবে এখনো পর্যন্ত আমরা যারা মঞ্চে আছি তাদের সঙ্গে আপনাদের পরিচয় করিয়ে দিই। আমার বাম দিকে কিবোর্ডে রয়েছেন দেবাশিস ভট্টাচার্য এবং মঞ্চের একদম ডান প্রান্তে আপনাদের বাম দিকে তবলায় রয়েছেন অঞ্জন বন্দ্যোপাধ্যায়। আজকের এই অনুষ্ঠানের মূল পরিকল্পনা এবং ভাবনা তিনি শ্রীমতী কাবেরী ঘোষ রয়েছেন মঞ্চে, রয়েছেন আমার ডান দিকে ডক্টর শর্মিষ্ঠা বন্দ্যোপাধ্যায়। এছাড়াও যারা অনুষ্ঠান করবেন তাদের নাম আগে বলে দিয়ে তারপর আমি উদ্বোধনী অনুষ্ঠানে যেতে পারবো। এছাড়াও যারা অনুষ্ঠানে অংশ নিতে পারেন তারা কাকলি কর্মকার, ডক্টর মধুচন্দ্রা কর এবং ডক্টর দীপঞ্জন বন্দ্যোপাধ্যায়। এখন অনুষ্ঠান শুরু হচ্ছে উদ্বোধনী সঙ্গীতের মাধ্যমে। উদ্বোধনী সঙ্গীত পরিবেশন করছেন সহেলী ভট্টাচার্য। সহেলী ভট্টাচার্যের কণ্ঠে আমরা দুটি রবীন্দ্র সঙ্গীত সহেলী ভট্টাচার্য।
Oh নমস্কার, আমার পরবর্তী নিবেদন সখী ভাবনা কাহারে বলে। সখী ভাবনা কাহারে বলে, সখী চেতনা কাহারে বলে, তোমরা জীবন দিবস রজনী ভালোবাসা ভালোবাসা, সখী ভালোবাসা কারে বলি যাত না আমার চোখে সকলে সকলে রবে সকলে বিমান শুনিলা বিষাদ ছড়া কুসুম হাসিতে হাসিতে ঝরে জোছনা হাসিয়া বিদায় যায়, হাসিতে হাসিতে আলোক সাগরে আকাশের তারা দিয়া সুখীকে আছে আর সখী আর কাছে সকলে মিলিয়া গাহিব মোরার ভাবনা কাহারে বলে, সখী যতনা কাহারে বলে, দিবস রজনী ভালোবাসা ভালোবাসা, সখী ভালোবাসা কারে থ্যাংক ইউ।
সহেলী ভট্টাচার্যের কণ্ঠে আমরা গান শুনলাম। এরপর আমাদের যে মূল অনুষ্ঠান রবীন্দ্রসঙ্গীত এবং কবিতার মেলবন্ধনে একটি নির্বাচিত কিছু গান আপনাদের সামনে পরিবেশন করব, সেটি আমরা শুরু করছি। প্রথমে সঙ্গীত পরিবেশন করবেন একই সঙ্গে, যদিও প্রথম গানটি অবশ্যই করছেন এই অনুষ্ঠানের পরিকল্পনা যান শ্রীমতী কাবেরী ঘোষ, এবং তারপরে আরেকজন শিল্পী আমাদের সঙ্গে রয়েছেন ডক্টর শর্মিষ্ঠা বন্দ্যোপাধ্যায়। আর আমাদের সহযোগী শিল্পীদের সঙ্গে আপনাদের পরিচয় করিয়ে দিয়েছি। আমি সুকুমার ঘোষ। শুরু করছি আমাদের অনুষ্ঠান।
কবি পক্ষে কবির প্রতি শ্রদ্ধাঞ্জলি নিবেদন করছি একটা পূজা পর্যায়ে গান দিয়ে। একটু ভয়েসটা বাড়বে একটু বাড়ি। প্রথম লাইন আজি বিজয় ঘরে নিশীথ রাগে
তুমি এসেছিলে আজ প্রাতে, অরুণ বরণ পারিজাত লয়ে হাতে, নিভৃত করে পথিক ছিল না পথে, একা চলে গেলে তোমার সোনার রথে। বারিক থামিয়া মোর বাতায়ন পানে, চেয়েছিলে তব করুণ নয়ন পাতে। সুন্দর তুমি এসেছিলে আজ প্রাতে, স্বপন আমার ভরেছিল কোন গন্ধে, ঘরের আধার কেঁপেছিল কি আনন্দে। ধুলায় লুটানো নীরব আমার বিনা, বেজে উঠেছিল অনাহত কি আঘাতে। কতবার আমি ভেবেছিলুম উঠি উঠি অলস ত্যাজিয়া পথে বাহিরাই ছুটি। উঠিল যখন তখন গিয়েছ চলে, দেখা বুঝিয়া হলো না তোমার সাথে। সুন্দর তুমি এসেছিলে আজ প্রাতে। এই কথাটি সদাই মনে বলতে যেন পাই। আর যা কিছু বাসনাতে ঘুরে বেড়াই দিনে রাতে, মিথ্যা সেসব মিথ্যা, ওগো তোমায় আমি চাই। রাত্রি যেমন লুকিয়ে রাখে আলোর প্রার্থনায়, তেমনি গভীর মোহের মাঝে তোমায় আমি চাই। শান্তির ঝড় যখন হানি, শান্তি তবু চাই সে প্রাণে, তেমনি তোমায় আঘাত করি, তবু তোমায় চাই, চাই গো তোমারই চাই, তোমায় আমি চাই।
ভালোবেসে সখী